The Committee on Health, Hospitals, and Human Services is now on the record. I'd like to say a pleasant good morning to my esteemed colleagues, invited testifiers, central staff, the viewing and listening audience. Today, the committee will address the healthcare crisis in the Virgin Islands. And February is Black History Month. And for this month, we'd like to give special congratulations to our own local hero, Dr. Alfred O. Heath. Dr. Alfred Heath's contributions to the Virgin Islands spans decades of dedicated service in medicine, military leadership, public health administration. He's a distinguished surgeon and former commissioner of health. Dr. Heath played a pivotal role in advancing healthcare services, serving as a director of Seaview Nursing and Rehabilitation Facility, chief of surgery at the North Hansen Memorial Hospital, director of emergency medical services. His leadership extended beyond medicine. He also served as chairman of the Board of Trustees at the University of the Virgin Islands, and he rose to the rank of Brigadier General in the Virgin Islands Army National Guard. Numerous other awards, certifications, and honors, including the Virgin Islands Medal of Honor. Dr. Heath's lifelong commitment to improving healthcare and public service has left an indelible mark in the territory. And of course, he's still with us, and he made 95 years young back in November. Well, Sapopa. February is American Heart Awareness Month. It's a vital time to raise awareness about heart disease, which is the leading cause of death in the United States and a significant health concern in the Virgin Islands. Cardiovascular disease accounts for nearly 1 in 3 deaths in our community, with high rates of hypertension, obesity, and diabetes. As you know, in our community, there's over 12,000 persons, either full-blown diabetics or pre-diabetics in our community. So about 14% of our population, which is very high. This month serves as a reminder of the importance of heart-healthy lifestyles, including proper nutrition, regular exercise, and routine health screenings to detect and manage risk factors early. By prioritizing prevention, education, and access to quality health care, we can work together to reduce the impact of heart disease and ensure a healthier future for all Virgin Islanders. Let's take this time to empower ourselves and our loved ones to protect our hearts and live longer, healthier lives. Approximately 500 Virgin Islanders receive a new cancer diagnosis every year. At a minimum, our new modernized Charlotte Kindelman Cancer Center, which I'm told will be completed by the end of 2025, must be fully staffed, and proper staffing is a critical need. Running a successful cancer center requires a diverse team of specialized healthcare professional and support staff. And we're going to get into those details in this hearing on health, hospitals, and human services. Mr. Clerk, roll call.
Good morning. Senator Herbert L. Fredericks. Senator Fredericks, present. Senator Marvin A. Blyden.
Present.
Senator Blyden, present. Senator Ray Fonseca.
I'm here.
Senator Fonseca, present. Senator Alma Francis Heiliger. Senator Heiliger, absent. Senator Kenneth L. Gittins.
Here.
Senator Gittins, present. Senator Milton E. Potter. Senator Potter.
Here. Here.
Senator Potter, present. Senator Court A. Vele. Senator Vele, absent. Mr. Chairman, 5 present, 2 absent.
Thank you, Mr. Clerk. We do have a quorum and we will proceed. Mr. Clerk, any correspondence to be read into the record?
Yes, Mr. Chairman.
Please proceed.
February 21st, 2025, the Honorable Ray Fonseca, Senator, 36th Legislature of the Virgin Islands, Capitol Building, Charlotte Amalie St. Thomas, U.S. Virgin Islands, 00802. Non-payment to GRS by Roy Lesser Schneider Hospital. Dear Honorable Senator Fonseca, my name is Denise Phipps. I am a retiree from the Roy Lesser Schneider Hospital, where I worked for over 33 years as a registered nurse and as the Director of Case Management and Social Services. On November 30th, 2024, I officially retired from the Roy Lesser Schneider Regional Medical Center. However, I have not yet received my retirement compensation or the 184 hours of annual leave I am owed. Although these funds was deducted directly from my biweekly payments, they were never paid into the Government Employee Retirement System, GERS, on my behalf. It is my understanding that until these payments are made, I will not be able to be paid. Moreover, this will be for another 6 months to a year before it can be rectified. This issue has been a significant hardship for both me and my family. As a retiree, I am compelled to pay $540 for insurance fees and massage services, which have forced me to forego all other services that would have been covered by my retirement funds. Having served in this community diligently as a public servant for 33 years, I am respectfully requesting your assistance in resolving this matter. Cordially, Denise Phipps, employee number 61913. That concludes the correspondence, Mr. Chairman.
Thank you, Mr. Clerk. Colleagues, what we're going to do is we're going to merge Block 1 and 1-2, and then we will have one testimony because there's certain departments that appear in both blocks. So we'll proceed with merging Block 1 and 2. So at this time, we're going to do a mic check. Yes, Senator Francis. Oh, yes, I have to recognize non-committee member Senator Francis. So strange, you know, he's always been a member of the committee, and the last time I assume he's still a member, but welcome, Senator Francis. Also, Senator Maurice James. Welcome, Senator Maurice James. Mark, Senator Maurice James as present. Okay, so we'll do a mic check. We're going to start with Commissioner Human Services, Averil George, and then we'll go to the
don't forget to have a...
Good morning, Averil George, Commissioner of the Department of Human Services.
Darlene Baptiste.
Pleasant good morning, Darlene Baptiste, CEO, Juan F. Louis Hospital and Medical Center.
Good morning, Christopher Finch, Board Member, Virgin Islands Government Hospitals and Health Facilities Corporation.
Good morning, Tasha Phillips Dorset, Assistant Commissioner, Department of Human Services.
Good morning, Gary Smith, Medicaid Director, Department of Human Services.
Morning, and I'd like to also recognize non-committee member, Senator Averil Lewis. Welcome. Okay, St. Thomas. We'll go to St. Thomas for. Oh, I'm sorry. Yes, continue.
Alvin Milligan,
Good morning, Alvin Milligan, Administrator of Senior Citizens Affairs, Department of Human Services.
Good morning, Akila O'Brien, Disaster Recovery Specialist, DHS.
Okay, thank you. And then I know we have one testifier in St. Thomas, but I don't see him in the well at this time. So, Mr. Clerk, can you please read the agenda into the record?
Yes, Mr. Chairman. Committee on Health, Hospital and Human Services, the Honorable Ray Fonseca, Chairman. Please be advised that the Committee on Health, Hospital and Human Services will be conducting a hearing on Tuesday, February 25, 2025 at 10 p.m. in the Fritz E. Lawette's Legislative Conference Room on St. Croix. Block 1, the committee will receive testimony regarding the strategic plan to address staffing shortages and the reduction of emergency room wait times at both hospitals. Also, the members will be presented with an overview on the territory's MAP program and the border crisis in the Governor Juan F. Louis Hospital and Regional Medical Center and the Schneider Regional Medical Center. Invited testifiers, the Honorable Averil E. George, Commissioner, Department of Human Services, Ms. Tina M. Commissiong, Esquire, MPA, Chief Executive Officer, Schneider Regional Medical Center, Ms. Hazel Philbert, Chief Operating Officer, the Governor Juan F. Louis Hospital and Regional Center, Ms. Darlene Baptiste, Chief Executive Officer, Governor Juan F. Louis Hospital and Regional Medical Center, Mr. Christopher Finch, former Chairman, Virgin Islands Government Health and Hospital Corporation, Mr. Edgar Phillips, resident St. Thomas, U.S. Virgin Islands. The members will receive an overview on the designs, including final completion target dates of the Herbert Grigg Nursing Home, Queen Louise Home for the Aged, Governor Juan F. Louis Hospital and Medical Center, Schneider Regional Medical Center, Myra Keaton Smith Community Health Center, and the Department of Human Services Complex and St. Thomas. Invited testifiers, the Honorable Averil E. George, Commissioner, Department of Human Services, Mr. Christopher Finch, former Chairman, Virgin Islands Government Health and Hospital Corporation, Mr. Darrell Smalls, Executive Director, Facilities and Capital Development, Territorial Hospital Redevelopment Team, and Mr. Jerry Smith, Chairman, Virgin Islands Government Health and Hospital Corporation. That concludes the reading, Mr. Chairman.
Thank you, Mr. Clerk. I'd like to also recognize through Teams, Tina Commissiong. Can we do a mic check?
A pleasant good morning to all. Good morning, Honorable Fonseca.
Okay, good morning. Okay, so at this time, we'll proceed with the testimony from Commissioner of Human Services, Averil George.
Good morning, Honorable Chairman Senator Ray Fonseca, members of the Committee on Health, Hospitals, and Human Services, distinguished colleagues, the viewing and listening audience. My name is Averil E. George, and I'm honored to serve as the Commissioner of the Virgin Islands Department of Human Services. Joining me today are key members of my leadership team who play a vital role in advancing the department's mission. Assistant Commissioner Tasha Phillips Dorset, Akila O'Brien, DHS Disaster Recovery Specialist, Alvin Milligan, Administrator of Senior Citizens Affairs, Gary Smith, Director of the Office of Medicaid. Additionally, Deputy Commissioner of Operations St. Thomas, Sean Georges, and Deputy Commissioner of Operations St. Croix, Hugh Nicholas, will both be present outside of the well to support this discussion. We are here today to discuss several critical issues that directly impact the Department of Human Services and, more importantly, the well-being of the residents we serve. My testimony will focus on key areas that require immediate attention and strategic action, including the ongoing hospital border crisis and its strain on both the healthcare and human services infrastructure, updates on the Medicaid assistance program amid federal funding uncertainties, and the progress of major infrastructure projects such as the relocation and reconstruction efforts for the Queen Louise Home for the Aged, the redevelopment of the Herbert Grigg Nursing Home, and the modernization of the new Hansen complex. These efforts reflect our continued commitment to improving service delivery, expanding access to care, and ensuring that our facilities and programs are equipped to meet the needs of our most vulnerable populations. Addressing the border crisis and the impact on healthcare and human services, the Virgin Islands has been significantly affected by the broader border crisis, which has placed unprecedented pressure on our hospitals, long-term care facilities, and social services. Both the Juan F. Hospital and the Royal Schneider Hospital have seen an increase in boarders, patients who have been discharged but remain hospitalized due to the lack of appropriate post-hospitalization placements. On average, between 7 and 10 individuals are classified as boarders at any given time. These individuals no longer meet the criteria for acute medical care, but cannot safely be discharged back into the community. Some may have family in the territory, but those relatives are either unable or unwilling to provide the intensive support services or discharge care required. As a result, they remain in hospital beds, driving up costs and limiting bed availability for those in need of urgent medical attention. This crisis is compounded by the territory's shortage of long-term care options. The Virgin Islands desperately needs additional nursing home beds for frail elderly residents, assisted living residential facilities for seniors who require some support with daily activities, independent senior living communities to accommodate aging residents who need affordable housing with access to support services, and adult daycare drop-off services. DHS maintains waiting lists for individuals of need of nursing home care and assisted living, but the availability of placements is extremely limited. Currently, Queen Louise Home has a capacity of 17, and Herbert Grigg Home accommodates 26 residents. To alleviate this strain, DHS is actively pursuing long-term solutions, including the construction of 2 new CMS-certified nursing facilities, one at Herbert Grigg Home on St. Croix, and another to replace the existing Queen Louise Home on St. Thomas. However, these projects will not be completed until early 2028, leaving an immediate gap in care. One potential solution would be to increase Herbert Grigg Home's capacity by accepting 11 additional residents. However, this expansion would require hiring 13 additional staff members, including registered nurses, licensed practical nurses, certified nursing assistants, institutional support staff, and dietary personnel. The estimated cost for this expansion would be approximately an additional $1.2 million annually and is broken down through the following. Staffing, salary plus fringe, is $746,094. Supplies to include medical, food, and operating costs is $378,125. Other services, repairs, maintenance, security, transportation is $90,640. Alternatively, relocating individuals to skilled nursing facilities outside the territories could also be considered, though costs range from $72,000 to $108,000 per person per year. This option is already being utilized in specific cases where specialized long-term care is unavailable within the Virgin Islands. Currently, DHS have 5 clients placed at the Casa de Salud facility in Puerto Rico, where our contract allows for a maximum of 7 clients. Additionally, 10 DHS Medicaid clients are currently residing at Pines Nursing Home in Miami, Florida, receiving the skilled nursing care necessary for their conditions. While these off-island placements provide a short-term solution, they highlight the urgent need for expanded skilled nursing capacity within the Virgin Islands. The planned long-term CMS-certified nursing facility at Herbert Grigg and the redevelopment of Queen Louise Home for the Aged represent crucial investments in long-term care services, ensuring that more of our residents can receive the care they need without the financial and emotional burden of relocation. DHS remains committed to working with local hospitals, Medicaid providers, and long-term care stakeholders to develop sustainable in-territory solutions, while continuing to utilize off-island placements when absolutely necessary to ensure the highest quality of care for those who require it. Medicaid program updates and strategic developments. Medicaid is the primary source of health care coverage for thousands of Virgin Islands, providing essential medical services for low-income residents, individuals with disabilities, and seniors. These services are available for children and adults who meet CMS eligibility participation requirements. The program plays a critical role in funding hospitals, community health centers, and long-term care services across the territory. While the 83% federal medical assistant percentage, FMAP, is now permanently established, the overall future of Medicaid funding remains uncertain as Congress continues to debate allocations for the territories. At the same time, the 17% local share continues to be an ongoing general fund expenditure, ensuring that Medicaid services remain available and properly supported within the Virgin Islands. As of December 29, 2024, Medicaid enrollment in the Virgin Islands stands at 21,071 members, a decline of 3,334 members from January 2024. This drop is largely attributed to the unwinding of public health emergency, the PHE provisions, which had temporarily expanded Medicaid eligibility during the COVID-19 pandemic. The reduction in membership raises concerns about individuals losing coverage, highlighting the urgent need for improved outreach, streamlined eligibility processing, and continued federal support to ensure continuity of care. Beyond Medicaid, there is a serious need for additional individual and family health insurance coverage options to be made available in the Virgin Islands to ensure residents have access to essential health care services. Key Medicaid program metrics. Total Medicaid enrollment as of December 2024, as stated before, is 21,071 members. Federal medical assistance percentage, FMAP, 83%, permanently established by the Consolidated Appropriations Act of 2023. Total Medicaid providers enrolled is 1,447. Personal care attendant, the PCA program, Medicaid members serve 75. Claim processes 1,372 total claims. Total amount paid is $1,658,159.30. The total PCA providers are 6. Medicaid funding and provider payments for year-to-date 2024. MAP is a lifeline for hospitals, federally qualified health centers, and other providers, ensuring that Medicaid recipients continue to receive quality care. The following payments were dispersed in FY 2024. Frederiksted Healthcare Inc., $6,321,446.99. Governor Juan F. Hospital, $8,641,446.80. Schneider Regional Medical Center, $13,914,093. St. Thomas Eastern Medical Center, $2,357,010.83. These funds are critical to sustaining healthcare infrastructure in the territory, allowing hospitals and clinics to continue offering services to Medicaid beneficiaries. It is important to note that providers have a full 12 months after services are rendered to submit their invoices for payment consideration in accordance with CMS guidelines. This allows providers time to reconcile claims, ensure compliance, and avoid unnecessary payment denials, further reinforcing Medicaid's role in maintaining access to essential healthcare services. Presumptive eligibility enrollment decline. Presumptive eligibility PE allows individuals in urgent medical need to receive temporary Medicaid coverage while their full application is processed. However, there has been a sharp decline in PE enrollments, raising concerns about barriers to timely healthcare access. These barriers appear to stem from both provider-level challenges, such as administrative delays, limited staff training, and stricter internal screening at hospitals and FQHCs, as well as individual-level challenges, including lack of awareness about PE, difficulty providing required documentation, and confusion over Medicaid eligibility due to recent policy change. To illustrate the extent of this decline, the following data highlights the significant drop in PE enrollments across key healthcare providers. Frederiksted Healthcare, Inc. went from 29 to 14. Governor Juan F. Hospital went from 459 to 164. Schneider Regional Medical Center went from 354 to 103. And St. Thomas Eastern Medical Center went from 7 to 0. This decline means that fewer individuals are receiving immediate Medicaid coverage, which could lead to delayed medical treatment for those in need, higher uncompensated care costs for hospitals and clinics, worsening healthcare outcomes due to gaps in coverage, Medicaid challenges and funding uncertainty. While the permanent 83% FMAP provides critical financial relief, Medicaid's long-term sustainability in the territory is still at risk due to potential federal funding reductions. The territory does not have the fiscal capacity to replace lost federal funding, and any reduction in Medicaid appropriation could result in the following: cuts to Medicaid benefits or eligibility restrictions impacting thousands of vulnerable residents, delays or reduction in payments to hospitals and healthcare providers, putting financial strain on the system, and further declines in provider participation, reducing healthcare access across the territory. Additionally, workforce shortages, delayed provider reimbursements, and local match funding constraints continue to pose challenges to the Medicaid program's efficiency. As of February 2025, there are 1,699 pending Medicaid applications, and only 306 out of 2,005 PHE renewal applications have been processed, underscoring the administrative burdens that must be addressed. Strategic priorities for Medicaid sustainability. To strengthen Medicaid's long-term viability, DHS has focused on the following strategies: protecting federal Medicaid funding for the territories, advocating for stable, long-term Medicaid funding appropriations from Congress, engaging with federal partners to ensure the territories prioritize in funding decisions. 2, improving enrollment and eligibility processing, addressing the backlog of 1,699 pending applications to prevent coverage gaps, enhancing presumptive eligibility outreach to ensure timely access to Medicaid for those in need. 3, expanding Medicaid provider networks, recruiting additional personal care attendants, PCAs, to improve access to home-based care, strengthening partnership with federally qualified health care centers to increase primary care availability. 4, ensuring timely provider payments, streamlining reimbursement processes to avoid payment delays, and supporting hospital and healthcare facilities to maintain financial stability. As DHS continues to navigate these uncertainties, we urge the 36th legislature to remain engaged in federal discussions, advocate for funding protections, and work collaboratively to ensure that Medicaid remains as stable as possible despite the challenges ahead. The reality is that if Congress reduces Medicaid funding for the territories, the impact on healthcare in the Virgin Islands will be severe. While we are committed to doing everything in our power to protect these services, we must also prepare for a future in which Medicaid may not be able to sustain its current role. The stakes could not be higher, and we stand ready to work with our federal and local partners to ensure that the people of the Virgin Islands do not bear the brunt of policy decisions made far beyond our shores. In regards to Queen Louise Home relocation and reconstruction, the Queen Louise Home for the Aged is undergoing a significant rehabilitation effort, necessitating a temporary relocation of residents to the Palms Court Haverview Hotel while construction is underway. This initiative is essential to ensuring the long-term safety, comfort, and well-being of our senior residents. The project has been carefully planned with clear timelines, funding milestones, and logistical coordination to minimize disruption and maintain a high standard of care. Project development and key funding milestones. The development of the Queen Louise Home relocation and repair plan is set to conclude by April 27, 2025, following a comprehensive 553-day timeline from inception to execution. This project is critical to ensuring the long-term stability and functionality of the facility, addressing both structural improvements and necessary upgrades to enhance the quality of care for residents. Despite ongoing logistical and funding challenges, we remain confident that the project is progressing as planned. As of today, we have achieved 36% completion with key milestones in infrastructure assessment, permitting, and preliminary construction already underway. FEMA public assistance PA funding for temporary repairs has been fully secured, enabling the commencement of critical repairs as planned. The FEMA PA amendment for temporary relocation was successfully submitted and approved by October 3, 2024, ensuring financial support for the temporary transition of residents. The CDBG DR Community Development Block Grant Disaster Recovery 5% match was initiated on March 29, 2024, and final components are currently being processed to complete the funding package. These key milestones ensure that both short-term relocation needs and long-term rehabilitation efforts are adequately resourced. The strategic alignment of funding sources allow for efficient execution without undue financial strain on local government resources. Project implementation progress. The Queen Louise Home Rehabilitation Project is structured into well-defined phases, each with a clear set of objectives and completion targets. Designing and planning phase, successfully completed by October 2, 2023, which included a comprehensive hazardous material hazmat assessment of the Queen Louise Home to identify environmental risk and ensure compliance with safety regulations. Federal consistency review. This critical regulatory process has begun on January 16, 2024. A final determination was issued on May 30, 2024. Key steps, including the submission of the FCR package to DHS and the Department of Planning and Natural Resources, are progressing efficiently. Temporary relocation supply agreement initiated on March 11, 2024, with the initial site visit already completed. While some components are still in progress, proactive measures are being taken to address outstanding requirements. The strategic execution of these steps ensure that relocation logistics, regulatory compliance, and facility readiness aligns with the broader project timeline, preventing delays and optimizing the transition process for residents. Construction and relocation timeline. Renovations at Queen Louise Home are scheduled to continue through early 2026, with construction beginning in April 2025 and a target completion date of February 15, 2026. A detailed project management plan is in place to ensure efficiency, accountability, and minimal disruption for our residents. Relocation preparation and execution. To ensure seamless continuity of care, the temporary relocation to Palms Court Harborview Hotel has been meticulously planned. Palm Court Harborview Hotel renovations are proceeding on schedule, including installation of an emergency generator to provide uninterrupted power supply, upgrading telecommunications and security systems to ensure seamless operation, enhancement to living accommodations to meet ADA and senior care residents. The transition of residents to the temporary location is planned for March 31st, 2025, with their final return to the fully rehabilitated Queen Louise Home on February 17, 2026. The Palms Court Harborview facility will provide private and semi-private accommodations to maintain residents' dignity and comfort, a secure residential wing to ensure safety and well-being, a dedicated socialization area for family visits and recreational activities, an on-site dining facility and dietary support services, around-the-clock staffing to maintain quality care standards, separate telephone/internet availability so that loved ones can communicate with their families. DHS has taken proactive measures to address staffing needs, ensuring that residents receive the same high-quality care at Palms Court as they would at Queen Louise Home. Additional personnel will be deployed during the transition period, and regular family engagement will be facilitated to support residents emotionally during the move. Ensuring long-term stability for elderly care services, the Queen Louise project is not just about physical renovations. It represents a broader commitment to improving long-term care infrastructure in the Virgin Islands. This initiative is part of a larger strategic effort to modernize facilities, expand capacity, and create a sustainable model for elderly care. With the planned long-term CMS-certified nursing facility set to replace the existing Queen Louise Home, this transition period provides an opportunity to refine care protocols, improve operational efficiency, and lay the foundation for a stronger, more resilient long-term care system. DHS appreciates the continued support of the legislature, the Office of Disaster Recovery, FEMA, HUD, and other key stakeholders in securing resources, addressing challenges, and ensuring that our elderly residents receive the highest standard of care. We remain committed to transparency, efficiency, and excellence in executing the critical project. Herbert Grigg Nursing Home Design Overview and Project Timeline. The Herbert Grigg Nursing Home serves as a critical long-term care facility on St. Croix, providing 24-hour skilled nursing care, rehabilitation services, and residential support for the elderly and disabled population. Given the facility's aging infrastructure and damage sustained from past hurricanes, DHS is advancing a full-scale redevelopment project to improve the capacity, safety, and quality of care at the Herbert Grigg campus. The redevelopment of the Herbert Grigg Home for the Aged campus is currently in finalization of the A&E design, pending task order approval. Once finalized, the project will move into detailed design and construction planning to support the delivery of modernized, high-quality elder care services. Key design features the new CMS-certified long-term care nursing facility to accommodate increasing demand for long-term care services, hurricane-resilient infrastructure, including storm-proof roofing, impact-resistant windows, and reinforced structures, upgraded medical and therapy wings, including rehabilitation spaces, medical consultation rooms, and modernized patient suites, specialized memory care unit for dementia and Alzheimer's patients, ADA-compliant accessibility features to enhance mobility and safety for residents. The department is fully committed to ensuring the timely completion of this much-needed facility and is actively working to expedite every phase of the project, from finalizing architectural and engineering designs to approvals and coordinating with contractors. The Herbert Grigg Home for the Aged redevelopment is a critical investment in the future of long-term care on St. Croix, ensuring that the facility meets modern standards for safety, resilience, and quality elder care. Nude Hansen Complex, St. Thomas Human Services Complex, permanent and temporary facilities. The Nude Hansen Complex is undergoing a major redevelopment initiative to ensure the continuity and enhancement of essential DHS services while a state-of-the-art hurricane-resilient facility is constructed. This transformation is critical to strengthening human services infrastructure in the U.S. Virgin Islands, ensuring long-term sustainability, accessibility, and emergency preparedness for the residents of St. Thomas. The permanent redevelopment of the Nude Hansen Complex is being led by Springline as the selected contractor, with A&E design currently in development as part of the Rebuild USVI projects. This project is a joint effort between DHS and the Department of Health and also involves FEMA, the Office of Disaster Recovery, the Virgin Islands Housing Finance Authority, the Department of Property and Procurement, the Department of Public Works, and other key stakeholders to ensure compliance, efficiency, and successful implementation to ensure that the facility serves multiple public health and human services functions. The final scope of work is pending submission, which is required before construction can begin. The project will be submitted for bids as a design-build package on March 3, 2025, bundled with the Queen Louise Home for the Aged. The new, larger, and more modern Nude Hansen Complex will serve as DHS headquarters, housing all central administrative offices and essential human services programs, with DOH also located next door on the proposed campus. St. Thomas residents will have easier access to both public health and social service programs in a single, efficient location. For years, DHS employees and the public have worked in a building that was outdated and extremely difficult to maintain. The new Nude Hansen Complex will provide modern workspaces with upgraded technology and improved layouts to support staff efficiency, along with better air quality and ventilation for a healthier environment. The facility will also be ADA compliant with wider walkways and step-free entrances to improve accessibility for all. With DHS and DOH housed in one location, residents will have easier access to services like Medicaid, SNAP, TANF, Head Start, and other services. Built to withstand natural disasters, the new complex will also feature improved security control entry points and expanded parking to create a safer and more functional space for both employees and the public. While the permanent facility is under construction, DHS is securing temporary office space to maintain operations. Tutu Park Mark via building. DHS will submit a scope of work amendment and cost alignment request to fund the build-out of office space and telecommunications infrastructure. DHS is also awaiting final lease approval from the Department of Property and Procurement, with proof of funding already submitted. Havenside, the old chicken and bowling alley. This facility will replace the 2 Lockhart Gardens location. Finally, final FEMA approval is expected following the environmental and historic preservation review. These temporary arrangements ensure DHS services remain uninterrupted while the permanent Nude Hansen Complex is constructed. In conclusion, honorable senators, we are at a pivotal moment in the transformation of healthcare and human services in the Virgin Islands. The road ahead is complex, shaped by challenges of funding uncertainties, workforce shortages, and infrastructure demands. Yet, despite these obstacles, our commitment remains steadfast to strengthen the systems that serve our most vulnerable residents and to build a foundation for long-term sustainable progress. While we are actively working with our federal partners to secure the necessary resources, the unpredictability of these policy changes create a ripple effect, one that impacts not only the Department of Human Services, but the providers, families, and individuals who rely on these services daily. It is imperative that we remain vigilant, adaptable, and unified in advocating for stable and equitable funding that meets the needs of our community. The department's broader human service initiatives require a coordinated approach that blends immediate action with long-term planning. We are making strategic investments in infrastructure, staffing, and service delivery models that will strengthen our capacity to meet growing demands. However, we cannot do this alone. The collaboration between DHS, the legislature, and other stakeholders is essential in ensuring that we not only address current needs, but also anticipate and prepare for the challenges ahead. With your partnership and continued support, we are confident that we can navigate this period of uncertainty with strength and clarity. Thank you for your time, your leadership, and your dedication to the well-being of our community. We will await any questions at appropriate time. Thank you.
Thank you for your testimony, Commissioner Averil George, and we are definitely here to help you. We know that the Department of Human Services has a lot of issues, but I know that that's an A team. Human Services is definitely an A team. And thank you for your testimony. I'd like to recognize the presence of committee member, the Honorable Senator Kurt A. Vele. Welcome, Senator Vele. Mr. Clerk, is there any correspondence to be read into the record?
Yes, Mr. Chairman.
Please proceed.
February the 25th, 2025, Honorable Ray Fonseca, 36th Legislature, Chairman on the Committee on Health, Hospital, and Human Services. Greetings, Senator Fonseca. Please note for the record, I will be tardy to the Committee on Health, Hospital, and Human Services scheduled for 10 a.m. on Tuesday, February 25th, 2025 in the Fritz E. Lawetz Legislative Conference Room due to a previously scheduled appointment. I will arrive as soon as possible. Thank you for your understanding. Regards, Senator Alma Francis Heiliger, Senator, 36th Legislature, Member, Committee on Health, Hospital, and Human Services.
Thank you, Mr. Clerk.
Mr. Chairman, that brings the roll to 6 present, 1 excuse.
Thank you, Mr. Clerk. Point of information, Vice Chair Senator Frederick.
Good morning, presenters. Good morning, colleagues, central staff, watching and viewing audience. Commissioner George, I wanted to ask you a question in reference to this cooperation between the legislature and your department. Which particular facility or do you currently have that's CMS certified or even close to being CMS certified?
We currently have no facilities that are currently CMS certified, Senator.
And the reason why I ask this is because in light of the challenges that you pointed out in your testimony, I totally agree that we need to come up with creative ways of passing the difficulties that we face together. However, if your facilities are CMS certified, what's the impact on your financial bottom line?
Repeat that question, Senator.
If these facilities are CMS certified, what would the financial impact be? In terms of the revenues, if they were, what would your revenue projection look like?
Yeah. Good morning, Gary Smith, Medicaid Director. I don't have the details of who are Medicare and Medicaid eligible at the facility, but the impact would definitely be beneficial because we'd be able to bill Medicare and Medicaid if the facility was CMS certified.
Okay, if you would, can you please provide the chair this information? Because if there's something you could do within your department to help your situation, like, becomes CMS certified, that's less money we'd have to find for you on our end. So clearly, let's try to see what the federal government has, what we could do to maximize that. I know some of it will be staff in situations that we could help with, but the key here is to provide the highest level of care to our residents, and that's what we're trying to do.
And Senator Frederick, just for your information, the new facilities that we're rebuilding and getting back up in speed with Queen Louise are gonna be CMS certified. And it's gonna be tricky to give you the revenues based on our residents that's currently in the facility, because based on your income level, you could either qualify for Medicaid or you can't qualify for Medicaid. So for us to sit here and say we can give you a number of revenues we're gonna get, is based on our input and output of our residents on a regular basis.
Thank you very much, Commissioner.
Thank you, Senator Frederick. Point of information, Senator Norville Francis, proceed.
Thank you very much, Mr. Chair. Good morning to you, my colleagues, and good morning to the testifiers. Just real quickly, Commissioner, I have a quick question for you in regards to your testimony where you spoke about an immediate potential solution to the situation over at Herbert Grigg. And in it, you talk about this $1.2 million infusion that will be required to get that up and running in the immediate. Obviously, you have plans to expand Herbert Grigg. That takes us out to 2028, 3 to 5 years out. But I wanted to ask you about the $10 million appropriation that was made in the 35th legislature, the last session, where there was some recommendations of providing $10 million to Herbert Grigg, as well as $10 million to Queen Louise and St. Thomas through the Epstein Fund, cash that was readily available to support the expansion of Herbert Grigg Home. Were you involved in the discussion that in regards to the availability of that funding? Obviously, the governor had vetoed this particular measure. I wanted to ask you whether or not you were involved in any discussion in respect to being able to utilize this money for immediate infusion into the Herbert Grigg Home.
Good morning, Senators. Tasha Phillips Dorset, Assistant Commissioner at DHS. In terms of the bill that was sent up for review, DHS and other agencies commented on the bill and sent those comments to the Office of the Governor. DHS stands in support of it. Pretty much any measure that will give us additional funding to rehabilitate the homes that FEMA will not cover with the prudent replacements. But we do understand that we have ceilings that are attributed to our yearly budgets from this body, and we have to operate within those ceilings.
Well, I'm speaking specifically, Mr. Chair, if I may continue along that line. I'm speaking specifically to the $10 million or the $20 million that was provided, 10 for St. Thomas and $10 million of immediate infusion of cash that will be made available for the Herbert Grigg build-out.
Correct, Senator, but it was vetoed. So the only input we initially put in was in the original bill draft review and the comments.
Okay. Again, well, thank you for your response, and I know that that's what you were saying, but however, there's a level of urgency that's required in this territory. And obviously, if we have $10 million available to us, I don't see what the logic will be for us to veto this. It's unfortunate that we didn't have the opportunity to override and make that money available, but I think that on recommendations, the governor usually utilizes recommendations from the various agencies and make it a determination whether or not these measures should go forward or be vetoed. But I will continue to say I believe that there was a mistake made in not taking advantage of that immediate infusion of cash that could have addressed this border situation that we're experiencing, the waiting list and everything else, where there was an immediate availability of $10 million to be able to expand the Herbert Grigg Home. All right, so thank you for your response. I'll query additional on my time. Thank you, Mr. Chair.
Thank you, Senator Francis. The Committee on Health, Hospitals, and Human Services will stand in recess for 1 minute. Committee on Health, Hospitals, and Human Services is back on the record. Colleagues, we're going to do a 7-minute round of questioning with the Department of Human Services. Senator Frederick will be first, followed by Senator Marvin Blyden, Senator Gittins, Senator Avery Lewis, Senator Norval Francis, Senator Maurice James, Senator Milton Potter, and Senator Kurt Valey. Okay, so, you know, human services, it's a lot that we have to cover. The Medicaid program, right? I wanted to ask on the state plan. The state plan. Right now, the income, and correct me if I'm wrong, the single is like 15,400 and double is 21,000 something. What are the numbers?
So for a single, sorry, Gary Smith, Medicaid Director. For a single adult, it's $15,654 annually is the income threshold for a single adult. Additional household members is approximately $5,400 per additional household.
So that's about, for a single person, basically if you're making about $350 a week, you don't qualify for the Medicaid program.
That's correct.
For a family of two, if you're making about $410 a week, you don't qualify.
Yes, Senator.
Okay, and right now, with those requirements, we have about 21,000 persons on the roll that do qualify.
Yes, Senator, as of December 31st, 2024.
Okay, good. Senator Herbert Frederick, you're recognized for your 7 minutes.
Thank you, Mr. Chair. Good morning again. I wanted to revisit a site visit that we did about a week and a half ago for the Herbert Grigg home on St. Croix. My colleagues and I, a few chief of staff, attended that visit, that site visit. And I want to thank you, Commissioner and Assistant Commissioner Dorsett, for the opportunity for us to come out there. There were some issues that we saw. By the way, it smelled great. I used to be a Medicaid auditor for the state of Georgia for many years, and hospitals and nursing homes was my specialty, and I could tell you, Herbert Grigg smelled great. I don't know what they're cleaning it with, but it doesn't have that weird foul smell that you have when you go into a lot of nursing homes. So, you know, kudos on that. And I was surprised the facility wasn't bad. You know, there were the little items that we talked about. Where are we in terms of the items that we talked about that should have been addressed? And were they addressed?
Good morning, Senator Tasha Phillips Dorsett, Assistant Commissioner, DHS. Our contractors did begin the roof repairs yesterday, and we had some water because it rained last night, so we had some water damage that they're cleaning up right now, and the contractors were on site from this morning. In terms of, there was one item I know that you asked about, and that was some cookies that were expired. They were thrown out of the pantry. We were very grateful there were no expired vegetables or meat or any other type of products like that there. And we're just going to continue to address line by line issues as they crop up. I think we still have challenges with our staffing. As you heard from our staff, our staffing levels are low, and we have staff working overtime to fill the gaps. We still have an issue with the back door that leads into the kitchen. We need to have some repairs done there, and we can't use federal funds to fill that gap. So that's one of the deficits that we still have to work through. Thank you.
I think we had a vehicle that was down. Did you get access to the vehicle?
The vehicle is being repaired, and we also in the process of purchasing another vehicle for Herbert Grigg home at this time.
Awesome. So right now, where we are, I am comfortable with what I saw. I heard the complaints from the staff about staff and pay. That is a real deal, something we will have to address. I understand the disparity between the pay of the nurses between the hospital and human services. What are we going to do to gap that? I know there are different unions. What can we do to help with that?
Averil, George, Commissioner, they're unionized, so it's union negotiations for wage increases. There's nothing DHS can do on the back end to assist that process, so we're just going to wait till union negotiations and go through the process. They're union employees.
But I think they were complaining more about their scheduling, Commissioner. Of course, they pay as well, but they were complaining about this scheduling being really taxing on them. And, you know, that's they started complaining about their pay. So if we could do something to at least try to hire some more nursing staff, then they wouldn't have to work these exorbitant hours.
And that is in progress, Senator, for us to restructure and bring on additional staff into all facilities.
Good. The next area that I was a little concerned about, which I know we talked about it earlier when I asked for a point of clarification. Is there a sprinkler system at all at Herbert Grigg? Do we have a sprinkler system? Okay. And
Currently, there's not.
There's not. So CMS requires that, right? And so, yeah, there's no way we'll be able to get that. But the new construction, we're going to be able to get that. Okay, great. So that's all my questions. Thank you very much.
Thank you, Senator Frederick. Commissioner, I want to go to page 2 of your testimony. DHS maintains waiting lists for individuals in need of nursing home care. What's the waiting list for St. Croix and what's the waiting list for St. Thomas, St. John? You have those numbers?
You're talking about getting inside of the Herbert Grigg home?
Herbert Grigg waiting list and Queen Louise waiting list.
Alvin Milligan, Administrator. Right now we have a wait list about 6 on St. Croix, and I think it's about 3 or 4 on St. Thomas. That doesn't include the border situation, because what we've been trying to do is to take some from the hospital as well and take from the community, because we do have some people that were waiting quite some time. So we're trying to solidify both, but as you know, with the border situation, as you get 5, then it goes back up to 10. So that's the issue. So, it might be more, but I'm thinking about those that have already started the process, because it's an application process. So that's what we have on board.
Well, Sir Popa, you know, them numbers sound real low to me. And it would seem like once you started the application process, that is someone on the waiting list. 6 persons on St. Croix, okay, and 3 persons on St. Thomas. So the borders now is how many in the Wang Louis, and the borders is how many in the Roy Schneider Hospital? See, you see what I want to. Go ahead, Ms. Dorset.
This is Tasha Dorset, Assistant Commissioner. I can answer on the border question. As of last week, we had for RLS, it was 8 total, with 2 that we were trying to send to Casa de Salud, and Wang Louis was 11 total, with 1 to be placed in Herbert Grigg and 2 to be retrieved by their family members. This is as of last Friday when we got an overview.
Okay, so
No,
if you...
I'm sorry, those numbers are not correct for sure.
If you add the 27 now that you have residents of Herbert Grigg, plus the additional 11 borders, you come up with 38. If you add the 6 that you're saying is on the waiting list, let's round it up to 10. It shows that you need 48 units on St. Croix, 48. But yet and still, you're only constructing 38. So right away, you have a 10 deficit. And on St. Thomas, how much, if you have, how much is the borders? 8 and 17, 20, 28. So you would need, right now you're saying St. Thomas have only 3. I can't believe those numbers. I'm going to request.
We should check those numbers.
Yeah, I'm going to, I can't believe it. I'm going to request through the chair that you send me those, the waiting list for St. Thomas, including the boarders and the residents, the waiting list for St. Croix, including the boarders and the residents. I need to verify that.
And Senator Fonseca, Commissioner George, I want you to keep in mind that it's not all boarders at the hospital will be qualified to go into
Yes,
the
I understand.
facilities. There's an age restriction, and there's other factors that we have to take in consideration for them to meet the requirement to be in a facility. So saying they have 15 boarders, or how many boarders, it does not necessarily mean that all boarders can meet the requirements to get into either Queen Louise or Herbert Grigg facility.
Okay, yes, understood. And send that to me. Correction?
Tina Commissiong is online. She has a clarification.
Yes,
Point of information.
Director Commissiong, Tina
A pleasant good
Commissiong.
morning
Point of
to all.
information.
I want to provide the correct numbers for Schneider Regional. We have 13 boarders currently in inpatient status, all that are appropriate for nursing home care, such as Herbert Grigg. We have 2 additional patients that may become boarders that are currently being boarded in the emergency department, bringing our number to 15. So that's the correct number for Schneider. Thanks.
Okay, so you see what's happening. There's a meeting for
Point of
these
information.
boarders that goes on constantly, and the numbers here are different. So that means that when you meet,
Point
you
of
have to
information.
agree on the numbers. Yes. Point of
Point
information.
of information.
Yes. Senator Gittins, you're recognized for your point of information.
Thank you. 2 things. Can you have the testifiers online to all mute their mics when they're not identified to speak, and when they come up to speak, please ask them to turn on their cameras. Thank you.
Tina, you heard that? Mute the mics, everyone. When you, sorry, Director Tina Commissiong. CEO. We the hang out on the baseball field. I got to remember we on the official record. Okay, so Senator Marvin Blyden, you're recognized for your 7 minutes.
Thank you so much, Mr. Chair. I was also trying to get a point of information, but that's okay. Good morning, Mr. Chair. Good morning to my colleagues, the listening and viewing audiences, staff, central staff, and good morning, testifiers, and thank you so much for your testimonies. Commissioner George, I really want to thank you for this testimony. Very informational and on point. You gave a lot of good information. You have a lot of work to do. You and your team. You have a lot of work to do. Your department is responsible for our people from birth until they die. And I really, really commend you guys for the job you do. It's a humongous job. Let me ask you, though, in respect to the testimony, you spoke to the critical role in funding the hospitals, right? And you stated there's an 83% federal medical assistance program, the FMAP, for the territory. What does that 83 represent in dollars and cents? How much funding did you receive as a result of that?
Gary Smith, Medicaid Director. So the 83% FMAP requires a 17% local match. That's for regular claims.
Understood.
The federal dollars that goes along with that for fiscal year 25 is $139,450,000.
That's what I'm talking about. That $139 million plays such an important role for our people in the territory. So let me ask you, though, your key Medicaid program matrix, right? You spoke to, but you know what, let me leave that alone. Let me go down to the Medicaid funding and provider payments for 2024, right? The Frederickson Healthcare Clinic, Inc. received $6,321,000. Juan F. Louis, $8,641,000. Schneider Regional Center, $13,914,000, and St. Thomas East End, $2,357,000, right? But let me ask you in respect to the PM, presumptive eligibility enrollment decline. We have seen a decline in the territory, right? That's on the CMS. We have seen a decline, a drastic decline, right? And it was spoke on page 4 of the testimony, spoke to challenges that you're facing, including a lack of awareness about the PE program, difficulty providing required documentation, and confusion over Medicaid eligibility due to recent policy change. With the recent policy change, did they send guidelines with those changes to assist the department?
Gary Smith, Medicaid Director. So, the confusion was for the past, prior to June 2023, CMS allowed us to provide automatic extensions subsequent to the 2 Category 5 storms in 2017. Then you had COVID-19 hit. So we began unwinding in June of 2023, or the recertification process, meaning all members had to recertify by submitting all documentation to remain eligible on the program.
Okay, Director Smith, again, no. My question was, did they send guidelines with those required changes, with the changes?
Yes, yes, we did numerous media, radio shows, social media, print media, commercials.
Okay, my concerns are, for instance, you gave a chart. Fredericksburg Health Clinic, they have been a decline from 29 to 14. Juan F. from 459 to 164. Schneider Regional Center, 354 to 103. St. John's, 7 to 0. That's a problem. How are we dealing with this situation? Because that's a major, major, major blow to our people and the health care. What are we doing to make those numbers level off in terms of the amount of individuals? Because it's a drastic, drastic decline. What are we doing in that respect?
Okay, so the presumptive eligibility is different from full Medicaid eligibility. We perform trainings with the hospital facilities, with the FQHCs on an annual basis. We perform, I believe, 4 trainings in 2024, and prior to that, 2023, I believe 3 to 4 trainings as well with the facilities.
Why I said that, though, because as a result of that, with fewer individuals, it basically creates delayed medical treatment for those in need, higher uncompensated care for the hospitals and clinics that we are speaking of today, and worsening healthcare outcomes due to gaps in coverage. So, is there anything else that can be done in that space to reverse or assist in this decline again?
So, Senator, I would say we just need to continue to communications with the facilities in assisting them, because the presumptive eligibility is the sole responsibility of the facilities. Medicaid can only provide support. So, we are available and open to respond to any questions, policy changes. All policy changes are definitely shared when received. So, as a matter of fact, during the COVID-19, we increased the opportunity for 2 opportunities to enroll in presumptive eligibility for 12 months versus 1, which was originally in the state plan. We amended the state plan during the COVID-19 emergency to allow 2 times to enroll in presumptive eligibility. So after the COVID-19 ended, it went back to 1 per 12 months.
Okay, very well. I know my time is running out, but let me ask before my time runs out. The temporary relocation of the
Biden, you have 18 seconds left.
Proceed, Senator.
Okay, I wanted to speak to Queen Louise Home for the aged and the temporary relocation of the residents to Palm Court, Harborview, and other temporary facilities. I believe you have the old Via building, and also you have the old Chicken and Bowling building in Havenside. The Chicken and Bowling building in Havenside, I'm just a little concerned about parking there in that area. Are there additional parking in that area for staff, etc.? Briefly.
Commissioner Averil, George, we are going to be getting additional parking in the back based on construction that is being done, so we don't foresee any parking issues at all at the facility. And the individuals that's going to that facility is our divisions that are not really has a lot of customer traffic, more HR or fiscal that's going to be at that facility, because we kind of split it up to make sure that the community has easy access to our via location by transportation, safari, or anything. So it's a split in the divisions between the two locations.
I see that, and it makes sense, and I appreciate your creative thinking. That makes a lot of sense, and I do agree with that. And I wish the chair would have showed the renderings to the community, because it's going to be a beautiful, beautiful space for our seniors, and a space that the employees also deserve to work in and operate from. And in closing, because I haven't heard my time, let me speak to senior living facility. We talked about senior daycares. We talked about other facilities for seniors, right? And the number that was given, 43 territory-wide between St. Thomas and St. Croix, I think that the waiting list, I don't think that number is correct either. I really don't think that number is accurate. But at the same time, let me ask Commissioner George, in respect to senior living facilities, nursing home in particular, and I know years ago when I used to manage Lucina Miller Home for the Aged, from the housing space, we had Department of Human Services actually running a facility with the nurses that were available and the other staff. What is there opportunities to have those type of partnership redeveloped in order to assist with the shortage of nursing homes facility here in the territory, and or PP3s? Is there opportunities moving forward for those type of facilities?
There's also opportunity for those kind of facilities, Senator, with the funding that is provided. At this time, we're working within our funding requirements and seeing what we can do best to curtail those shortfalls to see how we can assist the community better.
Well, again, thank you for your testimony and what you do, and thank you for your responses. Mr. Chair, thank you so much for the time. Thank you.
Thank you, Senator Blyden. Point of information, Senator Kurtville.
Thank you, Mr. Chair. Good morning to the people of the Virgin Islands. Good morning, St. Croix. Mr. Smith, I heard the previous line of questioning, and for some reason you didn't say anything about the pandemic protections under the CARE Act as to why so many people were dropped from the Medicaid roll. So you need to put that on the record. It wasn't just that the Virgin Islands decided to take people off the roll. It was literally mandated as an expiration of the pandemic protection under the CARES Act, and those individuals had to then reapply. So a lot of the ability for them to qualify literally expired. And I think that needs to be on the record, so it's not a belief that the Virgin Islands just dropped a bunch of people from Medicaid. Thank you so much, Mr. Chair.
Thank you, Senator.
Yeah, go ahead.
Bailey, proceed. You going to answer?
Yeah, thanks for that, Senator Bailey. So you're absolutely correct. Under the CARES Act, it was determined that, redeterminations had to begin.
Correct.
So a lot of people were receiving, as I mentioned, automatic extensions. So when they recertified, they became income ineligible. Folks fell off because of procedural reasons. You have the issue of churn. What that means is folks have the benefits when they need it, it expires, and they don't come back until they need it again. So there are a lot of different components and aspects as to why we have so many people that fell off of the rolls, but it's mainly because of they're no longer eligible.
Okay, question. The cost report. I want to discuss the cost report. So the cost report can lead to money being returned to the Virgin Islands, right? Is that correct?
Yes, Senator.
Okay, so say money is being returned based on the cost report. Does that money go back to the Medicaid program, or it goes to OMB, to the budget director, and then the government decide how it's going to be allocated? Tell me how that goes.
So the last iterations, the funds were returned to the government of the Virgin Islands, and the government of the Virgin Islands determined how those funds were used. Medicaid did not receive.
Okay.
Human Services received a couple $100,000. I mean, I'd have to go back and check for the exact numbers, but it was in tune of about $35 to $38 million that was returned.
Wait. Let me just get this clear. You're saying that based on the cost report, about $35 million of Medicaid fund was returned, and only a few $100,000 eventually came back to Human Services?
That's what I recall. And if I may, the cost report is an annual reconciliation performed to determine the cost of services provided by our public facilities versus what Medicaid paid.
Okay. Point of information, Senator Kurt Ville.
Thank you, Mr. Chair. In reference to the cost report, the government of the Virgin Islands don't make the decision as to how the money is spent. The legislature makes a decision. So we have to pass a bill to reappropriate those monies. And the reason why the bulk of the money went to the other institutions is because it's JFL and Fredericton Health Center and Schneider and East End. They are the entity that's billing. So the money went back to them because they are the billable entity, not Human Services. Human Services just providing the match, the 17% match, through the government of the Virgin Islands. If they are running clinics with Department of Health, then those clinics will also be eligible for a portion. But the bulk of the money goes back to those who are generating the money, and that was the decision of the legislature and not the GVI. The GVI can't do it. They can't touch the money. If they touch it, it's illegal. We have to appropriate it.
Okay, that's what I was figuring. I didn't think the budget director had that authority. But okay, good clarification. Senator Avery Lewis, you're recognized for your 7 minutes.
Thank you. Good morning. Good morning, colleagues. Good morning, testifiers. Good morning, Virgin Islands. Ms. Commissioner George, it was stated a couple of weeks ago we had a meeting with the hospitals CEOs, and they both concurred that it takes roughly about $1,400 per day to take care of a border. And both of them in a ballpark of about $6 million annually to house the borders at the different facilities, whether it's JFL or Schneider Regional Medical Center. When you renovate these new facilities and able to accept any of these, are we able to accommodate this new expense?
Commissioner Averil, George, Senator Lewis, with all borders common expense. Currently, we looked at the patient financial situation, whether they get Social Security, whether they get retirement to assist with their care, whether they qualify for Medicaid to assist with their care. So every patient that comes in to our facility, we review their financial situation and see what burden they're going to be to the government of the Virgin Islands. But it requires intense digging to see what funding they have available that can assist with taking care of them once they come into the facility. But we really try to make sure that the funding is available to offset our costs in regards to staffing, meals, and any main operational cost that is feasible.
And that brings me to my next question here. As we talked about the Herbert Grigg Center and even the Queen Louise, right now, currently, do you have adequate staff there for the patients that you currently have?
We're in the process of bringing on additional staff. We do have staff shortages, and individuals has been working overtime to assist in the care of these individuals. So to sit here and say I currently have adequate staff for the participants or the residents we have, no. We're making do with what we have to make sure that our patients are adequately cared for.
Do you have any vacancies currently at these facilities?
Yes, we're in the process of posting all our vacancies. We have reposted and posted nurses needed for these facilities through the DOP website as well as media outlets, and our response has been very low. So we have reposted them, and we're in the process of adding more vacancies to this listing.
All right, how many vacancies do you have total currently have?
I'll have to get that number for you, and I'll update you on before the end
All
of
right.
this hearing.
Good. On page 4 of your testimony this morning, we talked about presumptive eligibility, and there was you said there has been a sharp decline in presumptive eligibility enrollments, and one of them you stated administrative delays, limited staff trainings, stricter internal screenings at hospitals. So this is just a current trend. I mean, anything else to attribute to this that you would like to expound on?
Gary Smith, Medicaid Director. As stated before, Senator Lewis, folks falling off, they were just not eligible. But as far as the presumptive eligibility, that's a self-attestation process, and the responsibility of offering the presumptive eligibility is for the facilities that the uninsured persons present
3
to.
minutes.
Okay. Commissioner, you commend you for you and the team actually, for really championing the cause to move out of that current location you have here up in Hospital Ground, the old Hansen building. I was just there up to this morning. I really see where the staff and yourself could use a new home. But I have some other questions for you. As it pertains to moving to the Tutu Park Mall and the Haven site, there was in your testimony that you do have federal monies to relocate and pay the rent at these facilities, right?
Akila O'Brien, Disaster Recovery Specialist. Yes, we do.
So what is the cost for would be at Tutu Park Mall?
The yearly cost? What do you mean? So there's going to be 2 phases for, you said Haven site?
Tutu Park.
For Tutu Park? Tutu Park right now we have, for Tutu Park we currently have about $1.9 million for the relocation. That's going to be funded by FEMA.
And what would the cost be for rent per month?
I can get that number and I'll get it back to you.
No, the cost for rent at Haven site. Okay, while you're getting those numbers, Commissioner, in your testimony, you talked about relocating at the Palms Court Harbor View. I think that was a great choice. Have we ever explored options of probably even purchasing that building on our own? I know you won't tell me money is strapped, but have you ever thought about it since we're there now and we're going to retrofit it and so forth? Have there been an option? I know that building has been for sale for quite some time.
Based on funding, we don't have the, Commissioner George, based on funding, we don't have the funding to obtain that building. We are only using one particular wing at Palms Court to have a view for our residents at Queen Louise Home, and we're doing some maintenance and getting it up to speed. But to say that we can purchase that entire facility at this time based on funding constraints, I'll say no.
All right, there may be something that this body and you could get together to look into. I think that would be a great
Senator, 30 seconds.
facility.
Can Senate AC Dorset has something to add?
Good morning, Tasha Phillips Dorset. Senator Lewis, please recall that we are going to be building a new nursing home on a different piece of property on the island of St. Thomas, and we will be using our FEMA rebuild dollars for that. That's what the commissioner mentioned earlier, that it won't be ready until 2028.
Okay. So now that you went down that road, this is going to be a new assistive living center as well. You're going to encompass that?
DHS is not responsible for assisted living centers. We're responsible for nursing homes. You might be talking about Housing Finance Authority.
These nursing homes going to have in rehab centers and maybe recreational centers, because I see in here you have elderly people as well.
That is the goal, especially since we're trying to get the new nursing homes. Anything that we build, we want it to be CMS certified. And so those socio-recreational supports and occupational therapy, physical therapy, those are the supportive services that we would like to offer on site with the rebuild.
All right, Mr. Chair, just one last question so I can wrap up.
Yes, wrap up.
Commissioner, you said your Queen Louise home package is in the next bundling, which should be going out next week, Monday, possibly.
Akila O'Brien, Disaster Recovery Specialist, that's correct.
All righty, thank you, Mr. Chairman.
Senator Fonseca, before you move on, can
Yes,
I
go
update
ahead.
the team in regards to the completed application for Queen Louise Home? We have 4 completed applications for Queen Louise Home and 18 applications that are not completed for Herbert Grigg. There are four applications completed as well, and 21 applications not completed for individuals on the waiting list for Herbert Grigg.
Okay, thank you, Commissioner. Now, those numbers sound like the real numbers. Thank you for that update. Commissioner, I wanted to quickly, with the borders, right? The home-based health care and the personal care services, do you think those are areas that can potentially reduce the borders issue in the hospital?
The family has to want to take them first, and we don't do home-based care. We have homemakers that goes out on a particular time period to assist, but we don't do home-based care, and the families have to want to take them. And if there are borders at the hospital, means the family want them.
Yeah, that's unfortunately that's a reality in the community.
And Senator, some of them requires more than home-based care. Some of them requires intensive care.
Okay, so based on that, right? Because you're saying that you're projecting 38 units for the new Herbert Grigg home, right? You added the 11. No. You had the 27 plus 11. That brings it 38.
It's 44 beds, Senator Fonseca,
44.
not 38.
Okay. So 27 beds plus 15 additional.
Akila O'Brien, Disaster Recovery Specialist. It's hard to specify a number because it is based on what our budget allows. So for right now, we can say 44, but as we go into the A&E design and space programming, that number may change, it may increase or it may decrease because it's all based on the budget and how far it can stretch.
Okay, and see, that's my question, because originally it was my understanding the rebuild of Herbert Grigg was for 60 units. Is that correct?
That was our initial ask for 60 beds.
So why did you originally ask for 60 beds then?
That's what we felt we couldn't, to meet the needs for the community. We wanted 60 beds for both, for Queen Louise and Herbert Grigg. But then as we started going into the design and the budget, that number started to decrease.
Well, you see, I think the opposite of that. You have to build it to fill your need. And if you had 60 need before, and our community is an aging community, it would seem like your need is not going to decrease. So, you know, the main thing is that we want to build a facility that can accommodate the need. And that's very important. Okay, Senator Gittins, yes, you may respond.
Tasia Phillips Dorset, Assistant Commissioner. To address the full long-term care need in the territory, it's not going to be just GVI government alone. We are also going to have to partner with private facilities out there. And I know at least on St. Croix, there is one, I believe it's Rain Dance LLC. They're planning to build a multi-bed skilled nursing facility as well. Theirs may even be ready before ours is rebuilt. Sorry.
I think that's your mic.
Sorry.
Yes, you may proceed.
Excuse me. So with that, it's going to be sort of a jigsaw puzzle. Private partnerships and public partnerships to fill the gap in the territory. So that's going to be a real aid for us. I'm confident that we'll have enough bed capacity between some of these different ventures.
Okay, thank you very much. Senator Gittins, you're recognized for your 7 minutes.
Thank you, and good morning to all. Let me just roll back here a second to one of the last responses from Commissioner George regarding the borders at the hospitals and the possibility that some families are not wanting to come back for their loved ones. When this happened, is there any investigations taking place to determine whether or not these families are collecting public assistance funding or even retirement funding on behalf of these patients?
Commissioner George, Senator Giddens, you'll have to ask the hospital that when they come up. We only go that deep when they become, if we're getting guardianship of those individuals through the court to become guardians of DHS. We don't have access to their financials.
Have there been any inquiry to your agency to this extent?
You go ahead.
Good morning.
Go ahead.
Morning, Tasha Phillips Dorset, Assistant Commissioner, DHS. Every Friday, DHS does meet with the hospitals and Department of Health to review the borders and to plan strategically for their placement. I could tell you just 2 weeks ago, we were meeting on a patient in one of the hospitals, which their child just dropped them off to the hospital and they refused to come and pick the individual up. It went so far as to they had a hospital bed in their home and they threw the hospital bed away because they felt that their parent was not going to live and come back into the home. In cases like that, our caseworkers have to work with the caseworkers at the hospital and more than likely make either a adult protective services case, which eventually may go to the Department of Justice. So we have to look at these cases on an individual case-by-case basis and then make the determinations of what's best for the patient.
So, okay, my question is still not answered. My thing is, back in 2013 or 2014, there was an inquiry done. And from the legislature, I assisted them. I said, you know, we're going to have to go back and do this. Now, it took, of course, collaboration between Department of Justice, the hospital, and Human Services. But the border list was so long, and we had to determine whether or not the individuals were on public assistance. There were a couple. And immediately, when they addressed those families and threatened to either take away that public assistance or even charge them with neglect, the numbers went down significantly. So I am simply asking whether or not, based on the border population currently, have the hospitals reached out to the Department of Human Services to make a determination of any of the two areas that I asked, whether or not they're collecting public assistance funding or retirement funding on behalf of these borders.
Yeah. Commissioner George, conversations are continuing, Senator. A recommendation was made that if we have borders at the hospital and they're there over a certain amount of time, that we petition the court, give the family a certain amount of time to pick up their family member, and if they don't, then we petition the court for them to be guardians of DHS and for us to be able to check their finances. But the conversations are happening and the review is being done on a patient case-by-case basis. And this is where APS, Adult Protective Services, come into play if we feel that we have to intervene.
Okay, we'll have a sidebar conversation. I don't think that we're being aggressive enough on this. Let me ask you, what's your thoughts on Queen Louise and Herbert Grigg homes are nursing facilities that should be under medical facilities. What are your thoughts of them falling under the care of one of our healthcare institutions, whether the Department of Health or the hospitals? Because they should have clinical managers overseeing these as nursing homes. These aren't assisted living homes, but rather nursing homes, correct?
You're correct.
Don't you think it would be beneficial for them to be under one of those umbrellas?
No, I don't.
And why not? Can you, I think you made, are any of these homes CMS certified?
The ones that we're rebuilding will be CMS certified, Senator, as stated before.
Any of them CMS certified at this time?
No, they're not.
So what
It's a
would it
work in
take to
progress.
make, what would it take to make our nursing homes CMS certified?
They have to be remodeled. They're just too old. They need to be refurbished and they need to be brought up to the requirements of CMS, and it requires funding. And this is a conversation we can have at
What about the skill? What about the skill set of clinical people actually running the institution?
Senator, all that comes with a package of the rebuild and the restructuring of the
30
facilities that
seconds.
isn't planned.
The director of Medicaid, I think, why does the Medicaid state plan not allow for hospitals to bill for professional services?
Could you repeat that question, Senator Gittins, please?
Let me restate it in a different way. Does your state plan allow for the hospitals to bill for professional services?
Gary Smith, Medicaid Director. Providers can bill for professional services once they are not a full-time staff employee of the hospital.
So your the doctors at the hospital, how many in the ER specifically? I think the CEO for St. Thomas at least is on. How many are full-time?
Would you like me to address that question, Senator Gittins? Good morning.
Say that again?
Would you like to respond? I don't know if that question was directed to me or towards Medicaid.
Yes, I guess you.
We have a complement. We call for 5 physicians in our emergency department. We currently have 3 permanent staff and 2 rotating on a regular basis. We were up to 5 full-time complement. 1 passed away last year, and the other one has since resigned their position.
I just wanted to, the state plan, regarding the state plan, does it allow for the hospitals to bill for professional services?
No. We get a daily rate from Medicaid. We can't do professional billing for the physician services, which is a challenge. And we also cannot bill for the borders to the Medicaid program. It's not a part of the plan.
All right. And to my question to the Commissioner of DHS, asking you, have you all done any thorough investigations to determine, let me ask you first, how many borders do you have on St. Thomas?
We have 13 borders that are in inpatient status, many for a long, long time. And we have 2 borders that are in the emergency room that don't have any place to be sent right now.
So, and these are senior folks, elderly people?
Yes, senior persons who require...
Slow down. I want to just take this directly. Have your team reached out to DHS to determine whether or not any of these folks are collecting, their families that is, that refuse to come and get them, are collecting any public assistance or retirement funding? Do they have an income coming in?
Yes, sir, we have. We have, of the 13 boarders identified, 7 of them have some level of benefits that they receive. What we do is the social worker, in working with the family, will call and has worked with the human service, with the programs that provide that funding, and have that stopped if the family is not taking care of the one who is the recipient of those funds. The way it's set up right now, there's no way for the hospital to just start to manage those funds without becoming like the guarantor and then paying all of their other bills.
Well, of course you can't.
We could put legislation forward that says if they're receiving a benefit, the hospital needs to be paid first.
So this is why human services need to be involved. So let's make sure that we're communicating with that agency. And lastly, because I'm not sure if time was called, but lastly, I just want to ask.
Yes.
Okay, can I just ask?
Yes.
One question to that. Are any of the current boarders at your hospital undocumented?
Yes, we have 2 that are undocumented.
And you've okay, offline I will further discuss that. We don't have anyone from Wang Louis on, Mr. Chair, correct, at this time?
No, they're going to give testimony next, after Human Services.
3 minutes.
Thank you.
Thank you, Senator Gittins. Commissioner, real quickly, with the ID program for the elderly, why do the elderly folks' ID expire after 5 years?
Still good morning. Afternoon? Yeah, afternoon.
Yes.
Senator Fonseca, Alvin Milligan, Administrator. The reason being because it's an official ID, and if in fact it doesn't have an expiration date, they would not be able to use it at the banks or any institution. Now the airlines are also allowing them to use it as an official ID as well. As you know, in comparison to our voters registration card, that's not an official ID because it doesn't have an expiration date. Also, we do this because we've had some shady characters. 5 years might be, you might think it's insensitive to the seniors, but we have persons who have died within that 5 years, and people still trying to use the cards to do other stuff. So that's a way of us to do a wellness check as well. So that's the reason why it has to have an expiration date to be an official ID.
Okay, thanks for that response. I think that's a valid reason. So now I'm going to ask you the homeless. Someone is homeless, they're not working, et cetera, they don't have any place to live, they want to apply for Medicaid program. Who helps them to get an ID? Is that the Department of Health or is that the Department of Human Services? Mr. Smith, you heard the question?
No, could you repeat it, please?
A homeless person comes to your program to apply for assistance. They're unemployed and they're homeless. The presumptive, do they qualify?
Yes, we do provide benefits for homeless persons.
But you need an ID, right?
Yes, and I don't know the particulars, but
Alvin would answer.
Can you answer that question?
Yes, I can. The senior ID program is not just senior ID, it's called information and referral. So if that person goes over to the Medicaid unit and they need an ID, of course, our staff would in fact make that process available for them. So it's cohesive with us and MAP to get that ID for them.
I got a question here. Who in particular would the person go to get the homeless ID?
They'll come to the senior citizens division at FS and St. Croix at Marseille. We're right next to in the same compound, and Miss Ayala is there. And then on St. Thomas we have Jacqueline Alexander and also Miss Joanne Henderson that would be able to help them with that as well.
Okay, good, Carla. Miss Ayala or Miss Henderson, go see them to get the ID for the homeless. Thank you. Next, we'll go to Senator Novell Francis. You're recognized for your 7 minutes.
Mic check 1, 2. Thank you very much, Mr. Chair, and good afternoon. I guess it's afternoon now. Commissioner, thank you for your testimony, and wow, you got a lot on your plate. we'll continue to pray for you. A couple of budget questions real quickly. Have you received all of your allotment? Are you up to date with your allotments?
We're receiving our allotments on a monthly basis. We have not received all our allotments as yet.
And you getting those monthly allotments is the full amount, or is there anything deducted from it?
It's a percentage deduction, Senator.
What is that deduction?
I think it's like 1%.
1%. Well, you still have a CFO?
Yes, I do, Senator.
Okay. Is she working remotely, or is she?
No, she's in the office. We had to split up the team because we have a required federal meeting that the fiscal team had to attend. So they're online with us on chat as we get questions, so they can help us respond. But we had to split up the team for this hearing due to the rescheduling of the hearing.
No worries. Vendor payment. Are you up to date with your vendor's payment, or what's your delta? What do you owe in vendor's payment?
We're not up to date with our vendor payments. I think at DOF right now, I think we're about $6 million in vendor payments. I can check and make sure I get that accurate number.
Please, and
they're
I'm interested in
listening.
the areas in particular that, is there any cutoff? Anyone has stopped providing services to you as a result of not being paid?
No, no one has stopped providing services to us, and I'll have to say on the record that OMB and Department of Finance has been very helpful in making sure that our critical vendors are paid. All vendors are critical, but we want to make sure that based no payment at all, something is better than nothing.
Okay. And in terms of, what is your vacancy levels right now?
We just got back about 18 PRFs. I'm waiting for the vacancy listing. We just got back 18 PRFs, and so that's at DOF waiting to go on the website. So our vacancies are coming through to our federal budget that has been approved. All those federal positions that does not really have effect on the general fund are being filled immediately.
How many new hires have you had for this fiscal year, October 1 to current?
I will get that number for you from the team, but I think we're at 45, but I'll get a number from the team for you shortly.
Very well. Moving a little bit into the operational issues, would you submit that, or do you believe that senior care is in crisis in the Virgin Islands?
Yes, I will.
You will agree on that.
Just to correct you, our amount at DOF, Department of Finance, is $8.1 million in vendor payments.
$8.1 million. The money there, Papa? That's a lot of money owed, right? So we'll try to deep dive and see what particular area.
And we received our February allotment. Instead of 8.3, we are receiving 7.5.
0.5. Are you up to date with your MAP payments? Are those current?
Payments.
A pay cycle is currently in process. We're hoping to release payment to providers today during today's check run.
Okay, and that will cover what period?
That would cover claims submitted up to last week, Friday.
Okay, good. Thanks. Commissioner, talking a little bit in terms of the senior care crisis, is there any opportunity for us to be able, and let me say that when we look at the census report, we have 22,349 individuals that were documented as seniors, 62 years and older, which accounts for 25.6% of our population. And as of 2020, which means, and we have heard of the decline over the last several years. So again, those numbers are probably declining, and we have a larger amount of seniors. So our need to ensure that we're addressing our senior nursing home, assisted living home, living facilities is essential and necessary. And of course, you're responsible from cradle to grave, so you have your work cut out for you in that area. But I wanted to ask you whether or not, do you believe that outside of awaiting the upstart of our new facilities, is there an opportunity for us to create a sensory or memory area within our Herbert Grigg home, where we have an issue of dementia, Alzheimer's, stroke patients, loneliness, which in itself is another disease. Is there an opportunity for us to be able to address some of those issues at the Herbert Grigg and Queen Louise at this time?
Good afternoon, Senator Francis. That is true. I don't know that Herbert Grigg Home would be the entity, but I know that we have a growing community where dementia and Alzheimer is plaguing. Adult daycare, however, might be the answer to that, and that would alleviate from persons actually putting their family members into nursing homes. If they could have somebody to watch them while they go to work, most people would, I think that we come from a community where people would rather have their parents at home in the evening when they could take care of them, but not during the day when they have to go to work. So that
you take me right where I want to go. Okay. Because I think that we need to create an adult daycare to support and assist. We have a lot of our caretakers and those individuals that's really at their last leg. If we're not taking care of these individuals and giving them some respite, giving them some downtime, and we're driving them themselves into a crisis mode as well. So I do have a bill, and the reason why I talk about Herbert Grigg is because, again, it needs to be CMS certified. It needs to be a nursing home facility in order for us to be able to get benefits and compensation. But when we talk about physical and occupational therapy, like you mentioned, we need to really address that particular issue as we continue to see, and time is of the essence. As we continue to delay the build-out of these facilities, are coming up with this grand design by Springline, and I think Springline is always at the extreme. They always come in with all of these millions and millions of dollars of facilities and not really giving us what the budget, you talk about budget, and we're not giving us what our budget is. So when we talk about doing 44, by the time we get Springline's design, we have to come down to 38. We have to come down to 30 because they're always on this grand Taj Mahal of a facility, and we need to take a look at that. My time has been called, but if I had the opportunity to ask another question.
Yes, you may wrap up, Senator.
Yes, Mr. Milligan.
Just want to bring to your attention to this small facility that just came online for adult daycare in the WIM area. We just started out about a month and a half ago. We visited that facility as well. I can share that information with you as well when I don't remember the name offhand, but that's a start as well. So we know that the community is paying attention to these situations as well, and I've been saying it for quite some time. I don't know that it has to be all DHS, but I think that, other entities needs to look into it because this would be a great help to our community. Every day you hear people saying, I don't mind, but I just can't go to work and worry about my mother or father being at home or walking away or anything like that. So I'm hoping that we could get that on board pretty soon.
So I don't believe it should be all DHS. I think that there needs to be a synergy developed, and all of us need to be on board with addressing this issue. I heard about the Rain Dance LLC that's developing. I embrace that. We have Turning Point, we have Flamboyant Gardens, we have Lutheran Social Services. There must be a synergy where government is supporting these private entities, better, whether by funding or agreement, so that we could have everyone support and assist us in this endeavor, because it's continued to become a crisis, a further crisis, if we don't address this particular issue.
Senator Francis, the name of the facility in WIM is Fortress. Fortress.
Oh, well. Thank you. I'll query some additional in my second round. Thank you very much, Mr. Chair.
Okay. Thank you, Senator Francis. Okay, I'm still getting the text here. So they're saying it means that Ms. Ayala gonna help them get their birth certificate and the social security cards.
No.
The homeless.
No.
Just an ID.
Let me restate that, right? We are only responsible for issuing ID. If there's cases, they need to come with the documents that are needed for that. So the person does not have any documents at all.
Well, I don't know, but a homeless person, no job, live on the street. They're trying to get an ID. You said to come to Ms. Ayala, but they want to know if Ms. Ayala is going to help them get their birth certificate and their social security cards.
Go ahead.
Good afternoon. Tasha Phillips Dorset, DHS Assistant Commissioner. So in terms of the birth certificate, that's run through the Department of Health Vital Statistics Office. And in terms of Social Security card, that's through the Social Security Administration. Now, what our staff at DHS can do is give referrals in terms of contact names, the telephone number, that type of thing. But DHS does not provide or issue birth certificates.
Okay,
we can
good.
start it off with the senior ID and then assist if referrals are necessary. We also have an emergency and intake program at DHS. So if the person, is homeless, they're hungry, they don't have any health care, et cetera, we will route them through the areas or the divisions within our agency that can assist. That's within our purview. That's the point. If it's within our purview, we definitely can assist.
Okay, I'm sure they heard that. One other question. I saw where the Catholic Charities had a portable laundry and stuff. Is that working now? Do you know if that's working? Portable laundry. I think it was a free one wash load for all the homeless.
We can't speak on Catholic Charities, Senator Fonseca.
Okay.
The nonprofits will have to speak on their what their services they offer. We only give them certain funding through Department of Human Services.
Okay. One quick question. The homeless count. What's the homeless count for St. Thomas, St. John, and St. Croix?
That's under DOH. DHS does not keep
Department of
track
Health?
of the homeless count population. We can try to get that number for you based on if any one of our employees with ESF6 can provide that, but we don't keep track of the homeless count, Senator.
Thank you. I'd like to recognize the presence of the Honorable Senator Clifford Joseph. Welcome. Non-committee member. Senator Maurice James, you're recognized for your 7 minutes.
Thank you, Mr. Chair. Good morning, Virgin Islands. Good morning, testifiers. Good morning, colleagues. Good morning, everyone in the room and outside the room. I want to begin, first of all, by thanking the members of your team who gave us a tour of Herbert Grigg a few weeks ago. For me, it was very informative. I actually was, what's the word? I was heartened by what I saw. I felt good. And the information that was provided by all of your staff was very, very, very good information. I want to ask, first of all, I want to tell you that your testimony is excellent, very thorough, very comprehensive. You pointed out one thing that I really want to emphasize for Virgin Islands, for Virgin Islanders, that we all need to understand going forward. You said the territory does not have the fiscal capacity to replace lost federal funding. We just don't. And that reality needs to sink in across the population, including public officials, elected and appointed. So I'm glad you said that. On the note of the presumptive eligibility, I also noted that you spoke about the individual level challenges and in terms of lack of awareness, difficulty providing required documentation. That is another factor that I'm noticing across the different programs that are available. For example, at my hearing, when it came to emergency rental assistance, when it came to the Envision program, there was also the difficulty of our population providing documentation, responding to the department's requests for information. That is troubling to me because it speaks about the population that we have right now. And that should concern all of us in the Virgin Islands. Why we want to help as a government, but they have to help us too. But in that regard, is there any way that your staff can and I know you're short staff. That's another issue. How, or even just across the board, maybe development of some office that assists our population in providing documentation to any of these programs. Do you have like maybe a little unit or an office that does that?
Commissioner Averil George, what the team has been doing in terms of awareness is that we have started doing podcasts. And it's not everybody is tuned into social media. We have our social media platform. If you haven't liked us as yet, please follow us, U.S. Virgin Islands Department of Human Services. But we have started doing podcasts for the population that watches the government access channel. Our communication team has been doing meeting with each division, taking you from point A to point Z in regards to our processes, what is needed.
I'm going to stop you
We
on that
also have
note.
individuals in-house
Right.
that can assist when you come in to gear you in that direction to get the completed process.
One other thing, thank you for that though, for the people out there who watch podcasts. But what about our aging population, our senior population who no podcasts, no computer, no anything social media? That's part of the problem we're facing. But I'm going to segue into something with regard to the senior population. When I visited Herbert Grigg, a few of the, I think it was the nurses in the building, talked about how they're getting older. The wear and tear on their bodies in taking care of seniors in the home is really taking a toll on them. This is something else that we experienced with paramedics when we were doing the merger of fire and EMS. We simply are unable to recruit people. Why? I mean, what do you see as the challenges that you face in terms of, well, you're going to face competition throughout the right, different agencies, but what are the challenges are you facing in getting staffing at Herbert Grigg?
Our salaries. Our salaries is a critical point. When you tell them what we're paying for nurses at Herbert Grigg, they're telling we gotta be crazy. They can go to the States or go someplace and make double times what we make. It's always when the salary. That's our main focal point, the salary of nurses, to retain them. The minute we hire a nurse, and for instance, the hospital got a vacancy that's paying much more money, or a private provider is paying much money, we lose our nurses. So it's retention.
Yeah, true. And I think that's across the board. One of the other, I was doing some research on how to deal with borders, and I came across an article that talked about a federal program called Hospital at Home. That what's interesting about it though is that I came across a letter that was written by the secretary at the time, Xavier Becerra, who obviously now we're in a transition period. So I was wondering if you were familiar with that program at all?
30 seconds.
To address the borders?
No, I'm not.
Yeah, I'll ask the hospital officials. But in any case, the CMS funds are running out. We don't know whether Congress will extend it. But one of the things that was mentioned in that letter is that this is stateside and as well as here, that we now have to find public-private strategies to address ER crowding and boarding. And I think, Mr. Chair, may I just conclude on that note?
Yes, yes.
Thank you. I think the time for us in the Virgin Islands is to realize that we're actually going to have to go out to the private sector, whether it's private donors, private investors, private people to form these public-private partnerships. One more question, which was for Mr. Milligan, the Administrator of Senior Citizens. I just wanted you to explain for me, and for those who don't understand, what the Adult Daycare Center is. Thank you.
Oh, the adult daycare. Well, we only in the Alvin Milligan Administrator. So let me just clarify. The DHS provides the recreation centers. Senior centers that we provide is for recreation. So in other words, you cannot have Alzheimer's or dementia of the sort because we only provide recreation. So the adult daycare would just do that. It's you like how you drop your children to a daycare center. They'll watch them throughout the day, provide, therapy for them, try to stimulate them, keep them calm, whatever they need to do until you retrieve them in the evening. So that's a growing need because, as we know, the population, as Senator Francis said, it's a growing population, and every day you turn around, unfortunately, we're seeing more and more persons with dementia and Alzheimer's. But then you can't leave them alone. So we need to have some place to put them while folks could go to work and do what they need to do and then take care of them in the evening until the next day and so forth.
Thank you, Senator Maurice James. Commissioner, one other question here. Seems like a lot of people following your testimony. Are defibrillators required in Herbert Grigg, and do we have a defibrillator in Herbert Grigg home?
Senator, no, we don't have a defibrillator at Herbert Grigg.
Are they required?
We call the ambulance if we have an issue, and hopefully they reach quickly before any catastrophe.
Okay. Senator Kurt
Excuse
Bailey.
me, Chairman, Senator Fonseca,
Yes.
can I provide some clarification?
Yes, proceed.
Okay, regarding presumptive eligibility, I want to make clear, presumptive eligibility is a process that a member presents to the hospital, the FQHCs or Department of Health clinics, and they're uninsured. It's supposed to be a self-attestation process. When the SPA was submitted and approved by CMS back in 2015, the facilities are responsible for offering presumptive eligibility to the members. The plan is we would have outstation workers at the locations to provide support. We are not allowed to process presumptive eligibility applications. The facilities have been trained. As I mentioned before, we provided training as recent as November for the St. Croix facilities. The last time we provided training for the St. Thomas facilities was back in late 2023. We're working to coordinate to provide additional training as they have new staff and then also retrain the other folks. And then also, it's a temporary benefit. So if you present today, you obtain presumptive eligibility, it expires the following month. So that means your benefits will expire March 31st. And in between that time, you're supposed to submit an application with all of your supporting documents to obtain full 12 months of benefits from Medicaid. So I want to make clear, presumptive eligibility is a temporary period of benefits, and then you have to, within that period of time, submit your full application to get the full 12 months.
That's very important. I want to follow up on that, being that you stated you provided training. So in your opinion or in your assessment, has the hospitals and the clinics taken full advantage of the presumptive eligibility for their patients?
Well, based on the numbers that the commissioner provided in her testimony, I would say no.
No. Okay.
Senator Fonseca, just to give you an update, Commissioner George, our homeless count in the territory is 249, disabled 119, veterans 11, and children 2.
Thank you. Thank you for that update, Commissioner. Senator Kurt Bailey, you're recognized for your 7 minutes.
Thank you, Mr. Chair. Once again, good afternoon to the people of the Virgin Islands. Mr. Smith, in terms of the presumptive eligibility, is the issue that 30-day period in which they have applied at the hospital and then they have 30 days to complete the full application, and most of the individuals that receive presumptive eligibility at the site do not continue in that 30-day period to submit the application. Is that true?
Yes. So what we encourage the hospitals to do is, at the time that the presumptive eligibility is provided when the individuals are present. Encourage that they work with the patient and or family to begin that process
To complete
right
it,
away.
right. Because what is happening is that they get covered for the 30 days and then they don't complete the application, and then any further coverage is literally denied because they're no longer under presumptive eligibility. The surprising thing is that we're dealing with this for like 6 or 7 years now, and yet we still can't find a solution as to how we're going to get individuals to transition from the application process to fully applying at human services. I mean, to me, that's a meeting between the institutions and human services as to how we're going to get that information, because we're losing money. Because if that individual needs services for 6 months, they're not going to get paid for the next 5 months. They're only going to get the hospital will only get paid for 1 month. It's something we got to work out. I'm looking at your numbers on page 3 in reference to MAP. Those numbers represent what? The 83%, the 100%, the 17%? What does they represent? The 6 million for Freddie Said Health Center, 8.6 for Wang Louis, 13.9 for Schneider. What does that represent?
Those are payments, claim payments.
Okay. At the 83%, at the 100%?
It depends, because a single adult is paid at 90/10. A child.
Okay, so it represents the federal plus the local portion.
Well, no. It represents federal only, because we pay.
Okay, well, I understand. It represents federal only. So 31, I added all of those categories. It came up to $31,233,997, correct? And in a question asked before as to what type of access we had, you said for the 83% match, we had access to $139,450,000. That was correct?
Yes, but you would have to subtract that.
Okay, but what I'm trying to say is that we're not even using 30% of the monies. We have the capacity to go to 130 or 140,000 literally, and we only utilizing 31,000 because of eligibility and all of those other issues.
So eligibility, but then also timely filing of claims. Claims are submitted, they're not complete, they have errors, providers have to address those errors, all of that.
I just want to put on the record that we have tremendous capacity. We have capacity of 140, and we only utilizing 31. Now, my big question with that is that you also have 12 months to submit the claim?
Yes.
So, and I'll ask the hospitals this question later so that they can be ready. How many claims are falling through the cracks because they're not submitting it within that 12 months? Because if you look at the numbers, right, and I just want us to look at the numbers. Numbers reveal everything. And it reveals a billing situation at these institutions. Freddie Said Health Center, $6.3 million. Freddie Said Health Center is literally a clinic. Provide some other services, but literally a clinic. They don't have any hospital beds. They don't have any overnight stay. Wang Louis, $8.6 million. That's only $2.3 million more. But Wang Louis is a hospital with beds.
3 minutes.
So that number should have really been almost double. You see Schneider at $13 million. I mean, so we don't have to look at how many patients are going through both institutions, but right there with the numbers, with Frederick Said Hospital being 50% of Schneider and probably 80% of Wang Louis, you could see that a lot of individuals are falling through the cracks, that we're not billing for a number of individuals that have Medicaid. And that needs to be corrected, because the legislature is being looked at as a funding source for everything. But internally, you got to correct your practices, and then the legislature would provide whatever is needed for the uncompensated care. But we have access to $139 million. We should apply for every single instance of Medicaid to make sure it's paid. And I spent a lot of time on that. I didn't want to spend as much. You're getting the 17% from the GVI? Are you getting the full 17%? No. And are you fully funded to get a 17% this fiscal year?
No, sir.
Did you submit those numbers, Ms. George, Commissioner? Did you submit, based on your estimate of 31,000, you could have run it to 40,000. Did you submit what the 17% look like so that the GVI could include it in the budget?
Yes, we are still going through our budget prep for FY26, and those numbers are included.
Okay, so for FY25, did you receive a line item for that?
I will check and get back to you, Senator.
Okay, and when you do, I want to know exactly what is that line item. Mr. Smith, after an application is submitted to you, how long does it take you to render a decision for that person to receive medical care? What's the turnaround process in your office?
I don't have the specific.
Not specific. Average turnaround time for an application.
We have up to 45 days. To
Me asking what you have
I
up
know,
to.
I know, and that's what I'm saying. I would have to get back to you with that information.
Hold up. We're talking about individuals who are ill.
Understood.
So I asked the question to say we need to speed up the process. Because senators receive call a lot of times saying, hey, I made an application for blah, 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 I'm waiting. It shouldn't take so long. How many positions are covered by the federal budget for
30
MAP?
seconds.
You're supposed to know the number one.
We have at least between both districts, I would say 10 to 12 vacancies in eligibility and enrollment.
No, then the question. Under MAP funding, how many individuals are hired under that particular fund? Because you might have people hired under the fund and they
So
work
you're talking
there.
about the program total or just eligibility?
Program
enrollment?
total.
I have 33 staff currently.
Okay, and 33 staffers can turn around applications?
33 staff does not work in eligibility enrollment, sir.
Then you need to reconfigure what you're doing to make sure that we're able to capture these federal funds. You have 33% of your staff working in eligibility. You said 10 or 11, right?
We currently have approximately, I would say, 10, yes.
So what are others working in? What department?
You have care coordination, special services.
How many?
I have a staff of 5.
And for care coordination,
care coordination, special
but they have
services.
to be eligible first and approved, correct?
Yes.
Go ahead.
Yes, you have claims processing and provider enrollment. We have in that area.
Don't say no more. All I'm asking you to do is revisit the structure of the department to make sure that you're able to process claims or process eligibility or approval on a timely basis to get individuals off the island or get individuals the provided health care on island.
So may I make us okay? So Senator, I truly excuse me. We definitely understand that. I can request the dollars from the federal government all day, but I need the local funds to match. That funding.
That's our job.
That funding to cover those positions does not even come from my regular allotment that is used to pay claims. I write a funding document and request those dollars from the federal government.
For the 17%?
No, for the eligibility and enrollment staff who provides.
Are they funded 100%? Are their positions funded 100% or 75%?
They're funded at 25% local match, 75% from the federal government.
Hence, when you submit in your budget, Commissioner, let us know what is the cost for those individuals because it's a 75% federal, 25%. This government has been providing, or I know through the legislature, I was chair for quite a while, we were providing that 25% funding for all the positions that were listed in your personnel. And I know it was done last budget cycle also. You submit the positions, you know. And then the legislature fund, and the legislature provided sufficient funding to fund the federal positions plus the local positions plus some vacancies. If it's not, if there's a shortage now, then we need to know so that a supplement is done by this body to make sure that it's funded.
Correction, Commissioner Averil, George, you are correct. But based on the personnel listing that was submitted, we had to go back and make drastic changes with incorrect data that was submitted. So it eated up our funding that was allotted for vacancies because if the personnel list was not accurate from the beginning. So you are correct, but based on our restructuring and our review of the personnel list, it was not accurate to fulfill the funding that was provided.
Okay, and that is a mistake on the executive branch. That is a mistake on the legislature. The legislature fund.
It's not at all.
Yeah, what has been submitted, and too many times, the various branches, you know, you receive a funding ceiling from the OMB office and they tell you need to stay within this or that, and a lot of individuals come before the legislature and they don't truly say what they need, or they don't privately say what they need, so we pass what you propose to us. And if we pass what you propose to this body and it's not sufficient, then programs that could generate millions of dollars to the Virgin Islands don't function the way that they're supposed to.
Senator Viola, I have some numbers for you. Our MAP claims for FY25 is $10,240,000.
Up to February?
Up to February.
Okay, so we literally in the same piece with the same amount of money.
3 minutes.
Okay, cause that's 4 months. If you say up to January, it's 4 months. So February we collect 10 million, so you have 2 more cycles of 4 months. So we're on target for the same 30-something million dollars. So I'm just encouraging all the entities to do what is possible to make sure that we send those bills out. The most important factor that we need to cover today is those institutions that bill, sending the bills out. And everybody that work in those offices, that's their responsibility. And when they don't do their job, they're causing the Virgin Islands government to literally be on the verge of collapse, because you can't get 6, 8, 9 million here that you could reinvest into the facility that you're running. So everyone in those offices need to understand the responsibility of their job. And if they can't understand it, you need to switch them out. It's really as simple as that now.
And I also add that we don't receive a line item budget for the hospitals and clinic for their 17%. That is what their GVI allotment yearly counts for.
Okay, so we have the good finance chair right here to my left. So we need to have that information so that we can provide a line item for the FQHCs and a line item for the other providers, line item for the hospital. We need to get it right so that we could pull down the 83%. But thank you so much for your leeway, Mr. Chair.
Thank you, Senator. Yes, proceed, Director Smith. Media, recognize the mic for Director Smith. Yes, proceed.
Mic check, okay. Gary Smith, Medicaid Director. So just to add to what the Commissioner said, the hospitals, the FQHCs, Department of Health clinics only receive the federal share. And we're allowed to pay them the federal share because of the state plan amendment submitted, because they already receive government funds from the general fund, to your point, Senator Bailey. So when we reimburse them, they only get the federal share. So if the federal share is 83%, that's what they're getting. They're supposed to reconcile and make sure that that 17% is in their budget, which I know is a challenge for them.
So right now we're assuming that 17% is coming out of the allotment that they receive from the GVI.
Exactly.
Okay,
yes.
Thank you so much.
Yes, thank you, Senator Kurt Ville. Point of information, Senator Frederick.
Commissioner, a point of information on the vacancies that you were discussing. It was 18 vacancies you had said was total, of which how much is classified and how much is exempt positions?
What number you're referring to, Senator, that I said?
When Senator Francis asked you about your vacancies, you mentioned...
And I told him I'll get that information back for him. I didn't give a number.
You didn't? Okay.
No.
Did you receive that information?
No, they're working on getting that for me.
Okay.
And I'd like to put on the record that for vacancies, we received a lump sum, not because our last budget cycle, we were only allowed to put 5 vacancies on it based on what was submitted. And we were given a lump sum budget to draw down for the vacancies that we have in our respective department. So for me to sit here and say I have a vacancy count of 80 to 100 will be unfair, because we're dealing with the budget that we were given, that lump sum budget, and is drawing down from it. And the team has been advised to make sure that critical positions that we need to fill based on our federal mandate in regards to our eligibility specialists for Medicaid and SNAP, our nurses and staff are filled from that lump sum budget. So we don't have a standard perfect vacancy listing, because we're filling vacancies based on the funding received and our critical positions.
Thank you.
I
Thank
hope
you.
that answers your question.
Yes, thank you very much. But whenever you do get the numbers, please let us know.
Yes, thank you, Senator Lorenzo Frederick. Senator Maurice James, you're recognized for your point of information.
Thank you, Mr. Chair. I actually was going down the same road that Senator Viale is down, because I think our people need to understand that, you know, their pay is dependent on their work. But I wanted to ask you, with respect to programs that are administered, especially with the FQHCs and nonprofits, right? Because a lot of funding comes through you for them, as we just, of course, talked about. Since January, have there been any issues accessing any of the funding that we get from the federal government in your department, or with respect to nonprofits or the health clinics or centers?
Commissioner Averil, Judge, no, Senator. We have not at this time received any funding issues. We just recently paid, with the help of Department of Finance, our third and fourth quarter allotments to our nonprofit, which was behind, and the nonprofits was recently sent out the notice of grant awards for the first quarter, which we got from OMB, and we're awaiting the documentation from the nonprofits that is required prior to releasing those funds.
Okay, so that's good right now.
Yeah, right
as
now.
of today.
As of today.
Yeah. One additional question with respect to the matching. There's no requirement that from the federal government. I don't know the answer to this. This is really out of the blue. I was just sitting here. There's no requirement that we provide our 17% before they release their 83, correct?
Normally, you're not, Gary Smith, Medicaid Director, normally you're not supposed to, but in some instances, they would allow you to, you know, they have a process called slow pay and other issues. But, you know, it's working with the federal partners, CMS, and advising them of your challenges, and receiving that permission to make those decisions.
Good. That's good to know. Thank you for that. Thank you, Mr. Smith. Thank you, Mr. Chair.
Thank you, Honorable Senator Maurice James. Mr. Milligan, yes, you can proceed with that explanation.
No, I just wanted to clarify again about the homeless ID, the person that was inquiring. The IDs that we issue at the ID facility, INR, they have to be 60 or older. They have to be a senior, to be considered a senior ID, so they have to be 60 or older. So if the person is under 60, then we're going to have to revisit where else we could try to help them with that, but they have to be 60 or older.
So that means they can't go to Ms. Ayala, they got to come to you then, Mr. Milligan.
Not to me particularly, but I'm saying that let me tell you this here, though, but I was saying this in her defense. Ms. Ayala has a wealth of information, so she deals with situations like that. But between that and if they're looking for other services as well, we'll collaborate and try to solidify that issue. But I didn't want the person to get excited. They may be homeless, but if they're not a senior, then that's an issue that we have to now resolve again. So I just want to make that clear.
You see, when you gave that good explanation for why the senior ID expired 5 years, we took it, it was good. But this one here is a little different. Good. Senator Milton Potter, Mr. President, you're recognized for your 7 minutes.
Thank you very much, Mr. Chair. Good afternoon, colleagues. A special good afternoon to you, Commissioner George, and the members of your senior leadership team who are with you today. I want to thank you, Commissioner, for your very comprehensive testimony today. I wanted to, right out of the gate, I wanted to ask you a question about the borders. I know we've been discussing that today. I wanted to just get your thoughts on what immediate steps can be taken to reduce the number of borders at Wang Louis and Schneider Hospital while we're waiting for the construction of the new long-term care facilities. What are your thoughts and ideas on that?
I will say, like I said in my testimony, where I gave numbers in regards to additional beds at these facilities and funding and subsidies that can assist in the short-term effort.
Okay. And just sticking on the issue of borders, and I wanted to ask you about the role of families, the roles that local families play in addressing the issue of borders.
The borders at the hospital, I won't say that I made a statement earlier, and I'll correct my statement that the families don't want these individuals. It's just that some families can afford or don't have the the amenities to assist with individuals in with the illnesses that some of these patients are experiencing. So I'll take back my previous statement. But family play a critical role in borders, and we can assist with so much based on our availability and funding with these borders. But again, DHS can only do what we can do based on what we have.
I wanted to follow up as to, in terms of funding and support, are there any initiatives that DHS could identify to provide additional support or incentives for families willing to care for discharged patients?
The services we currently provide, Senator, which is homemaker, Meals on Wheels, what else we have? PCA program. It's just a regular service that we provide to everybody in our community that meets our requirements. We don't have anything beyond that, and it requires a lot.
Yeah, I mean, I'm thinking, just considering the high cost and the burden that the borders place on our hospitals, I'm thinking if there were some program or some initiative that, between human services and the hospitals could come together to come up with an initiative that would provide that sort of extra specialized support to families, because I think sometimes it is a matter of them feeling a level of inadequacy as far as their ability to take care of their loved ones who are being discharged. I just wanted to get a sense as to whether or not there was any dialogue or discussion with the hospitals to come up with a program or a special initiative outside of what you have now with the Meals on Wheels, etc. Because we're paying big money anyway. My point is. So isn't there a possibility that we could come up with a program or an initiative that would incentivize families to accept their loved ones when they're discharged from the hospitals?
At this time, Senator, I'll say that we can go. We're strapped right now. The services that we provide is what we can offer. Conversations can be had with the hospitals and the families to see what else can be provided to them to assist them if they're willing to take their loved ones in their home. But that's additional conversations that needs to be had.
And I'm just saying, considering how significant this issue is, I think that it should be something that would be prioritized to, just to come up with something outside of, the idea of, we know the building of the new long-term facility, ultimately that is the fix. But in the interim, I think that is something that we are to really, put some brain power towards, developing. I think it'll go a long way towards easing some of the pressures off of the hospitals. But I'll move from that, Commissioner.
Thank you, Senator, for your recommendation, and it's conversations that we can start to have based on your recommendations. I appreciate it. I think Mr. Smith had something to add to your questioning.
Yeah, so, we created a personal care attendant service program, which provides assistance for daily living activities, very similar to the Homemakers program that also assists once the person is Medicaid eligible, they can receive those services. And if the services require medical care, there's home health services available as well, which has to be provided by a licensed practitioner, the home health care. And on the personal care attendant side, just a high school diploma, is necessary to assist with daily living activities, combing the hair, helping bathe, but can't administer medications, can't change bandages on wounds, that sort of thing.
30 seconds.
What is Human Services doing to really expand our workforce and encourage more individuals to enter this field?
So that is providers. We enroll providers to provide those services. There are currently 6 in the territory.
Okay. My final question. How does Department of Human Services plan to address delayed Medicaid provider payments, which may contribute to staffing shortages and financial instability among healthcare providers?
Yeah, so the provider payment is a collaborative effort between the department, our partner Gainwell, who manages, processes and adjudicates the claims, and the Department of Finance. Once we process and adjudicate the claims, the pay file is submitted to the Department of Finance, and then the Department of Finance, they're the ones that releases the payment. Human Services does not release the payment. But I can share, as I mentioned earlier, we submitted a pay file to the Department of Finance. I know it has been processed, and we're hoping that it will be released today.
Okay. I mean, my thinking is that I know your role is, you don't actually cut the checks, but I'm just thinking the critical role that you play and the other partners who you just mentioned. I've heard so many stories of providers who have not been receiving their payments over a long period of time. I'm just thinking that there ought to be some mechanism or some system or some review of the processes to speed up, this.
Unfortunately, Senator Potter, it has to do with funding. Once a claim is submitted to our claim system, once it's a clean claim, it's processed and adjudicated within a matter of seconds. So it is automatically ready. When we first started with the system, payments are going out on a weekly basis, but the funding has to be available for the payment to go out. The local match funding has to be available for the payment to be issued.
Okay, and the local match is the main reason for the delay. That's what you're saying?
I would have to say yes.
Okay. Thank you, Mr. Chair, for your time. I won't abuse my time. Thank you.
Thank you, President Potter. Next, we'll go to the Honorable Senator Clifford Joseph, the Chairman of the Public Safety, Homeland Security, and Justice Committee. Senator Joseph, you're recognized for your 7 minutes.
Yes, good afternoon, everyone. Good afternoon to everyone in the world. Good afternoon to our testifiers. Good afternoon to the staff here at the legislature. And good afternoon to my colleagues. Commissioner George, I must commend you and your group, everybody that works for Human Services. Sometimes I do visit, and I know you got some good volunteers as well, too, that put a lot of their effort forward to helping the situation that you're in. Because the situation you're in, like I heard Nobel said earlier, I'm going to go with a little bit of the Bible and say, your cup run it over. I ain't worrying about your plate, but I know your cup run it over, and you still have a lot of work to do. My first question I have for you, I don't have much, but my first question would be, can the adult daycare be paid for by Medicare or qualify for Medicare?
Adult daycare be qualified.
I would have to get back to you on that, Senator. I'm not sure. Gary Smith, Medicaid Director.
Okay, good. Or a block grant, maybe?
Yeah, we would have to research that and get back to you.
Okay.
So if, I'm not, is a adult daycare required to be CMS certified?
Some are, Alvin Milligan, administrators, some on the mainland are, not all are, so it has to be tailored to what we would want it to be. So both of your suggestions or your inquiries could be either right. If they're CMS certified, then it could be paid by Medicaid. If not, then we'll have to get, whoever the entity is would have to get funding to run the facility.
Okay, good. What is considered the local poverty level for the territory?
I'll get that number for you, Senator. Commissioner George, I'll get that number for you.
Okay, thank you for your answer. What income qualifies for one for Medicare?
The income threshold for a single adult is 15,654. And that is gross, not net. We do not, Medicaid does not take into consideration, your light bill, your rent. Your income is based on your annual gross, what you're making on an annual basis.
All right, but what can we do to increase?
So we are currently working with that, with our partners and CMS to increase that threshold, hopefully to get it up to like 18,000, 19,000.
Thank you, Mr. Chair. I don't have no other questions, and thank you for your answers.
Thank you, Senator Clifford Joseph. And colleagues, I think we've exhausted our line of questioning. If there's any burning question, I would allow that. Hearing none, yes, Senator Fredericks, you're recognized for your point of information. Burning question.
Commissioner, before we wrap this up, I just want to make sure the public understands. Your agency is $8 million in the hole, correct? Of accounts payable.
We have
vendor payments, right?
We have $8.3 million of vendor payment, and I'll put on the record that I will say that is a small amount based on what DOF has paid out for us within the past 2 months. They've been working feverishly with bringing down that number and making sure that our vendors are paid. So I just want to put it, 8.3 might sound a lot to you guys, but what was on the books and what was paid over the past couple of months, I just want to put on the record that DOF has been assisting with getting our vendor payments down to a certain level.
And the reason I'm asking this question is because the vendors are texting us asking when they'll be paid because they can't wait. Unfortunately, they've been waiting, some of them. Do you know what the aging was on that? How many was over 90 days?
We have vendors that just submitted invoices from October, November that just was put in DOF system that brought us back up to $8.3 million. We can only account for when it was submitted and when it's sent to DOF in regards to requisition processes. So it's not like it's current payments. We have payments, invoice dated back 3-4 months that just been entered in February based on when the team received the invoices.
Okay. Thanks for the clarification, Commissioner.
You're welcome.
Yes, Senator Vele, you're recognized for your point of information.
Thank you so much, Mr. Chair. Who is currently paying Casa de Salud? Commissioner.
Good afternoon, Tasha Phillips Dorset, Assistant Commissioner. Currently, we are on a contract, we, meaning DHS, are on a contract for 7 beds total at Casa de Salud. Right now, we have 5 beds occupied.
Who are paying for the patients that were referred to Casa de Salud from Juan Louis Hospital?
The hospital is currently paying that. I believe they have 3 patients there, 1 from 2014 and 2 from 2020. But to my knowledge, DHS was not involved in the process of placing them there. So we don't have a budget. We don't have it as a line item budget.
Okay, so that's good. But you need to request it because the hospital shouldn't really be paying for borders in Puerto Rico. So we need to get that number so that we could really provide a line item to take care of those individuals who the hospital, who's already broke, have been having to pay on a regular basis. And I think that we can make that work. And my last comment is that those vendors who are paid utilizing 100% federal funds, we need to make sure that all of them are paid and that we're drawing down those federal monies, especially what is going on in Washington now. We need to speed that up. Every single federal dollar that is owed to vendors that have already provided the service, let's make sure that they get paid. Okay, those in the Head Start or pre-Head Start programs and all of those, let's make sure we draw down those monies and get it paid as quick as possible. Thank you so much, Mr. Chair.
Point of information, Senator Fonseca. Chair.
Just like to be recognized. So you're good.
Well, I would like to provide some information then.
Switch seat to me.
Yeah, I'll allow you to speak. Yes, go ahead, Director Smith.
Yeah, Gary Smith, Medicaid Director. This Senator Averil. So we spent a total of $135,827,797 from our claims of the 136. So we left 722,000 on the table. So we were almost there, and we could not spend that last 722 because we did not have the match to push the payment out. So we had to process the payment when the new fiscal year started.
Yeah, yes. Go ahead.
Test it. So those other monies went to what? Private providers? Because the total here.
Yes.
So $100 million going to private providers out of this territory for Medicaid?
So currently we have 30 members off island receiving care because they can't obtain the care here.
So you could just provide us with the breakdown, because that's $100 million, Mr. Chair, that's actually going to private providers.
Well, no. We spend approximately on average $30 million for off-island care. The rest of that money being generated here in the territory, but to private providers outside of the public facilities.
So 30 and 30, 60, so about $80 million going to private providers on island?
$90 million to, about $80 million to $90 million total, yeah.
So you gotta
Locally.
check and see if they're paying those taxes and those money. Thank you so much.
Yes. Senator Novell Francis, you're recognized for your point of information.
Thank you very much. Commissioner, is there any quality assurance, anyone that's checking on those individuals that's in Casa de Salud? Is there anyone that's evaluating, making sure that we're getting the services that we're paying for, checking on them?
Tisha Dorset, Assistant Commissioner. Senator, great question. Generally, it's our APS case workers that travel to Casa de Salud to check up on our clients. We actually have a team going this Thursday. That's on the schedule.
And prior to that, how long, I mean, in between, is it done quarterly? How often do we go? What's the frequency?
I believe it's twice per year.
Thank you. And I'm sorry, and the evaluation is documented. I mean, do you then get a report of how they're doing, what the conditions they're in, anything like that?
Yes, Commissioner George, yes, we document our review because that also has to be provided to the court system.
Very well. Thank you.
Yes, thank you, Senator Francis. Before I wrap up, real quickly, Commissioner, okay, so the update on the spending plans, are there any funds, human services funds that are in danger of going back to the feds? How are we with that?
At this time, no, Senator. We have been having our fiscal representative meet with each program on a regular basis to make sure the spending plan that is submitted is adhered to, structure and accountability.
Awesome. See, that's what I like about you. You know, that's why I keep telling the people, you're A-rated commissioner. That's a major improvement from how it was, with the previous commissioner. Yeah, the facts is the facts. So at this time, Commissioner, hearing no further questions or point of information, we'll allow you a 1 minute close.
Senator Fonseca and the members of the legislature, thank you for the opportunity to provide testimony on behalf of DHS. This has been 2 Senate hearings in a week, so hopefully we won't have much more. But I just want to say that I appreciate my team, first of all, the entire team, DHS territory-wide, for the work that we continue to do with the tools and resources and benefits that were provided. I will say, like I stated in my last testimony, I graded myself with my territorial team on my first year, and I gave myself an F. And many will say, why an F? Is because as leaders, we come into these positions with all these short-term and long-term goals, and we haven't been able to step out of that box to address any of them because the continuous outing of fire and crisis that we continue to see on a regular basis. If the team, short staff, lack of adequate facilities, but they continue to drive hard every single day. We do have the bad, but we have to take the good with it also. But this is a work in progress. When I sat before this committee, everybody said it's gonna take years to fix this problem. And I said, they gotta be crazy because my track record has been get into the department, get stuff fixed and see a light. 1 year in, and you're correct. This is a work in process. We're starting to see a little light, which is good, but we're gonna continue fighting because our job is to provide services to the people of this community as best as we possibly can. My team will stand here and I say my 2 words is structure and accountability. We gotta get process in place. We gotta hold our employees accountable for the job that we do. And just pray for us and hope that we continue to do the best that we can do with what we're provided. I'd like to thank Government House and their entire team. We couldn't have got to see the light without the help of OMB and Department of Finance team. I know they might be watching and saying, I continuously call them every day, what can we do different? What funding is available so we can move this needle? And they have been responsive every way possible. So I just want to publicly thank the teams for their support. But as we always say, DHS on the rise.
Thank you, thank you. And you know, I have to congratulate you on hiring the lady on your left, Miss Tasha Dorset Phillips. Awesome hire, awesome hire. We had a little bump the other day, but we good. Thank you, and you're relieved of your testimony.
Thank you, Senator.
The Committee on Health, Hospitals, and Human Services will stand in recess for 20 minutes. The Committee on Health, Hospitals, and Human Services is back on the record. Earlier in Block 1, we had testimony from the Department of Human Services. We got an update on the programs. Specifically, we got into detail with the Medicaid program, and we got a lot of information, and they have some information that they have to provide back to the committee. And so in Block 2 now, we're going to hear testimony from the hospitals. And so what we're going to do is we want to do another mic check and make sure that
Testing 1, 2.
Director Tina Commissiong is still connected with us. And over on St. Thomas with Mr. Baker, we wanted to do a mic check, make sure everything is good. So what we'll do is we'll start with Director Carty. And if you can just give your name and identify yourself. CEO Carty. CEO Baptiste, Carty-Baptiste.
Check, check. Good afternoon, a pleasant good afternoon. Darlene Carty-Baptiste, Chief Executive Officer for the Governor Juan F. Louis Hospital and Medical Center.
Yes, thank you, thank you. Dr. Smith.
Yes, good afternoon, everyone. Dr. Jerry Smith, I'm the chairman of the Government Hospitals and Healthcare Facilities Corporation.
Chris.
Good afternoon. Again, Christopher Finch, Secretary, Virgin Islands Government Hospital and Health Facilities Corporation.
Okay, and then we'll start on my right.
Good afternoon, everyone. Patricia Welcome, Chief Legal Counsel at the Juan F. Louis Hospital.
Good afternoon, Doris Plaskett, Chief Nursing Officer.
Good afternoon, Rosalie Javois, Interim Senior Vice President of Finance, Governor Juan F. Louis Hospital.
Welcome. And Director Tina Commissiong.
A pleasant good afternoon to all. Tina Commissiong, Chief Executive Officer of Schneider Regional Medical Center.
Yes, and then we will go to St. Thomas. Oh, yes, Miss Patricia Canegata, yes. How can I miss you?
Pleasant good afternoon. Patricia Canegata, Chief of Human Resources, Governor F. Juan Louis Hospital and Medical Center.
Thank you. And then we'll go to St. Thomas.
Good afternoon, Senator. Darrell Smalls, Executive Director of the Territorial Hospital Redevelopment Team.
Good afternoon, Senator Edgar Baker Phillips, Executive Director, St. Thomas Stroke Support Group, 501(c) organization.
Okay, so we'll start with Director Tina Commissiong, and then we'll go to Director CEO Tina Commissiong, and then we'll go to Executive Director Darlene Carty-Baptiste, and then we'll go to Darrell Smalls, and then we'll get testimony last from Mr. Baker. So we're ready. Director CEO Tina Commissiong, you may proceed.
Good afternoon, Honorable Senator Fonseca, Chairman of the Health and Human Services Committee, to the other Honorable Senators of the Health and Human Services Committee who are present, all other Honorable Senators of the 36th Legislature who are present, to our team at Schneider Regional Medical Center, and to the listening and viewing audience. I am Tina Commissiong, Chief Executive Officer of Schneider Regional Medical Center. Thank you for the opportunity to appear before this committee to present testimony on SRMC's strategic plan to improve and expand our services and to give you an update on our financial condition. Our presentation today will cover uncompensated care, borders, accounts payable, emergency room services, and staffing shortages. Thank you for the support that you have provided to the hardworking SRMC team over the past year. And thank you for recognizing the critical importance of prioritizing funds for our territory's hospitals. I know that as community leaders, you share the same goal for healthcare as we do. We all want to ensure that our community receives the highest quality, best care that's available right here at home within the Virgin Islands. All of our employees, both the clinical and non-clinical side, work very hard every day to serve our community. For SRMC to continue to uphold its mission to provide and expand high-quality healthcare services, we must stabilize and improve the finances of the organization. Though 2024 began with great promise for SRMC, we did face significant challenges, including 2 major cyber attacks that disrupted our organization, and it impacted our financial stability and tested our resilience. As we move forward this year to 2025, we recognize the urgency behind putting systems in place that are going to allow us to improve our revenues and collections and reduce our expenses. We must acknowledge that insufficient funding for uncompensated care and insufficient funding for the maintenance of the aged facilities have had a major negative effect over the years on the financial sustainability of SRMC. SRMC must aggressively pursue our own strategic initiatives and improve our own billing and collections, and the GVI must provide adequate funding for the uncompensated care we provide. By making some strategic investments of cash for Schneider Regional Medical Center, the government of the Virgin Islands will be able to ensure that access to high-quality care continues, and SRMC will be able to position itself as a beacon of hope and a model of healthcare excellence for the region. There are 2 main factors that have impacted SRMC's financial stability. The first is the persistent underfunding of uncompensated care. The GVI appropriation for SRMC for FY25 should have been $46.3 million. As per law, the GVI appropriation must cover 2 things: the local Medicaid match, which amounts to about $2.3 million, and uncompensated care. And that definition is found within Title 19 of the Virgin Islands Code, Section 221. Uncompensated care for Schneider Regional for the year is $44 million. Schneider Regional Medical Center received a budget of just $32.5 million for FY25. That underfunding of $14 million, which is a little bit more than $1 million a month, significantly affects SRMC's financial stability. Plainly stated, the allotment is insufficient to cover the uncompensated care that the hospital delivers. Uncompensated care places a significant burden on SRMC. SRMC must provide care to anyone who presents to our emergency room, regardless of their ability to pay. And we have a population that has a very high Medicare and Medicaid percentage, and those underpay for the cost of care. We also take care of a lot of patients that are undocumented, that have no ability to pay and can't qualify for assistance. And so Schneider Regional is really providing a lot of uncompensated care for the community. And we know that the cost of healthcare has increased significantly year after year. Inflation in healthcare is more than 4%, yet SRMC continues to receive an essentially flat budget. Additionally, as was discussed earlier in the hearing today, the availability or lack thereof of nursing home beds in the community has not improved. It's actually gotten worse. SRMC is currently caring for 13 boarders, also known as unsafe discharges, for which we receive no reimbursement. Our non-acute care unit requires 5 staff nurses and 5 certified nursing assistants. And so 1 year of just basic staffing for that unit cost the hospital more than $800,000. Based on looking at the Medicare daily rate that we should be receiving of at least $1,400, which is not even enough to cover the cost of care, it's costing SRMC approximately $6.2 million per year to care for these 13 boarders. Additionally, we have 2 patients that are currently in boarder status in our emergency department that need placement. And so this is really a challenge for us in terms of flow and throughput within our emergency department. As a result of being underfunded for years, the daily cash on hand for Schneider Regional fluctuates between 2 days and 10 days throughout the month. So we do not have operational funding to make substantial payments on our accounts payable. SRMC's accounts payable has grown to $38 million. For reference, a hospital about our size and serving the community we serve would be comfortable with having about 100 days cash on hand. Frequently, for Schneider Regional, we have 2 days of cash on hand. That is not enough to make all of our vendor payments. It's not enough to make strategic investments. It's not enough to maintain our facilities. This makes it very, very difficult for Schneider to get supplies that are needed by our clinical staff on a consistent basis And there's frequent juggling of which vendors to pay for current needs, which vendors to pay to catch up on accounts payable, and needing to balance making payroll. We've also had insufficient investment in capital and facility repairs over the years. The budgets for SRMC year after year have included $0 for capital investment or facility repairs, no funding for depreciation. Because we've lacked capital investment for so many years, and because we're in an aged facility, we're continually faced with using operational funding to do immediate facility repairs. The Royal Leicester Schneider Hospital was built in 1982. The infrastructure is more than 42 years old. Although certain areas have been updated over time, we still operate with some of the original components that were installed when the hospital was first constructed. And further, the temporary modular structure that's been put in place at Myra Keating following the hurricanes was not designed to be a permanent solution, and that will need facility repairs until the new permanent MKS is built. While FEMA has obligated the money for the new facilities, it's going to be at least another 5 years, it's looking like, for the new hospital to be ready on St. Thomas, and probably about 3 years for a new clinic to be ready on St. John. Of course, we hope those timelines are shortened and it happens sooner, but we need to be investing and maintaining the facilities we have until those new facilities open. None of the FEMA money was approved to maintain the current hospital facility on St. Thomas or the clinic on St. John. And so SRMC needs the GVI to provide funding for that maintenance and replacement of some of the equipment that's within those facilities. We are working hard on our strategic plan for improvements at Schneider Regional. It can't all be the government supporting us. We have to do better to support ourselves. And I genuinely believe that Schneider Regional Medical Center has the ability to improve its operations and to achieve financial sustainability and have a very strong future if a few strategic investments are made. We're going to need help digging SRMC out of the current crisis, and we need to course correct, and that's due to years of underfunding. We need to do the following to course correct. First, we need assistance with paying down the AP. The GVI should earmark funding to help us with paying down the accounts payable that's owed by SRMC from not being able to pay its bills timely year after year because of not having sufficient coverage of the care and payment for the care we provide. We especially need to make those payments to local vendors and to our supply and staffing vendors. We're also asking that the GVI allow for some forgiveness of debt owed by SRMC to the GVI, specifically around GRS payments and old Division of Personnel health insurance payments on the employer side. The second thing that we need to do to help SRMC course correct is to invest in some capital repairs. Immediate funding for the maintenance of the facilities is absolutely critical. In our FY25 budget testimony, we emphasize the need for line item funding in the amount of $9.7 million for capital repairs and equipment, and we received $0 on that line item. Without this funding, there's no ability to do replacements and repairs to the interior and exterior of the buildings, to the AC systems, the generators, and to our major medical equipment. To ensure a safe environment of care and to maintain our accreditations, SRMC currently needs to spend approximately $500,000 on some immediate improvements. MKS also requires an investment of about $400,000 to bring the current infrastructure up to date. The third thing that we need to do to help Schneider get on good footing is to install some IT infrastructure updates. We need to invest in an enterprise-wide EMR that would serve both Schneider Regional and the Juan F. Hospital. It will have new features, including medical scribing and better charting, which is going to allow us to optimize and increase our billing and collecting. We know that we need to do better with billing and collecting, and we need a system in place that's going to help us do that. We have put systems in place to enhance our security, which is going to reduce the expense of downtime and reduce the expense around security breaches. And we just got to continue to make investments in IT. It's critical to the future sustainability and operability of our system. SRMC is going to generate significant additional funding and have less reliance on the GVI allotment in the future with a better IT system. The fourth thing that we need to do, and this lands a little bit more squarely on us than on the GVI, is actually just improving the billing and collections. As I mentioned, the EMR is going to help us to do that. But we have to continue to increase our collections by improving our revenue cycle. In 2022 and before, we averaged about $4 million in collections per month. We put a lot of work into revenue cycle, and we started to generate a lot more. So approximately 2/3 of the funds that we use to operate SRMC comes from the work that we do and the billing and collecting that we do in terms of collecting from insurance and patients. Approximately 1/3 of the funds that we use to operate comes from the GVI allotment. Aside from the impact of the 2 downtimes, we were on track to consistently improve our collections to between $5 and $6 million per month, which is a significant achievement and improvement for our hospital. And we look forward to getting back to that and even improving on that. We are engaging with third-party billing and collections agencies to look for opportunities to increase collections and to get help with identifying opportunities for process improvement, better coding, better documentation, better submission of claims, more timely filing, and less denials. We're also training our department leaders on managing their own budgets. We need to continue to work with JFL and the Government Health Insurance Board and this body actually to work to get new contracts in place with the insurance companies and payers, specifically the large government payers, and to work on the United Healthcare Medicare Advantage plan. SRMC needs to be better reimbursed for the care that we're providing. And we think that the GVI health plan should offer incentives and discounts for patients to receive their care within the territory's hospitals at SRMC and JFL. The fifth thing that we need to do, and again, this one falls more on us, is generating new revenue and improving service lines. So we're going to continue to expand our services and continue to recruit patients and better payers to SRMC for outpatient services. At RLSH, we do more than 15,000 patient visits through our emergency department every year, and we perform more than 1,500 outpatient surgeries and procedures. We're working to increase those volumes. At Myra Keating Smith, our volumes continue to grow across all of our service lines. And in FY24, we had more than 7,000 patient care visits at Myra Keating. We're going to continue to expand service options. We started with opening a gastroenterology clinic in October of 2023. It had tremendous success. With the addition of that service line, we're catching cancers earlier, we're saving lives. And it's a service line it's truly beneficial to the community, and it helps with revenue generation. We also have several other clinics that are going to be coming online this year and into next year. We've hired a full-time orthopedic surgeon who has specialty in spine work and pain management, who's going to be helping us to run a spine clinic. We're also reopening our cardiac catheterization laboratory to do interventional cardiology. That's going to help to address the high prevalence of cardiac-related health concerns within our community. And it's going to help us to avoid up to 30% of our transfers off island, which are for persons with cardiac issues. We'll be able to take care of them right here at home. We're working to strengthen our laboratory so we can expand our outpatient offerings through the laboratory. And all of these things are needed for the community, and all of them are also revenue generating for SRMC. So we acknowledge, part of our testimony today is to talk about the ER, and we acknowledge that our ER needs improvement. For context, emergency departments all over the country have long waits, and we're no different. But we want to be even better. And so we want to upfit the feel and flow of our emergency department by adding more fast-track bays and adding additional staffing. We know that somewhere between 30 and 40% of the presentations at our emergency department are not true emergency level care. They're more urgent care level and fast-track level type of encounters, and we can handle them more smoothly by expanding our fast-track area. Our ER is currently staffed with 3 permanent physicians and 2 rotating physicians. We also have 4 mid-level providers. We need to add 2 permanent ER physicians to get rid of the rotating coverage. And we need to add 7 permanent ER nurses to help to support the care that happens through the ER. Importantly, our ER delays are directly linked also to the border problem that we identified earlier in the testimony and that was spoken to earlier in today's hearing. Because we have 13 beds on the inpatient unit that are filled with and occupied with boarders, that means we're frequently unable to move admitted patients up out of our emergency department onto the floor, onto those units, because there's no available staff beds left. So then that clogs up the ER and creates lengthy days because you don't have space available in the back to bring patients through, and it really affects your patient flow, creating lengthy delays for patients that are waiting to get to the back of the emergency room for care. So we need definite movement on the border situation, and I heard the testimony earlier. I appreciate what my colleagues at Department of Human Services are doing, but I really want to emphasize to this body, it can't happen soon enough. It's not happening fast enough. We need additional beds opened, whether that's at Herbert Grigg, by adding beds and staff immediately, or by contracting for additional beds outside of the territory at Casa de Salud in Puerto Rico. But we need an immediate movement on that if we're going to improve the situation at the hospitals. So In conclusion, our team at SRMC is working hard to provide high-quality care to the residents of the Virgin Islands. SRMC does need additional funding to make up for the years that our system has been underfunded. We're focusing on ensuring that we have a safe environment of care for our patients. We want to continue to increase the community's trust in our hospital system and in the care we deliver. I can tell you we have very high quality care, excellent physicians, and really a good product. We have a lot of patients who have been to us and gotten great care, better than they've gotten even when they've gone off island and gone to the States. We're committed to improving and enhancing the physical infrastructure. We're committed to enhancing the services as best as we can while we wait for the new hospital. And we're very excited about the reconstruction of the Charlotte Kilman Cancer Institute. We thank the THRT and their executive director, Darrell Smalls, for all the work that's happening on Charlotte Kilman Cancer Institute. If you drive by, you can see the tremendous progress that's happening there. We're looking forward to providing radiation oncology to our community again. And we have to note, supplemental funding needs to be provided now for CKCI. It needs to be provided this year. We're on track to open that facility from a construction standpoint in November 2022. It takes 6 months to recruit these specialists that you need to work in it. We need to start recruiting for and onboarding the critical clinical positions that we're going to need to care for those patients. We don't want to open the facility and have a ribbon cutting, and we don't have the staff in place to provide the services to the patients. There was $0 allocated for CKCI in the past fiscal year budgets, and including this year's fiscal year budget, because CKCI was closed. But we really need to start working on some allocation now so that we can have the operations ready to go by the end of this calendar year. I want to thank our entire senior leadership team, our entire clinical team, our non-clinical team, and support teams for their continued hard work, their dedication to SRMC and the community. We have to retain our excellent staff, and we need to recruit where we have vacancies. And to do that, we have to keep pace with the market rates for these specialists. We need to continue to move our employees to step. We need to renegotiate several union contracts this year, including SIU, USW, and many others. We have 9 unions, and I believe all of them are due for negotiation this year. SRMC needs to be able to offer those competitive market salaries if we're going to continue to successfully recruit. And in order to pay those salaries, we need an appropriately funded allotment. I can tell you that the allotment this year, $32.7 million. If you take off the $3 million that we get, that's just the match for the Medicaid, that's about $30 million that's left. When you take off the health insurance withholding, you take off the WAPA payments, it's really only $1.6 million that's coming to the hospital each month through the allotment. Annualized, that's $19.2 million. Our salary and benefit expense alone is $60 million a year. And so that's not even including supplies, drugs, making payments on AP, making strategic investments. The hospital is being underfunded. The $19 million that we actually get a year is not covering the $44 million in uncompensated care we're delivering. We bill Medicaid $31.7 million each year because of the daily rate and how that's fixed at $405 for an outpatient encounter and $1,373 for an inpatient stay. You know, we're only getting paid $17.8 million. That's $14 million less than cost on Medicaid. So a lot of uninsured care, uncompensated care that's not being fully covered. Medicaid, a lot of Medicaid that's not being covered at the cost of care. And we have the challenges with Medicare as well. So we need more support from the government. We need to make some strategic investments. And with those strategic investments, we'll be able to do better on our own in terms of billing and collecting for the work we're already doing and adding new service lines that the community needs and helping to cover more of the uncompensated care on our own. So I look forward to continuing to working with this body, with the central government, and with my colleagues at JFL to improve healthcare for the territory and improve our hospital system. And I thank you very much for the opportunity to present today.
Thank you for your testimony, Chief Executive Officer Tina M. Commissiong, Esquire, MPA. Next, we'll move to testimony for Darlene Carty-Baptiste, CEO Wang Louis.
Well, a pleasant good afternoon again. Honorable Senator Ray Fonseca, Chair of the Committee on Health, Hospital, and Human Services, esteemed senators of this committee and the 36th legislature of the United States Virgin Islands, and members of the listening and viewing audience. I am Darlene A. Carty-Baptiste, the Chief Executive Officer of the Governor Juan F. Louis Hospital and Medical Center. Before we delve into today's testimony, may I take a moment to reintroduce myself to the community. Today I stand at 15 working days in this particular post, but yet I come with 25 years of experience in health, business, education, and have led projects across administration, budget, education, outreach, and case management. I have served in many jurisdictions, including Florida, the British Virgin Islands, the island of Anguilla, and here, my home in the U.S. Virgin Islands. In my previous roles, I've served as a Director of Practice Operations for the Advanced Radiation Therapy Department of the Orlando Health Cancer Institute, the Group Facility Administrator at the DeVita Kidney Care of Central Florida, Chief Executive Officer for the British Virgin Islands Health Services Authority, the Executive Director for the Acute Alternative Medical Group, which is our first urgent care center here in the island of St. Croix, the Territorial Employee Development Administrator for the Division of Personnel, Chief Executive Officer for the Health Authority of Anguilla, and most proudly, the U.S. Virgin Islands Health Commissioner. My vision for JFL is to foster a dynamic environment where we not only navigate uncertainty, but thrive in it. By cultivating robust internal and external collaborations alongside a strategic organizational framework, JFL will remain competitive and resilient, ready to seize the opportunities as they rise. I also want to express my sincerest gratitude to the Governing Board of Directors for their trust and confidence in my leadership. Joining me today in the well to assist with this testimony are the Interim Senior Vice President of Finance, Rosalie Javois, the Chief Nursing Officer, Doris Plaskett, Chief Legal Counsel, B. Patricia Welcome, Chief Human Resources Officer, Patricia Kennegator, and in the chambers, we have the Acting Chief Medical Officer, Dr. Regine Flipping, Chief of Staff, James Rollins, and key support administrative staff. Thank you. I take this moment to extend apologies for my fellow invited testifier, Chief Operating Officer Hazel Philbert, who is on pre-approved leave to address a family matter. Thank you for the opportunity to testify on JFL's strategic initiatives and efforts to address staff shortages, reduce emergency room wait, resolve the ongoing patient disposition crisis, and provide an update on accounts payable. I look forward to today's discussion wholeheartedly. When addressing the staffing shortages, we understand the impact there is on healthcare industry, and most of it will mirror what my colleague previously said, specifically to the Schneider Regional Medical Center. And it has a subject to much speculation. The shrinking population limited pool has contributed to the inadequate availability of trained healthcare specialists and help against this health-specific workforce. At JFL, addressing this shortage is top priority, particularly in three critical areas: nursing, allied health, and medical physician staff. Today, I will focus on these high priority workforce challenges and our efforts to strengthen recruitment and retention. Specifically to nursing, we have made remarkable strides in stabilizing our nursing workforce with a total of 22 full-time registered nurses hired in fiscal year 24 and fiscal year 25 to date. This underscores our commitment to excellence and efforts to reduce our reliance on travel nurses. Currently, we do not have any travel nurses. The successful completion of negotiation with the collective bargaining agreements within the Virgin Islands Licensed Practical Nurse Association, the Virgin Islands Nursing Association, and the Registered Nursing Leadership Union has significantly enhanced our ability to recruit and retain nurses. We are proud to offer competitive benefits and incentives to ensure our nursing salaries are on par with market compensation. We continue to focus on stabilizing our nursing staffing levels, particularly in critical and specialized areas such as the emergency room department, intensive care, and neonatology. These areas demand highly specialized nursing training and experience to provide optimum care for critically ill patients. To address this need, we continue to build our collaboration with the University of the Virgin Islands School of Nursing through the Graduate Nurse Residency Program. We have successfully onboarded 34 local nurses through this program to date. The Graduate Nursing Residency Program provides new graduates and inexperienced nurses with structured training and mentorship, allowing the opportunity to gain experience in different nursing specialties. By investing in mentorship, continued education, and staff development, we can strengthen our nursing workforce for the long term. As we move to allied health, these professionals provide specialist skills and services for comprehensive patient care. These professionals include surgical technologists, technicians, CT X-ray technologists, ultrasound technologists, echocardiograph technologists, and dietitian. They all play a vital role in ensuring that the diagnostic and surgical procedures run efficiently. With a deficit in allied health professionals, as observed nationally, JFL has supplemented the need for allied health professionals with agency staff. This is a borne cost to us. To address this, we entered negotiation phase with Seafarers International Union in June of 2024 to explore sustainable solutions. As this issue remains our priority, we're expected to reconvene negotiations in 2025. Completing these negotiations will empower us to develop competitive recruitment and retention strategies, significantly reducing employee turnover rates and position JFL as a competitor and a competitive employer for allied health professionals. As we look at our medical or physician staff, JFL continues to navigate the ongoing physician shortages. With 33 active physicians on staff, while some critically specialty positions remain unfilled. To help bridge this gap, JFA supplements this deficiency with locum coverage, ensuring continuing access to care. By February 21st, 2025, we have expended $520,726.03 in locums, with this outstanding balance remaining at $827,897.10 owed in individual locums, not including miscellaneous and staffing agency costs. Our first strategic goal to improve physician recruitment and retention is to set and to take shape as we work to redefining what the true compensation model should look like for JFL. We look forward to collaborating with our sister hospital on this very important initiative and to glean from their success. The most recent approval of our National Health Services Corporation site application has been a successful benchmark in our recruitment strategy. It will empower us to effectively attract and retain healthcare professionals through the NHSC programs that offer valuable loan repayment, scholarship opportunities, and other attractive benefits. This makes JFL a preferred choice for providers ready to serve in designated short areas and will be ready to adapt to any change in the national trajectory. Lastly, we will conceptualize a marketing strategy designed to attract medical talent, inclusive of the digital campaign through social media and direct engagement. We remain committed to implementing strategic initiatives to stabilize and strengthen our workforce, ensuring high quality care for our community. If we're looking at reducing emergency department wait times, it still remains a major priority for JFL's focus, as it would directly impact the quality and efficiency of our ED services and our community satisfaction. Recognizing that emergency room delays stem from multiple factors, we employ a multidisciplinary approach to tackle these issues. Understanding the testimony from block number 1 and from my colleagues, we understand the domino effect that the border has employed in these particular areas. But to drive significant improvement, we reestablished the Emergency Department Improvement Team, EDIT, committee in May of 2024, focusing on enhanced ED throughputs, the time patients spend from arrival to departure in the ED. This committee meets monthly and includes key departments from nursing, medical staff, quality, radiology, laboratory, executive leadership, patient access, patient experience, case management, and housekeeping. The EDIT committee evaluates and tracks essential data, including turnaround times from the ED visits, diagnostic testing, and imaging, left without being seen rates, and discharged against medical advice. The EDIT also focuses on refining the patient triage process. You heard my colleague talk about the fast track, optimizing our staffing levels to ensure they're on par, and streamlining the discharge process to create a more responsive and effective emergency room care system. We recognize several challenges affecting the patient throughout and the throughput. They are being actively addressed, including our financial and supply constraints, our shortages in the emergency room department. We currently have 5 full-time providers, laboratory, radiology, limited bed availability, the border crisis with close to 50% of our med-surg beds occupied by a border, and the increasing patient influx stemming from the Medicare coverage loss, which you've heard in greater detail this morning. Through our efforts with that committee, we are committed to finding effective solutions and improving our overall operational capacity. In addition to internal process improvement, public education plays a vital role in reducing the unnecessary emergency room visits. Many individuals seek emergency room for non-life-threatening conditions that could be better managed at urgent care facilities or even in the primary care clinics. Our strategy involves heightening the community outreach efforts to educate the public on when to visit the emergency room versus when to seek alternative care, and the process of how patients are seen based on their acuity levels. This initiative aims to reduce the overcrowding in the ED and ensure that those with the most urgent medical needs receive timely attention. Finally, we recognize that patient experience and communication are integral to improving emergency care. To enhance satisfaction and transparency, our strategy involves more patient experience touch points throughout the ED. These touch points include improved signage and regular status updates from our staff. By addressing these key areas, we are committed to reducing the ER wait times and improving the patient throughput. Currently, Senators, at the time of this presentation, preparation, JFL had housed 8 disposition patients. But as of today, we're at 9 disposition patients. And as stated earlier, we pay for 3 disposition patients that are housed at Casa del Salud, Puerto Rico, at an average of $5,100 monthly. And this agreement was entered in March 2020. These patients no longer require acute hospital care, but cannot be discharged due to the lack of available placements and guardianship issues. Their prolonged stay in the hospital significantly contributes to our bed shortage, again, the domino effect, impacting our ER wait times and our ability to admit new patients in need of critical care. Disposition patients incur a significant cost to our hospital that is not budgeted. Note that the daily rate for our med-surg unit averages $1,758.48, thus equating to $52,754.40 per month per disposition patient. And again, this does not include medication, supplies, staffing, and other overhead costs, and it is increasing as uncompensated care. The lack of community resources such as skilled nursing home, rehab centers, long-term care facilities, again, as discussed earlier this morning, will be more suitable for many of these patients, these border patients. Their care is needed based on their specific needs, and they really need recreation, socialization, of which we cannot offer, and this is a continued challenge. To facilitate timely placements, we continue to collaborate closely with the Department of Health and Department of Human Services through our regularly scheduled meetings to provide status update and discuss the plan for the disposition of patients. Again, 9 patients. These partnerships are essential to identify suitable facilities, securing the necessary resources, including capital, and streamlining the transitional process of these patients that require these specialized care beyond our current hospital setting. But despite these challenges, we have made progress. This calendar year, 2 patients have been successfully placed at the Herbert Grigg Home for the Aged, with 1 additional placement currently being pending. This demonstrates the effectiveness of ongoing efforts to find appropriate solutions for patients who no longer require hospitalization. However, the demands for placements continue to outpace their availability, requires continued advocacy, system-wide improvement, and cash infusion. We are seeing an increase in patients, particularly seniors and those with behavioral health needs, remaining in our hospitals without a clear care plan. Limited resources and caregiving challenges have been difficult for families to coordinate for long-term support, thereby leading to extensive hospital stays. Again, this places an undue pressure on our healthcare system, understanding it also places pressure on the families. To better support these patients, we must strengthen our policies, enhance coordination, and expand our community-based resources. Finally, public education is a critical matter. Many people are unaware of how these borders affect not only individual patients, but also the broader healthcare system. By raising awareness, we can encourage families, caregivers, policymakers to support sustainable efforts to prevent unnecessary hospital stays and ensure that all patients receive the proper care in the right environment. Through continued collaboration, advocacy, and education, we remain committed to addressing these challenges and improving patient disposition processes for the benefit of both the hospital and the community. I will speak briefly on the accounts payable for the JFL hospital. Throughout this testimony, we have highlighted several key areas that directly, in fact, impact our financial stability, particularly the uncompensated care. Notably, today we stand at accounts payables in the vicinity of $19.9 million, which is a significant decrease from the $54 million over 6 years ago. However, there has been a recent upward trend with our payables, particularly in fiscal year 23 and leading to the present. As the close of fiscal year 2024, our accounts payable stood at $17.8 billion, which has carried over from into fiscal year 2025 and rising an additional $2.2 million again as we sit and present to you a total of $19.9 million as of February 2025. I must concur with my sister facility as it relates to the request for assistance in addressing our indebtedness and the support of a procurement of a more robust EMR system that will help us help ourselves. We acknowledge the need for further process enhancements in our revenue cycle processes and support vendor commitment for supplies, medication, and services. This is a high priority focus for our hospital. To address this, JFL and SRMC collaborated on a joint RFP for contracted services to address the opportunities for improvement in optimization of billing, coding, charge capture, and ultimately collections. We are also working on immediate steps to address the cash flow challenges in our hospital. We literally meet daily to address them. This includes increasing our real-time collection for all medical services, itemizing review of our denial and rejection claims, right-sizing JFL through workforce productivity and evaluation, increased automation of our supplies management and inventory control, conducting a workflow analysis for the business administration and operations, strengthening internal controls and monitoring our claims process, and we are also revisiting our internal access to our clearinghouse. So in conclusion, despite the evolving healthcare challenges, JFL remains steadfast in its mission to drive improvement with compassion and respect, while implementing strategies and solutions to address our staffing shortages, our ER wait times, our patient disposition challenges, and our fiscal sustainability. We extend our deepest gratitude to our hard-working, dedicated staff, whose unwavering commitment ensures the best possible care for our patients. We also thank the Board of Directors for their leadership, the Governor and the Executive Branch, and for their ongoing collaboration, and to this legislative body for its continued support as JFL rebuilds today for a healthier tomorrow. We stand ready to answer your questions.
Thank you for your testimony, Darlene A. Carty-Baptiste, CEO Wang Louis. Next, we'll go to Christopher Finch, Secretary. Outgoing Chairman.
Good afternoon, Honorable Chairman Ray Fonseca, members of the Committee on Health, Hospitals, and Human Services, other members of the 36th Legislature, Senate staff, fellow testifiers in the listening and viewing audience. I am Christopher Finch. I'm the Secretary of the Virgin Islands Government Hospital and Health Facilities Corporation, more commonly known as the Territorial Hospital Board. I'm testifying today particularly on the conditions that lead to the high number of boarders in hospitals. This impacts on the emergency room wait times as well, which is another topic for discussion today. My testimony concentrates on the need for additional long-term care services for our increasing aging population to provide sufficient service alternatives such that it reduces the need for people to live at the hospital because they have nowhere else to obtain needed care. I wish to start by expressing gratitude to the members of this body for your interest in the well-being of the hospitals, and especially to the members of the Committee on Health, Hospital, and Human Services and Chairman Ray Fonseca and his staff for their work with the hospitals. I am joined today by colleagues, including Board Chairman Dr. Jerry Smith, Schneider Regional Medical Center CEO Tina Commissiong, and Juan F. Hospital and Medical Center CEO Darlene Baptiste in her third week as CEO, and the Hospital Redevelopment Team Executive Director Daryl Smalls. I was asked today to discuss a strategic plan regarding the borders. Other testifiers will and have focused on hospital-specific information. My testimony will focus on the larger issue of insufficient long-term care supportive services that creates the conditions that result in borders. I'll discuss potential avenues the Territory can take to start to address the situation. The impact of borders. Who are our hospital boarders? Boarders are human beings. They are people, mostly frail elderly members of our community who no longer have the ability to care for themselves and do not have sufficient family or friends to provide the care they need at home. They are people who came to the hospital originally for medical reasons, now no longer need to be in an acute care setting, yet cannot be discharged as they have nowhere to go that can provide the care they need. The hospitals have nowhere to transfer these patients to a more appropriate care setting. Since the hospitals cannot make unsafe discharges, the patients remain living in the hospital for free and become boarders. Let's be very clear on one point. Once a patient no longer requires hospital care, the hospitals cannot bill any third-party payers for continued care. We cannot bill Medicaid, Medicare, or private insurance companies if there is no medical reason for the stay. The boarders occupy our limited beds and receive free care. Since they are in a hospital setting, there are mandated levels of medical care they must receive daily. The hospitals continue to provide them with this care for no compensation other than from our annual GVI budget allotment. We lose all ability to make the revenue from the beds that would be earned from other patients. When we have large number of boarders, like now, occupying a significant number of our beds, this results in patients remaining in emergency room beds while they wait for an open bed within the hospital. This limits the spaces to see other emergency room patients and is one of the causes of increased wait times. Let's look at the current situation. JFL North Temporary Hospital has 21 medical surgical beds, essentially our adult general beds. These with 10 boarders, and you'll hear as you hear the numbers have fluctuated, 10, 9, 8, but 9 today. But so with 9 boarders, only 12 beds remain for the entire island. In the case of SRMC, the 13 boarders occupy almost 1/3 of their general adult beds. We cannot expect a hospital to be successful financially if we remove 1/3 to 1/2 of the beds they need to produce revenue. The lack of remaining available beds for the community not only means people backed up in the emergency room, but the loss of revenue means we have less money for supplies, staff, equipment, and repairs. For JFL especially, the lack of revenue has led to supply shortages, which leads to the cancellation of non-emergency surgeries as supplies are reserved for emergencies. Since surgery overall is a large revenue source, the cancellation of surgeries means lost revenue and our challenges increase. Presently, SRMC has 13 boarders and JFLH has 9 boarders for a total of 22 boarders. Why? How did we get here? What can we do? We'll start with aging of the population. The boarders are one result of our need for additional long-term care supportive services. The Virgin Islands population has become dramatically older, and we have not kept up with increased need for services for frail seniors. In fact, we have lost some service capacity since Hurricanes Irma and Maria, especially some of our already too few nursing home beds. I've been making speeches and testifying to the need for more long-term care services for years, first as Executive Director of Lutheran Social Services, then as Commissioner of DHS, and now as a hospital board member. With the rapid growth of the number and percentage of seniors in our population, the need for services for that age group has increased fast. Let's look at some statistics that demonstrate this aging of the population. Table 1, and I have a lot of graphics, and I apologize to the listening and viewing audience that they won't be able to see this. But Table 1, created by the Federal Reserve Bank of St. Louis, uses World Bank data to track the increase in USVI seniors 65 and older from 1960 to 2023. It measures the percentage of the total population occupied by seniors. In 1960, seniors constituted 6.2% of our population. Following this was a 3-decade drop to a low point of 3.6% in 1971. It was not until 1991 when the percentage of 65 and older people exceeded the 1960 percentage of over 6% of the population. From then on, the number of seniors grew rapidly, as can be seen by the upward curve in the table. The Federal Reserve Bank of St. Louis estimates that by 2023, the USVI 65 and older population was 22.2% of the total population. Table 2 shows information from each U.S. Census from 1980 through 2020. I decided for today's testimony to dive deep into the censuses that have been done during the last 40 years to demonstrate the growth of our senior population. In 1980, 4.6% of our population was aged 65 and older, or 4,475 people, out of a population of 96,569. By 2020, that number jumped to 18,541 people, or 21.3% of a declining population of 87,146 people. We see similar rises in the percentages of people 75 years and older and 85 years and older. In 1980, 1.4% of our population was aged 75 and older. In 2020, it was 8.6% of our population. In 1980, 0.3% of our population was 85 and older. In 2020, it was 1.8%. For each age range, it was over a 500% increase over the 40-year period. As the number and percentage of older people increases, they need additional services targeted at their age and needs. According to the Federal Department of Health and Human Services, 56% of adults 65 and older will require long-term support with an average projected duration of 3.1 years. I'm certain we will all agree that the services available for older people in the Virgin Islands have not kept up with increases in population. Boarders are people who need either extensive home-based care or a long-term care bed in an assisted living facility or nursing home. For clarity and definition, let me explain that both assisted living facilities and nursing homes provide 24-hour, 7-day-a-week care, a major difference being that nursing homes have additional medical services. A key number to consider when planning for long-term care bed capacity needs is the number of people in the community aged 65 and older. While an official consensus on long-term care bed need doesn't seem to exist in the senior care industry, a general rule of thumb is that a community should have long-term care bed capacity for a range between 3% and 5% of its population aged 65 and older. Studies of the number of people stateside living in nursing homes and other long-term care settings support that 3% to 5% range. A recent study showed the United States 65 years and older population at 55.8 million people, with 2.1 million, or 3.8%, living in nursing homes or assisted living facilities. Another 2020 U.S. study from the Center for Disease Control reported 1,016,400 people living in assisted facilities and 1,300,000 in nursing homes. Combined, that equals 4.2% of the U.S. senior population. And indeed, the number of nursing homes in the U.S. is equal to 5% of the 65 and older population. Table 3 shows the information from the 2020 census on the number of people in the USVI aged 65 and older and the number of long-term care beds we would need to support that population at the 3% and 5% targets. With 18,541 people in the Virgin Islands 65 and older, using the yardstick of 3% to 5%, we would need 556 to 977 long-term care placements. We have a small fraction of that number at 74 beds in our territory. Table 4 shows a change in the number of local assisted living beds and nursing home beds from just before Hurricane Irma to now. We lost 40 beds as our numbers dropped from 114 to 74 beds. And certainly this is not a complete number of long-term care placements, since the Department of Human Services has placed and is paying for additional people out of the territory, as was described in testimony earlier today. Even Juan F. is paying, and it's actually $15,300 a month, for 3 former boarders that placed years ago at a facility in Puerto Rico. Short-term solutions. The easiest short-term solution for the present boarders would be give DHS the funds to place them in good facilities out of the territory. This would cost $65,000 to $100,000 per person per year. Since some qualify for Medicaid, the cost would be far less for those boarders, assuming DHS has the fiscal capacity under its federally imposed Medicaid cap. However, with such a large unmet community need, the border population would likely increase again. I'm certain DHS will be describing its long waiting list for beds, and actually DHS provided information on that earlier today. A few months ago, JFL was down to 3 boarders. In a short time, the number increased to 11 and is now at 9. Funds can also be provided to DHS to maximize the bed space at the Herbert Grigg home now, and soon the Queen Louise home for the aged when it is renovated, which I understand will be not too long from now. Those two actions would add as many as 24 beds to our local capacity. I understand there's interest in making this happen. The commissioners of the Department of Health and the Department of Human Services and their staff hold weekly virtual meetings with hospital leaders and staff to discuss specific border placements. The hospitals are greatly appreciative of this initiative and the efforts to prioritize border placements. Thank you, Commissioner George, and thank you, Commissioner Encarnacion, for your leadership on this. Long-term solutions. If our border crisis stems from a dearth of long-term care services for an increasingly elderly population, the long-term solution lies in creating as complete a continuum of care as we can. Long-term care is not just nursing home care. It is far more complex and multifaceted. A comprehensive system of long-term care supportive services envisions a range of services from home-based to institutional. The major advantages of having this continuum of care include the ability to offer people services where they want to be, which is most often in their own homes, the ability to offer individualized services where people get the assistance they need while retaining the ability to self-manage as much as possible, and the ability to treat people in less expensive settings, thus reducing the cost of the most expensive service settings, which are nursing homes. The elements of a comprehensive long-term care service system include, under home and family-based services, homemaker care, providing personal assistance with activities of daily living, such as bathing, personal hygiene, dressing, toilet hygiene, functional mobility, self-feeding, home-delivered food, such as Meals on Wheels program, home renovations, such as adding wheelchair ramps, widening doorways to accommodate wheelchairs, renovating bathrooms and kitchens for accessibility, and providing assistive technology for remote monitoring of healthcare, emergency call devices, et cetera. Second version of long-term care home health care includes such services as visiting nurses and other medical professionals, providing afforded needed medical equipment to the home, special beds, wheelchairs, other assisted devices, oxygen, et cetera, home dialysis, and providing telemedicine services to the home, including patient devices that allow remote monitoring. Third aspect of long-term care are paratransit transportation services with door-to-door services. A fourth is support for family caregivers, including education and training on best practices in providing care and assistance, emotional support groups, respite care, plan on the emergency basis for family caregivers to get time off. A fifth aspect of a comprehensive long-term care continuum are senior daycare. These are often drop-off day centers able to provide care for frail elderly persons, freeing caregivers to run errands or work. A sixth aspect is service-enhanced independent living housing. The Virgin Islands has several government and nonprofit senior independent living rental communities which provide a range of assistance as their residents grow frailer. Having numerous seniors living in close proximities makes these sites affordable locations to deliver a range of services that help people remain living independently longer. This has perhaps been best demonstrated locally in the Flamboyant Gardens and Ebenezer Gardens senior housing communities owned and operated by Lutheran Social Services of the Virgin Islands. Services in these independent living communities can include daily well-being checks, social work coordination, nursing case management, daily medication management, transportation for doctors, shopping, socialization, homemaking, assistance with activities of daily living, socialization, and even daily community meals. Seventh aspect of a continuum of care include rehabilitation facilities. These are 24-hour staff facilities providing rehabilitation care post-surgery, post-accident, et cetera. Medicare pays for such care for up to 100 days. These are not a long-term care solution per se for boarders because they don't provide custodial care. However, the care they provide can help a frail person recover sufficiently to resume self-care. Eighth, assisted living homes, 24-hour staff residential facilities in a non-medical setting, providing meals and assistance with activities of daily living. And then finally, probably what we're most familiar with, 9th, nursing homes, 24-hour staff facilities, and a medical setting. The Virgin Islands has or had at one time many elements of the long-term continuum of care I just described. We just do not have nearly enough of most of the service elements, especially since the number of seniors have risen far more quickly than we have added or increased services. Figures 1 through 4 provide a visual description of the services that may be included in a robust continuum of care for long-term care services and support. They're divided into home-based care, Figure 1, support for family caregivers, Figure 2, creating service-enriched senior independent living communities, Figure 3, and 24-hour facilities, Figure 4. My hope is that this visual aid helps provide a roadmap for policymakers, funders, and service providers. And since I've largely described what's in the figures in my description of the continuum, I will skip ahead to page 13. Funding long-term care services. In 2023, the Congressional Research Service put out a newsletter as part of their In Focus series titled, Who Pays for Long-Term Services and Supports? This newsletter provided statistics from 2021 showing Medicaid and Medicare as the first and second largest payers, accounting for a combined 64.1% of all long-term care supportive services spending. The largest share was paid by Medicaid at 44.3%, with Medicare providing 19.8% of the funding. Including other federal programs such as the Veterans Administration, the federal plus the federal state public share amounted to 71.4% of all spending. The next largest categories were individual out-of-pocket spending at 13.6%, private insurance at 8%, and other private, which is mostly philanthropy, at 7%. And those are shown in Chart 1. I will delve into Medicaid and Medicare a bit more deeply. If these programs pay 64% of the cost stateside, we should investigate if we can make better use of them here. I'll start with Medicare. Medicare pays for post-acute services like skilled nursing facilities and home health services for a limited time, usually not exceeding 100 days. It does not pay for long-term custodial care. Some patients who are considered unsafe discharges and remain at the hospital would benefit from the physical therapy and other rehabilitative services offered at such facilities. When Seaview was operating, it had 15 to 20 beds devoted to skilled nursing care, providing post-acute care rehabilitation services. There is an opportunity for the hospitals or others to develop skilled nursing units to allow for funded, time-limited post-surgery care for persons who do not have the needed home supports. Similarly, it's also possible for the GVI to assist with subsidies for the hospitals or private agencies providing Medicare-funded home care to make that service affordable or profitable. These services would provide a federal funding source and may alleviate part of the border problem. Medicaid is a major payer for institutional long-term care such as nursing home and more recently for an array of home and community-based services. Reports indicate that 2/3 of the people living in nursing homes depend on Medicaid to pay for their care. For the federal Medicaid program, long-term care costs represents about 33% of all Medicaid spending nationally and has steadily increased to a level of around $200 billion a year for the 94 million Americans who receive Medicaid benefits. Our percentage of Medicaid spending on long-term care is far lower than the national average. In the Virgin Islands and other territories, we have a unique challenge that the states do not have. That is our Medicaid cap on annual federal expenditures. In recent years, the Department of Human Services has been at the cap or exceeding it. Up to the cap, the federal government pays 87% of costs, and the local government share is 13% for Medicaid recipients. Once costs exceed the federal cap, the percentage shifts negatively for us to 0% federal and 100% local. If DHS is already spending the entire amount of annual federal allotted Medicaid funds up to the cap, then there is no extra money to pay for long-term care, even if we get our institutional programs to be CMS certified and we add new home and community-based Medicaid programs. It cannot be emphasized enough that we must all work towards getting the Medicaid cap eliminated or at least sufficiently increased for us to get as much federal assistance to pay for additional long-term care services. And Senators, I must add, you know, I wrote that line, and even as I wrote those lines, I know federally they're looking at putting a cap on all the states. So, but we can hope, and this has to be the plan. Conclusion. I was invited to testify on a strategic plan to address the border crisis and long waits in the emergency room. These are both very important to the hospitals. We want to treat patients who come to our emergency rooms timelier. The hospital CEOs will or just did testify in more detail to their ideas. We want the boarders to be able to move home with services or to a more appropriate care setting than an acute care hospital. A hospital is simultaneously both an inappropriate and the most expensive setting for someone who has no medical reason to be there. And I'll say as a side, you've heard much testimony today that the long-term nursing home costs are about $100,000 per person, and you've heard both hospitals testify that the cost of leaving that person in the hospital is over $500,000 a year. One key reason for the emergency room waits is people admitted to the hospital who are waiting in an emergency room bed for a bed to be available for them. We have fewer beds than we should have available due to the number of boarders living in them. When I last testified to this body, specifically on the boarders in September 2022, we had 18 boarders. In May 2023, during Senate testimony, I reported we had 16 at that time. Today, we have 22 boarders. At the 2022 hearing, I testified that if the boarders moved into the then not yet open JFL North, that would represent a huge problem for the hospital. Unfortunately, that has come to pass. An immediate short-term solution is to find funds for DHS and place the boarders out of the territory. A little longer solution is to provide DHS with the funds to fully staff the entire bed capacity it has in its 2 nursing homes. These actions can provide temporary relief but do not address our lack of capacity issues. To fully address the need for services and to greatly reduce the potential border population, we must increase our long-term care services. Through this testimony, I provided information on how our population has grown older and what a continuum of care would involve for a long-term care service system. I am planning a conference for the public, nonprofit, and for-profit providers in the VI, providing different parts of the long-term care continuum from home-based services to nursing homes. The goal is for the providers to know each other, be better able to make referrals and coordinate services, and to share knowledge as to challenges, assets, and opportunities to begin to develop a long-term supportive services continuum of care plan for the Virgin Islands. This concludes my testimony. I thank this body for listening. I thank the men and women working in our hospitals, along with my colleagues testifying today, for their dedication and service to us all. I'm available for questions at the appropriate time.
Thank you, Mr. Christopher E. Finch, Secretary for the hospital's Territorial Health Facilities Corporation. Next, we'll go to Dr. Jerry Smith, the Chairman of the Territorial Hospital Health Facilities Corporation.
Good afternoon. I'm not sure if there's anything else to be said. I think we can go ahead and leave now. Yeah. I'll do my part. Well, good afternoon, Honorable Senator Ray Fonseca, Chairman of the Committee of Health, Hospitals, and Human Services, committee members, and other senators of the 36th Legislature, and to the listening and viewing audience. My name is Dr. Jerry Smith, and I'm honored to serve as a newly seated Chairman of the Virgin Islands Government Hospitals and Health Facilities Corporation. As of today's hearing, I've held this position for 5 days. However, prior to becoming chairman, I served as the vice chairman for the Territorial Board, the chairman for the Human Resources Committee, vice chairman for the Finance Committee, and member of the Performance Improvement Committee. And I also serve as the chairman for the St. Thomas St. John District Hospital Board. It is my pleasure to testify before this esteemed body regarding the pressing healthcare challenges facing our territory. I would like to first acknowledge the testimony provided by my predecessor, Mr. Christopher Finch, who has presented a historical perspective of our system's challenges, particularly the impact of an aging population and the lack of long-term care beds, and the resulting border crisis. I also appreciate the insights shared by CEO Tina Commissiong of Schneider Regional Medical Center and CEO Darlene Baptiste of the Governor Wang Louis Hospital and Medical Center, who have outlined their respective operational strategies to address these challenges. My testimony today would build upon these presentations, focusing on the broader systemic implications of strategic recommendations to enhance patient care and financial sustainability. One of the most urgent issues we face is extended wait times in the emergency rooms. This problem is directly linked to the border crisis, as you've heard many times today. The situation where patients having completed their acute care hospital stay remain in our facilities due to a lack of appropriate discharge destinations. This crisis not only affects patient well-being, but also places immense strain on our hospitals' operational capacity and financial stability. Patients have been known to be hospitalized for periods of up to 5 years beyond their recommended acute care stay. This is a historical and present-day problem that exacerbates the issues faced by our healthcare system. Reduced capacity within our hospitals has a cascading effect. When acute care beds are occupied by patients who should have been transitioned to long-term care or rehabilitative settings, the emergency departments experience significant overcrowding. This results in prolonged wait times, negatively impacting patients' outcomes, increasing the risk of complications, and diminishing the overall efficiency of hospital operations. Furthermore, this congestion reduces the throughput of the emergency department, leading to a decline in revenue generation for the hospital. Similarly, the operating room, a major revenue center for any hospital, suffers from this crisis. Elective surgeries, which constitute a substantial portion of hospital income, are frequently postponed or canceled due to bed shortages for post-operative recovery. This not only affects hospital revenue, but also compromises the quality of care for our residents who require timely surgical interventions. Beyond these immediate concerns, the financial ramifications of the border crisis extend to the procurement of essential medical supplies. As revenue shortfalls persist due to the reduced operational efficiency, hospitals face increased difficulties in maintaining adequate stock levels of critical supplies. This exacerbates an already challenging situation, leading to further cancellations of procedures and an overall decline in the quality of care delivered. While my colleagues have provided a very detailed, breakdown of the measures being taken at the facility level, I wish to highlight the necessity of a comprehensive territory-wide strategy. Addressing the border crisis and emergency room wait times requires a multi-pronged approach that includes: 1, expanding long-term care and rehabilitative facilities. This is an urgent need to develop and fund additional long-term care and skilled nursing facilities to accommodate patients who no longer require acute care but still need medical oversight. 2, strengthening community-based care. This is enhancing home health services and community-based care programs which can facilitate earlier discharges and reduce the burden on hospital facilities. 3, policy and legislative support for alternative care models, collaborating with policymakers to develop sustainable funding models for long-term care solutions will be critical to alleviating systemic bottlenecks. 4, investment in workforce development. So that's addressing staffing shortages across all levels of care, including nurses, therapists, and support staff, is fundamental in improving patient flow and reducing wait times. And lastly, leveraging technology and telehealth. Expanding telehealth capabilities and remote monitoring programs can facilitate post-discharge care, reducing readmissions, and enhancing patient outcomes. Additionally, it is imperative that we transition towards a value-based healthcare model to improve health outcomes and cost efficiency. In the 2020 USVI Community Health Assessment, It identifies significant healthcare gaps, particularly in chronic disease management, mental health services, and emergency care. A value-based system aligns reimbursement with improved patient outcomes rather than volume-based care, ensuring that resources are utilized effectively to improve the overall health of our population. By prioritizing preventative care, chronic disease management, and community-based interventions, we can reduce the burden on emergency departments and acute care facilities while enhancing long-term patient well-being. In the early days of my leadership, I will convene the board with the assistance of EY healthcare consultants to produce a far-reaching strategic plan. Among this plan must include the idea of a cohesive territorial healthcare system. Long gone are the days where the 2 district hospital boards individually ran each of the hospitals and the territorial board met quarterly in a bitter clash. Today, I am happy to report that the period of time in which each district board not having a quorum forced the territorial board to function as a single organizational policy and oversight board. I call for the abolition of the district board and the idea of a territorial board in name and function, and the birth of a cohesive healthcare system with a centrally guided ecosystem for its leadership. This shift represents opportunities for efficiency, cost savings, and improved care for the people of the Virgin Islands. I urge the members of this esteemed body to consider legislative solutions that would remove or reduce existing hurdles for hospitals to garnish or acquire assets belonging to border patients who remain hospitalized long beyond their acute care period. Establishing a clear legal framework for cost recovery would enable hospitals to better allocate resources and maintain financial sustainability, ultimately ensuring that the quality of patient care is not compromised. The Virgin Islands Government Hospitals and Health Facilities Corporation is committed to working in partnership with the legislature and our healthcare stakeholders to implement these solutions. By addressing the structural deficiencies within our healthcare system, we can create a more sustainable and efficient model and care that meets the needs of our community while ensuring fiscal responsibility. I really appreciate the opportunity to present this testimony and welcome any questions from the committee. Thank you for your time and dedication to improving healthcare in the U.S. Virgin Islands. Thank you.
Thank you. Thank you, Dr. Jerry Smith. New chairman, the whole 5 days of it, Popa, of the Government Hospital and Health Facilities Corporation. Next, we'll move to St. Thomas, and we'll receive testimony at this time from Darrell A. Smalls, professional engineer, Executive Director, Territorial Redevelopment, Hospital Redevelopment Team. Mr. Smalls, you may proceed.
Good afternoon, Honorable Senator Ray Fonseca, Chairman of the Committee on Health, Hospitals, and Human Services, Honorable Senators of the Committee on Health, Hospital, and Human Services, other Honorable Senators of the 36th Legislature, Senate staff, fellow hospital testifiers, and the listening and viewing audience. My name is Darrell A. Smalls, Executive Director of Facilities and Capital Development for the Territorial Hospital Redevelopment Team, which I serve under the leadership of Chairman Dr. Jerry Smith of the Virgin Islands Government Hospital and Health Facilities Corporation. If I may, I would like to take a quick moment to publicly thank the former Chairman, Christopher E. Finch, for his unwavering support to the Territorial Redevelopment Team for the past 4 years. I would also like to welcome and look forward to the continued collaborative and steadfast support of our new Chairman, Dr. Jerry Smith. Thank you for this opportunity to testify today before the Committee on Health, Hospitals, and Human Services with respect to the recovery efforts as it pertains specifically to the designs, including final completion, target dates of the Governor Juan F. Hospital and Medical Center, Schneider Regional Medical Center, and the Myra Keating Smith Community Health Center. As the Executive Director of the THRT, my primary role is to manage and oversee the planning, programmatic design, final design, bidding, project management, construction, procurement, and closeout for the redevelopment of our facilities to include JFL, RLS, CKCI, and MKS. In recent testimony you received last week from Adrienne Williams-Octolin, the Director of the Office of Disaster Recovery, you were provided an update as to the efforts of her office and the Super Project Management Office in spearheading the project bundling efforts for the island of St. John, which includes the Myra Keating Smith Community Health Center, as well as the soon-to-be resolicited Governor Juan F. Louis Hospital and Medical Center, and the upcoming solicitation for the Governor Roy L. Schneider Hospital. During my last testimony before this committee, I reported on several important milestones that had been completed, in addition to those that were anticipated to commence. Since the inception of the Territorial Hospital Redevelopment Team, we have had great success despite the many challenges we have faced. Shortly after the hurricanes of 2017, we successfully completed modifications to the interim healthcare facility that was originally provided by the Army Corps of Engineers on the island of St. John in 2019 at a cost of $433,513. We recently completed the mechanical building and systems to facilitate the opening of JFL North in 2023 at a cost of $11,863,521. We were assigned the task to complete the much-needed repairs to facilitate the opening and transition of patients and patient care into JFL North from the Governor Juan F. Louis Hospital in 2023. We successfully completed the clinical administration building for outpatient care services for JFL North in 2024 at a cost of $7,200,379. We successfully acquired leased land adjacent to JFL North to provide on-site parking for staff and visitors, a critically needed building for on-site storage for food and medical supplies, medical record storage, and support services for facility maintenance, wherein we will soon issue the notice to proceed for the construction to commence in less than 30 days at a combined cost of $36,912,037. We successfully completed the solicitation and selected a contractor who will soon commence with the renovation of an existing facility to house the interim dialysis functions on St. Croix at a combined cost of $8,281,670. We are currently awaiting approval of a cost alignment to secure the required funding to complete this work effort. The THRT, in collaboration with the Territorial Board and the leadership of the Schneider Regional Medical Center, are also pleased to report that the reconstruction of the Charlotte Kimmelman Cancer Institute remains on schedule, and we continue to make great progress. We maintain an active construction project at a cost of $32,523,105. We have also solicited and contracted for the Linear Accelerator and CT simulator at a combined cost of $3,971,241. We continue with other vitally important solicitations to include low voltage, signage and wayfinding, minor medical equipment, FF&E, IT equipment, and security systems, to name a few, which will ensure all items are procured and received timely for the projected completion of November 2025. I'd like media, if you could share a presentation that I just wanted to show some of the progress of the CKCI. We issued shortly after the issuance of the notice to proceed in March of 2024, what we're highlighting here is what has been completed to date. What we're highlighting here is some of the information that took place in early 2024 and where we stand today in 2025. And what I'm really highlighting here is the aggressive schedule and commitment of the team to ensure that the CKCI is completed on schedule. And again, just a highlight here, this is just a vision of what is to come for the Governor Juan F. Louis Hospital and Medical Center on the island of St. Croix, as well as what the Charlotte Kimmelman Cancer Institute will look like in the very near future. Thank you. To date, the THRT has successfully completed and is in the process of completing projects that exceed more than $101,185,469 in hurricane-related disaster recovery efforts, a testament to the hard work, tenacity, dedication, and commitment of the Government Hospital and Health Facilities Corporation, the Governor Juan F. Louis Hospital, the Schneider Regional Medical Center, and the THRT. The THRT, the Territorial Board, and the executive leadership teams of both JFL and SRMC remain committed to working collaboratively to develop the standards for from a systematic perspective to ensure that the medical and clinical programming efforts are standardized throughout our respective facilities. This is vitally important for the sustainability, resiliency, operability, and maintenance of these major investments. Once completed, our facilities will be state-of-the-art healthcare facilities for the people of the Virgin Islands, as our residents deserve no less. As I conclude my brief presentation, I would like to thank the Government Health and Hospital Facilities Corporation, the executive leadership of both JFL and SRMC, the employees of our hospitals, and the numerous public and private supporters for their acknowledgement and appreciation of the efforts of the Territorial Hospital Redevelopment Team. And to the consummate professionals of the THRT, I thank you. This concludes my presentation. I will remain available to answer questions you may have at the appropriate time.
Thank you, Mr. Darrell A. Smalls, professional engineer, executive director, Territorial Hospital Redevelopment Team. Next, we'll receive testimony from Mr. Edgar Phillips, Virgin Islands resident. Mr. Phillips, you may proceed with your testimony.
Good afternoon, Chairman Fonseca, all senators, viewing and listening audience, and all those present. My name is Edgar Baker Phillips, Executive Director of the St. Thomas Stroke Support Group, INC 501(c) organization. Also a resident of this community for over 72 years plus. I would like to thank you for inviting me here today to talk about my sister Doris and my experience with the Roy Lester Snyder Hospital. First, let me give you a quick report on my sister Doris. She's a 17-year-old Virgin Islander who was recently diagnosed with schizophrenia. She resided off island for approximately 20 years, and the family was not aware of her location. She returned to St. Thomas in 2020 and refused medical care. If I had known about the Baker's Act, I believe I would have been able to help my sister at that particular time. And I believe residents of this Virgin Islands should be aware of the Baker's Act to help medical and mental patients here in the territory. She erected a tent on the family property and decided to live there. On January 25th, I received a call from my sister neighbor who informed me that they had not seen my sister for many days and her yard was unkept, which they had never seen before. The neighbors felt something was wrong. On January 26th, I went to the hospital to find out if she was admitted there. Informed by the hospital personnel at the front desk that my sister was not hospitalized at the hospital. Since I was unable to locate my sister, I decided to file a missing person report with the Department of Public Safety. A silver alert was sent out by Public Safety while she was in the morgue. On January 27th, I received a call from another neighbor of my sister who informed me that my sister was taken by ambulance to the hospital approximately 2 weeks prior to January 27th. I contacted EMS to confirm if this information was verified by my sister, Doris, was transported by to the emergency room at Schneider Regional Medical Center. I was advised to contact the nursing supervisor at the hospital for additional information. Contact the supervisor, who informed me that the emergency room physician will contact me. The physician did call and reported that my sister was brought to the emergency room on the 9th of January and died the same day from a bleed. According to the physician, they were unable to contact individuals who was listed as next to kin. The individual who they reported that they contact said she never received a call from the hospital. This was not the first time that my sister was hospitalized at Schneider Regional Hospital, and they could have looked back and determine who was her next of kin then, or they could have filed a report with public safety. Additionally, I went and picked my sister's belongings up. Her bag had numerous pieces of identification. Also, I encountered a problem obtaining my sister's death certificate to enable the family to plan her funeral. The process is quite lengthy. She was in the morgue for 2 weeks, but the document was not signed by the physician. It was signed the following day, sent to the funeral home. Then the funeral home had to send it to Vital Statistics, who needed 5 to 7 days to record the information and return back to the funeral home. The funeral home then forwarded it to the family for review. It is returned to the funeral home, who will have to return the document if an error is in the document. That is cumbersome. I found out that my sister had a bank account with funds for her funeral, but there was no beneficiary listed. But Title 15, Section 89, Payment for Death and Funeral Without Administered, provides a guide on how this is handled. The bank determines how much will be provided. Even if the invoice are provided and there is sufficient money available in the bank. According to the bank personnel, a repast is not considered a part of a funeral, neither an organist. This title also states that a family member has approximately $10,000 for burial for any family member. If that money is in the bank and you can't spend it, something is wrong with that picture. Thank God the family was able to pull together and bury my sister. My concerns were as followed. No notification to next of kin or family members of death of a loved one. She was taken to the emergency room by the ambulance. Therefore, they were aware of where she was living. The process of obtaining a death certificate is too cumbersome. Why is the bank determining what is considered a part of a funeral, even though the funds are available? I would like to thank this body for allowing me to share my experience as it relates to my sister's death. I'm available for any questions this body may have or solutions concerning this situation, like a better protocol at the hospital, better service with obtaining death certificate, an amendment to Title 15, Section 89 to add a repast, organ and entertainment service, which is a part of burial. Thank you, and I stand ready for any questions you may have.
Thank you for your testimony, Mr. Edgar Phillips, Virgin Islands residents. So colleagues, we've heard the testimony of several of the persons that is in charge of our health, our hospitals and health in the community. And we're gonna go to a round of 6 minutes each. I'm going to start with the Vice Chair of the committee, the Honorable Senator Lorenzo Fredericks. Senator Fredericks, you're recognized for your 6 minutes.
Good afternoon again, everyone. Thank you, Mr. Chair. I want to first go to you, Chairman Dr. Smith. In your testimony, you said something that piqued my interest. You talked about the possible consolidation of the boards, which is something new. The discussion has been ongoing for quite some while, but you actually mentioned it, I guess because you're new. It's going to open up Pandora's box, but nonetheless, why do you think that's a good idea?
Thank you very much, Sir Jerry Smith. I think it's not new, actually, and I'm not new enough not to know that this is going to be a big deal and a big source of contention, potentially, and dialogue. I think it's the way we function now. My entire time on this board, which is the last 3 years, we have not had functioning district boards. We have been functioning as a committee under the territorial board. Any decision, and I put that in quotation marks because we couldn't legally have a decision until recently when the act was updated, giving us quorum. All matters were then forwarded to the Committee of Jurisdiction of the Territorial Board and then forwarded to the full board for approval. So we have been functioning that way, except adding multiple layers of busy work for years. So what I'm proposing in this is just removing a layer that is somewhat unnecessary.
Which is the elimination of both district boards.
Yes, and the reason why it's extra necessary is because it allows for one cohesive system. If you look at historically, the St. Thomas and John District Board really informed the way Schneider Regional Medical Center developed, and the St. Croix Board informed the way the Governor Wang Louis Hospital developed, and which caused two completely different hospitals that have different systems, have different policies, have different organizational structures, very, very different organizations, and that just simply does not work.
So because of that mindset, the historical mindset, our cost structure for both hospitals are upside down. You have one hospital where their accounts payable, Ms. Commissiong, she said her accounts payable were like $38 million. Wang Louis is right at 9.7. That's day and night. One hospital operates out of a modular unit. One still operates out of a, 6-story building? So clearly, we 5-story building. We need to look at that, look at the damage that was done. Why did it take so long for us to come up with this suggestion that maybe we should consolidate? Our cost of operation is high. If you look at the purchasing price for medication, for supplies, everything is so high, but we don't get a discount because guess what? We purchase separately. What was the board thinking back then? What are they thinking now? Why keep this system that's failing both hospitals? I know today everyone is blaming the borders, as being the main reason why both hospitals are in the state they're in, but before that they existed. This is not new.
Sir, I agree with you, and maybe because I'm so young and so easy, so new in this, that I'm naive enough to tell the truth. Right? I'm naive enough to tell the truth. And really what it comes down to is the way the divide in the territory exists between the two districts. And we have to stop that thinking. We have to think as one people and create one system that works well.
So let me go straight to the new big person. Everyone is new. CEO Carty-Baptiste. help us out here. So you're new to the job. You came into a situation where, thank God, you have some old help that's familiar, you know, some veteran help. Let me put it that way, not old.
Thank you.
You've got some great people that I'm familiar with. What are we going to do in the short term to turn things around at Juan Louis? Because we're still in that modular. We're not sure if we'll be able to get all that $900 million from the federal government. And we can't find someone who wants the demolition of the building. What are we going to do?
Darlene, Carty-Baptiste, CEO of Juan Louis. As I alluded in my testimony, a lot of it comes back for us being better stewards to the funds that's given to us. So that is what we're going to do in reference to right-sizing the organization. So what does that entail? Looking at the productivity level of all of our employees and evaluating the functionality. I also alluded to the fact of the business office operation and administration. Starting on Monday, we have performance review for all 26 of our departments. They'll be conducting SWOT analysis from each one of the areas. We'll look at our short-term goals for the 3, 6, and 9-month period. And then that will help us to deal with preparing ourselves for the fiscal year budget presentation, so it can align the organization to be ready today for what's coming tomorrow.
Okay, I've got 30 more minutes, so I was happy to hear that. No, I'm taking the minutes, Mr. Chair. She said minutes on the record. So, as Mr. Finch alluded, we have an aging population. So, on both hospitals, this issue about elderly care is going to be with us for the foreseeable future. Both hospitals should be positioning themselves to accommodate this new trend that we see. What do you have in plan? What do you have right now strategically planned for this?
Right now, for this particular age population, it's just looking at our service lines and see how best we can look at the geriatric or gerontology services. There's something been unique for us within the territory, and the charge from the chair or new chair to myself and my colleague is a reference of the synergy between the islands and how best we can optimize the healthcare services for the territory.
Mr. Chair, one more question, if you may.
Yes, you may proceed.
So, Mr. Smith, Dr. Smith alluded to telehealth and the impact that might have. Have you spoken to your staff about how that could be incorporated? Because that's something we could easily do to help generate some additional revenues that will not impact the rest of the function of the hospital.
The telehealth and telemedicine, I've only spoken with our chief medical officer. She's currently off island. And to me, that's the only extent to which we've spoken about it. It is feasible, but there are so many things we need to put in place because we are we're surrounded by water. So the fact of if anything is handled telehealth or telemedicine, the liability will fall on the physicians here to maintain the care. So that's something that we really need to address and put into place. But it is a feasible option.
Excuse
yes,
me,
you
Mr.
may
Chair.
wrap up. You may wrap up.
I didn't ask Ms. Commissiong. I'm so sorry. Ms. Commissiong, thank you, Ms. Baptiste. Excuse me, Ms. Commissiong, CEO Commissiong.
Yes, good afternoon, sir.
Can you please answer the question that I asked the Juan Louis Chair, CEO as well, please?
Can you restate the question? If you're talking about adding geriatric services, we definitely plan to do that. We need more adult internal medicine services. We need to continue to develop more clinic services available to take care of patients. And we're looking at things like hospital at home, which was mentioned earlier by Senator James. There's a number of programs to put into place to address the aging population.
Thank you, Mr.
If you're referring to telemedicine, we're very interested in telemedicine. We have applied for a grant to assist us with purchasing some of those devices. We think it really will help us to expand the services that we can provide at home by getting consultation from specialists that are in the States, hopefully help us to avoid having to transfer some patients off island and help us to better care for our people. So telemedicine is certainly something that we are embarking on even as we speak now. Those providers would have to be licensed within the Virgin Islands to provide that care. So it's a little bit of process for onboarding and credentialing those docs, but we're looking for partner organizations that have those specialties that can help to support, for example, the stroke program, neonatology services, and some of our other service lines.
Thank you very much. Thank you, Mr. Chair.
Okay, thank you, Senator Lorenzo Frederick. Okay, Director Commissiong. Okay, we heard testimony about CEO Commission. We heard testimony about a 33-year employee retiring as a nurse, but they're unable to collect their GERS payment. Do you have outstanding payments due to GERS? Is just this one employee, or there are others that you have a balance to?
We do have an outstanding amount with GRS. We have strengthened the relationship with GRS over the past year, and we have been working with them to ensure that as persons retire, we get a letter from them of what is owed from the hospital side and the employee side. We promptly pay that, and we get the employee started on GRS retirement annuities. We have not formally received a letter for Ms. Phipps, even though I heard the testimony read into the record today. It's something that we'll certainly look into. We valued very much the service that Ms. Phipps gave to the community and to Schneider Regional, and we're going to work to get her squared away as quickly as possible. We've been reserving some of the employee contributions, and those will be remitted to GRS within the next 30 days. We have a large outstanding contribution on the employer side that we will need help with. And I mentioned in my testimony that is some of the support that we're looking for in terms of funding from this group. Thank you.
Well, you know, this is very important. This lady did 33 years as a nurse. Her testimony before this committee is she officially retired on November 30th. She didn't also get her 184 hours of annual leave, and we're almost in the end of February. You're almost 3 months away, and you're telling me your testimony is you have not officially received her retirement. Something doesn't gel here, but is she retired from the hospital? Yes?
She's
Okay.
retired from the hospital.
I need you to look into that and give a report to the committee on this particular incidents, because there's a conflict here between her testimony and what you're saying. Okay, we want to move on now.
Annual pay payout.
Yes, go ahead. You can
When we receive
respond.
the letter from GRS, we will work to make sure that she's paid up so that she can start to get her retirement annuity, like we've done for all of the other employees that retired from Schneider within calendar year 24.
Okay, good. I want to move on to the cancer center now. I think the Charlotte Kindelman, Director Smalls, it's your testimony. The cancer center should be finished more or less by December of 2025.
Good afternoon, Senator. Darrell Smalls, Executive Director. Yes, right now our construction schedule is poised for completion in November of 2025.
Okay, good. That's awesome. CEO Commission. So with the staffing for the Charlotte Kindelman Cancer Center, we have a CT simulator and a linear accelerator, right? It's going to be installed?
That's correct.
Okay. So as far as staffing now, a radiation oncologist, do you have that? And is that part of your staffing plan that you're going to come before, or you already have that position filled?
I have a staffing plan with 19 positions that need to be added to be able to take care of patients in Charlotte Kindelman when it opens. That includes a radiation oncologist, as you mentioned. It also includes nurses who specialize in radiation oncology. It includes radiation therapists, a dietitian, 2 social workers, a medical oncologist we already have, but we need some additional nurses who do medical oncology. And there's a handful of other positions that make up the 19 that we need to add, that we will need funding for with the reopening of Charlotte Kindelman.
Okay, and you know this is very important because, you know, as I said earlier, 500 more or less, Virgin Islanders receive a cancer diagnosis each year, and you know one of the reasons why those with the Cigna and the United Healthcare and the Medicare and the Medicaid go off island is because we have to build up a level of confidence so that they can stay here. So let's continue with the staffing. So the surgical for the cancer, a surgical oncologist, you're going to hire a surgical oncologist, or you're going to use existing general surgeons to do that surgery?
Thank you, Tina Commissiong for Schneider Regional. We have surgical oncology covered with our existing staff members. Our existing general surgeons handle surgical oncology as well.
Okay, how about a molecular pathologist? Do you have that covered where you use the genetics to guide the cancer treatment? How are you going to deal with that? That's part of your staffing plan?
We have 2 highly skilled docs on board that do some of that work, and some of the work is sent out to specialty labs for those results.
Okay, so is that one of the positions you're going to submit that you need to cover, or that's something that existing staff can already cover?
That's something that existing staff can already cover.
Okay, well, as soon as you can, please submit that to the committee so that we can review, because if the cancer center is going to be finished by December, we need to start onboarding that appropriate staff. And then also CMS certification. It's going to be where you can get the CMS certified and all of those other issues.
Yes, sir. We plan to be CMS certified, and we have Joint Commission accreditation as well.
Good. So we'll go to Senator Marvin Blyden. Senator Blyden, you're recognized for your 6 minutes.
Yeah, thank you, Mr. Chair. But before I begin my time, I just want to let you know that Senator Alma Francis Heliger is here in the chambers. Okay?
Thank you. Yes, thank you. Welcome, Senator Alma Francis Heiliger.
We'll start my time now. Okay, thank you so much. Good afternoon. Good afternoon to the testifiers. Good afternoon, CEO Commissiong for the Roy Lester Schneider Hospital, CEO Carty-Baptiste, Juan F. Hospital Medical Center, Mr. Christopher Finch, former chairman, Virgin Islands Government Health and Hospital Corporation, Mr. Edgar Baker Phillips, resident, Mr. Darrell Smalls, director, and thank all of you for those most important testimonies. I must say, a lot have been said, and it's important that, and sorry for your condolences to your sister loss, okay? But it's important that we focus on what's going on in the space right about now. I'm going to focus on Mr. Finch's testimony, and he spoke to the impact of borders, and that's what we're speaking of today. And it's very important that many times we hear it as a cliche, good health is wealth. Today it's very clear that good health is wealth. You know, and data drives policy. And today we got some data in Mr. Finch's testimony. This is the first time I've gotten some of this data. And it's very important that we go over some of it. As Mr. Finch stated, that borders are human beings. They are people, mostly frail, elderly members of our community who no longer have the ability to care for themselves. And the border crisis, like I say, the border crisis in our hospitals is deep and wide in terms of a revolving door, as one of the testifiers stated, in our community. And it's compounded by the issue of impact to the emergency room, which causes other trickle-down effect. For instance, as was stated in several testimonies, being able to do operation that actually makes revenues for the hospitals. It actually creates long waiting times, which affects many individuals being able to get service, which affects their health, and on and on and on. And I am kind of happy that Mr. Finch, who's been around for some time, basically gave some suggestions, short-term solutions, like many others in their testimony. But the number that I talked about with the data, in terms of using a yardstick that on page 6 of his testimony, in respect to a solid number, we state we would need between 556 to 977 long-term care placements. That's important. But we only have a small fraction of 74 beds at this time. So it is clear that we have a serious issue in our hands, but at the same time, we know how to move forward with some of the short-term solutions. And also, he spoke to some low-hanging fruits, in my opinion, that can assist in attaining some of those goals. For instance, support for family caregivers, that's important. That's something we can do that's not going to cost much money, which is educating, training, or implementing best practices in terms of providing care and assistance, emotional support groups, etc. Also spoke to service that enhance independent living housing, which I spoke to earlier in Block 1, like Lucina Miller Home, like we used to 2 years ago, in terms of bringing individuals from the Department of Human Services to assist with nursing and other elderly care at those type of facilities. Also to bring on board more assisted housing facilities and more assisted living homes. Now also Dr. Smith, I love what he spoke to also in terms of some of his solutions in terms of expanding long-term care and rehabilitation facilities, strengthening community-based care, also, of course, policy and legislative support for alternative care models, investment in workforce development, which addresses staffing shortages across all levels of care, including nurses, therapists, and supporting staff at our different facilities. And of course, which was spoken to a little earlier in terms of telehealth and telemedicine and leveraging technology. It's important though that, the conference that Mr. Finch spoke to that he's planning, that's going to be critical in bringing all of the players at the table to address this most important topic of borders and a border crisis in our hospitals, because it affects all of us. And we do have an aging community, and we all are getting older on a daily basis, and we must find a way to really address this long-standing issue. It has been around for some time, but it's glaring its ugly face at this time like never before. And I must say, I appreciate the conversation today. I appreciate the input from all of the testifiers and the dialogue. And I also appreciate the different solutions and recommendations that were stated in many of the testimonies. And I look forward to working with all of the individuals moving forward to see how we can really at least make an impact. We're not going to solve it overnight, but make an impact in terms of reducing borders at our hospital and see how we can work on our health care issues moving forward. I want to thank the chair again for having this meeting today. It's very important and timely. And I want to thank all of the testifiers for their testimony and their responses, even though I really didn't need a response at this time. Thank you so much, Mr. Chair, for the time, and thank you, colleagues.
Thank you, Senator Marvin Blyden. A quick question I wanted to ask. As far as the hospital billing rates, right now, are the hospital billing rates comparable to the ambulatory surgical centers? More or less the same, or are they generally lower?
Commissiong from Schneider Regional, I'm happy to start. We know that the rates that we're currently being paid are under market. It doesn't sufficiently cover the cost of care. I'll give you the example for Medicaid, ER visit where a patient might come in and need blood products, pharmacy products, nursing time, physician time. We're only receiving $405 for that encounter, which does not cover those items. If a Medicaid patient needs a knee replacement, for example, the cost of the implant alone might be $5,000. We're receiving a daily rate of $1,370 from the Medicaid program. So the rates are not sufficient to cover the direct expenses and the cost of care. And it came up earlier that we're focusing on the borders. The borders are a huge part of the problem, but the borders are maybe $6 million worth of the $44 million of uncompensated care we give. We give a lot of free care. Uncompensated care, as in defined in the code, is the sum of bad debt, which is your inability to collect on, responsibilities, and it's the charity care that we provide. We have a number of patients that come to the ER. We have to take care of everybody who have no insurance. There are a lot of folks within the middle that make more than the $15,000 with that Medicaid will allow for, that don't work for the government, that don't have any insurance coverage, and an unforeseen medical event is a very tough bill to deal with. And so a lot of care that we give is free care, self-pay, no pay. And we have a large number of undocumented persons that we take care of as well. That is also pretty much free care. So the $44 million of that we're giving of uncompensated care is really a huge issue for the hospitals. And the rates that we receive, the uncompensated care number doesn't even account for the underfunding from Medicare and Medicaid. So when you couple the $14 million that's not coming through the allotment for uncompensated care, another $14 million in underfunding for Medicaid, underfunding from Medicare, it's really tough for the hospitals to do what we need to do, procure the supplies we need, hire the staff we need, take care of the patients that we need to do. And so we need attention to those issues.
Yep.
And it's broader than the...
Yes, Director Baptiste.
Darlene, Carty-Baptiste, CEO, Juan Louis. And again, just to piggyback on my colleague, specifically to, we could give you numbers specifically to our Medicaid patients. What we bill is just a fraction of what is actually collected. And we have our fiscal year data information for 24 and 25 to date. Based on 8,000, close to 8,000 discharge, we bill in approximately $37 million, and we already collected. This is for fiscal year 24, collected 11.
Yeah, and see, I researched that also, and CEO Tina Commissiong, you're right. For knee surgery, since you mentioned the knee surgery, Cigna would pay up to about $45,000, whereas Medicare is about $11,000 and Medicaid is about $1,500. So you can see why the Cigna patients who are going off island, for the most part, are so important that the hospital can convince those to stay here and get the surgeries because those are the profitable clients. So I want to get one other question I want to ask both the CEO for the hospital. So the co-payments, mandating zero co-payments for government plan health receiving care. What is your opinion on mandating zero co-payments, and how can that benefit you? Because, that government plan can be renegotiated by the hospital, by the board, the insurance board. Give me your opinion on that, zero co-payments for government health plan members.
Thank you, Senator Fonseca. Tina Commissiong, CEO for Schneider Regional. I think that's a great initiative. I totally support it. I think we need to incentivize persons to choose, not necessarily punish people who want to go elsewhere, but incentivize people to get their care done at the hospital for the care we can provide. We have a great product, high quality care, and we want to encourage people to come to us for their care. That helps us to collect enough through the insurances to offset the free care that we give. So it makes sense for the government to encourage folks to use the government health plan and get their services done at the hospitals. More money circulating in the local economy and more support for the hospital means less that the government has to provide in terms of an allotment. So we totally support that, and I think we've been trying to push for that, and we appreciate the advocacy from the legislature, and we got to work with the GSE Health Insurance Board and the local plan to see how do we reduce the patient responsibility, reduce the out-of-pocket expenses to encourage folks with the government Cigna to use the territory's hospital system.
CEO Carty-Baptiste.
Yes, Darlene, Carty-Baptiste, CEO, Juan Louis. The same thing, we do fully concur, and it's not just the services themselves, but it's the wraparound services as well that would benefit. Those are ancillary services that would be benefited here in the territory, and even to the fact of physical therapy for those persons to come on, remain on island, and even the wellness and the health wellness and the mindset of the individuals will benefit overall for better healing, and that's proven by data.
Thank you, CEO Darlene Carty-Baptiste. Point of information, Senator Vele, you're recognized.
Thank you so much. And I think we do need to do everything possible to make sure that individuals go to both local hospitals and we're able to generate funds. But anything zero got to be paid for from someplace else. So when you're talking about insurance and you're talking about no copay, etc., the cost is going to come from someplace else. Whether it is an increase in the cost of insurance, but the cost is going to come from someplace else. Because if you're deducting that from them, they're going to look to recapture that someplace else. So it's not a simple solution, but it's one that we need to look at all of the factors that are involved before we make a determination as to what will work or what wouldn't work. And Medicare, Medicaid, that's a federal battle. It's not a Virgin Islands battle alone. It's a federal issue. You know, our ability to convince them to change the rates, which haven't been changed in quite a while, but it's a federal battle, and we have to deal with some reality right now, because I'm just reading about the $1 billion suggested over the next 10 years in cut for Medicaid that they're asking the Senate and the Congress right now to determine how they're going to deal with over $80 billion in cut to Medicaid over a 10-year span, which is $8 billion a year. So all of these stuff are coming down. So we need now to begin to think, how are we going to be able to generate money for the Virgin Islands outside of all of these reductions that are possibly going to be placed on us in the near future? Thank you so much, Mr. Chair.
Yes, thank you, Senator Bailey. Senator Avery Lewis, you're recognized for your point of information.
Thank you, Mr. Chairman. Mr. Finch, through the chair, Mr. Finch, on page 7 of your testimony, could you just, one quick question here. At your table 4 diagram, you said that the long-term care facility, Herbert Grigg, pre the storms was 40 beds. Now they're 29, which is a difference of 11. Queen Louise, 25, currently 13, difference of 12. These facilities was damaged or storm damage or something made that we have this difference in beds or something?
Hi, good afternoon, Chris Finch. And I believe also, Senator, that Human Services gave slightly different numbers today, but I think they add up the same. I believe it's a combination of storm damages and what they are currently staffed for.
All righty, thank you.
Thank you, Senator Avery Lewis. ARPA funds. So I'm going to ask the hospitals now, how much ARPA funds has Roy Lester Schneider Hospital received, and how much has Wang Louis received? And I'm specifically concentrating in fiscal year 2024.
Tina Commissiong from Schneider Regional. So both hospitals received an allocation of ARPA funds, originally of $10 million, that was changed to $9 million. We've had most of that already dispersed to us. We have a slight remaining balance within ARPA for projects that are already scoped out, and the funding, how that funding will be spent is already been identified. We're working with OMB on those final releases under our ARPA pot. We would have loved to have more available within ARPA because we have a lot of needs that need to be addressed.
So Roy Schneider got $9 million in ARPA funds. Did you get the $1 million for the diabetes, the chairs on that second wing? Did you get that additional $1 million?
No, sir. We had an act approved for the release of $1 million to support hemodialysis. We've not gotten any of those funds released to us yet. And we had another approval for $500,000 for interventional cardiology. We've also not had that released to us as yet.
And Wang Louis?
Darlene Baptiste, CEO. I can get that to you. What I've been advised, it's closer to the 10. It was split between personnel, operating costs, and supplies. I could get that breakdown to you, sir.
Okay, and the status of your additional dialysis chairs for the Wang Louis, when are you going to have those completed?
That's driven by the project, and we could give you the details through our Executive Director for the projects, Mr. Smalls.
Darrell Smalls, did you hear the question?
Yes, good afternoon, Senator. I did hear the question. Unfortunately, the funding that we're receiving for the dialysis center is through a project worksheet, FEMA project worksheet. I'm not aware that there's funds appropriated via ARPA towards that endeavor.
Yeah, there was an additional, the 35th legislature approved and the governor signed $1 million each. Okay, so you'll get back, Senator.
Both items will be submitted to your office.
Senator Avery Lewis, you're recognized for your 6 minutes.
Thank you. Let me walk my way back. Ms. Commissiong, when the CKCI reopens, God's willing, in December, January, give or take, is there a cancer register position on board?
Yes, Senator Lewis. So the Tina Commissiong, Schneider Regional, the cancer registry is maintained by Department of Health. They have a cancer registrar that's actively maintaining that. I believe they have a diabetes registrar as well. But those functions happen through Department of Health. They have access to our systems and to also the private docs and the private radiology centers. So they get real-time notification of new diagnoses and they get updates on the care that's happening at Charlotte Kimmelman Cancer Institute directly.
Thank you very much for that. Thank you for that answer. Mr. Smalls, good afternoon.
Good afternoon, Senator.
You talked, first of all, I really appreciated the presentation. And thank you very much for all the work you and the team doing. That's not you alone, but I see some young folks up there behind you. So thank you to you and the team. The CKCI is coming along nicely, but do you see any impediments, anything stopping you thus far that you think may be a hindrance for your date of November, December?
Currently, Senator, everything is working as planned. Obviously, we have additional procurements to undertake. Of course, then we also are battling weather. We always do, as we know that we will be entering into the height of the season. But barring any unforeseen circumstances, yes, we're still on target with the contractor for November 2025.
Supplies, everything going smoothly?
Right. Everything that we've ordered, we addressed the long lead items on the upfront at the start of the project. And with the execution of the contracts for the major pieces of equipment, all of those are on schedule for delivery and to begin training prior to November 2025.
Great. So based on all the work I'm seeing going on, when you swing open those doors, December, January, God's willing, what is a wow effect? What is something new that we never had before that we're going to see? Or maybe improve?
Well, I think from an equipment standpoint, both the linear accelerator and the CT upgraded, state-of-the-art. As a matter of fact, we just went through a change from the standpoint that when we ordered the initial equipment, the software has been upgraded for 2025. But just overall, the facility is just the functionality of the facility. Okay, I just remember one thing. Yes, the major improvement prior when we first opened the Charlotte Kimmelman Cancer Institute, we focused on adult care. However, with the new Charlotte Kimmelman Cancer Institute opening, we will have provisions for adolescents and children who may need infusion therapy. We've also increased the number of infusion bays to be able to provide for care for residents of the Virgin Islands.
Okay, thank you. Thank you, Mr. Smalls, and again, extend my gratitude to the team as well.
And not to take on to your time, but the one other thing I just also remember, the Charlotte Kimmelman Cancer Institute prior was dependent on the main hospital. This new reconstructed facility is going to be a standalone facility. So it has its own power generation, power backup, refrigeration, fire suppression systems. So when we move to the
water supply,
as well as water supply, we have 2 storage tanks that are going in. So as a result, when we commence with the overall renovation of the Royal Schneider Hospital, that demolition or that work effort will not impact the functionality of the Charlotte Kimmelman Cancer Institute.
Thank you, Mr. Smalls.
Thank you for the opportunity.
Dr. Jerry Smith. And Paige, in your testimony, you talked about long are the days where the 2 district hospital boards eventually ran each of the hospitals and the territorial board met quarterly in a bitterly clash. Has this conversation or it's like, how close are we to having this being a reality where we just have one board, in your estimation?
Good afternoon, Senator Lewis, Jerry Smith. We are one act of legislation with the governor's signature away from that being done. The functioning of the board right now is such that we basically function that way already. It's just a matter of legislative changes that would help us because our regulators currently require that we do as the legislation says. So as the legislation calls for a district board to exist, to be the entity directly above the hospitals, we have to continue some of the functions of those entities. If the legislation no longer said that, then we would continue without using that structure.
1 minute.
So, Dr. Smith, I am following your trend, how you plan to trend, and you see you're trying to right fit and right size. So you're looking at this for maybe duplicates and maybe positions in both hospitals as well?
Yes, Mr. Lewis. So some positions are much more difficult than others to do that with, and some would not be advantageous to do. So it's a really surgical precision to how we would look at the cohesive system, which is why it needs to be wrapped into an overall strategic plan, and then we look at a timeline that's appropriate. We have two very large organizations that have intricate details of the way things function. So the goal is to not turn things into being helter-skelter. We want to slowly look at what positions first would benefit from this sort of change. Example of the first things that can be done today would be a central chief financial officer, because there's none in permanent position right now. It's looking at IT, it's looking at procurement. Entities that lend themselves to a district-wide, a territory-wide application would be the ways where we would start first.
Mr. Chair, if I could ask one more question.
Yes, you may wrap up, yes.
So, Ms. Commissiong, you talked earlier about your billing, need to be up to date, your current billing system. And you talked about an EMR system. And I think in a previous discussion, you talked that this system would be able to work between you and Schneider Regional and JFL. Are we still on track with this particular system, and what would be the cost of this system to the both hospitals?
Yes, Senator Lewis, thank you for the question. I think it's a great investment, probably the best investment that can be made right now for the two hospitals is to get a new electronic medical record system that's fully electronic, that's stored in the cloud, that is much better for documentation and coding, allowing you to bill better, have less denials, and be able to work those denials better. I think it makes sense for us to get an enterprise-wide system that serves both hospitals and standardizes procedures. That new system is going to have better financial reporting, better decision support, and it's definitely the direction we need to move in. It's going to help us improve billing and collections, help us generate more money monthly. The new system, total cost of implementation is $10 million. That would cover both hospitals. Sounds like a lot. It is a lot. I would say that's probably going to cover the first 18 months, and then beyond that, it's a subscription service, probably just about under $100,000 a month to maintain that. It's definitely what we need for our hospital system.
And this system is the one that's going to speak with the previous system, collect all the data that we had from before, moving forward, speak with the Wang Louis system and their system they're running. I mean, this is a complete system, right? We just say one that we buy this package and then forget to buy Part B and Part C.
Comprehensive, complete system. It'll also interface with the territory's health information exchange, which makes sure that your record can pass between your private provider, the hospitals. If you have an allergy list, let's say that's recorded in your hospital stay in St. Thomas, and you happen to be at St. Croix for Ag Fair and get sick, when you go to the hospital in St. Croix, they'll be able to pull up your records, see your allergy list. It'll be a lot better for the patients. If you have to go to the States for some advanced care, through the HIE, your record can follow you. It allows us to have folks that are on site, that are specialists in professional billing, help us with that coding and billing. It just really opens up some necessary tools that we don't have right now, even in making decisions in terms of decision support. What should we continue to invest in? How is this service line performing against another one? We'd be able to have a lot more functionality with a new EMR, and we're currently evaluating those systems now, and it's going to take a pledge of funding of about $10 million to accomplish that.
Great. And late last year, you had a little breach in your IT system, your ransom and so forth. Is that rectified? We back to normal, or are we still limping along? How are we dealing with this? We still have some technical issues.
Yeah.
You got to.
Tina Commissiong for Schneider Regional. Thank you for the question, Senator Lewis. We're mostly back on track. We are doing all of our documentation for our active patients within Meditech. We also have separate computers that are there that allow for internet use and the internal files and the intranet and whatnot. Everything is not connected back together because we're keeping the medical record and financial information within a bubble to keep it secure for right now. We've done a lot of security enhancements, improving the firewall, new software systems, constant penetration testing to see where the vulnerabilities are. We're working to continue to remediate those vulnerabilities. And now we have 24/7 monitoring. So as anomalies are picked up within the system, it immediately shuts it down. So we've done a lot to improve the security system, but it really had a devastating effect on our operations, on our collections, and we're still recovering from that cyber attack.
I thank you very much, Mr. Chair. Thank you for the flexibility. Thank you.
Yes, thank you, Senator Averil Lewis. Real quickly, Dr. Jerry Smith has informed us that he have to leave, but if any senator have any one particular burning question for Dr. Smith, I'll allow you to ask. And I do have a question. Okay, so we're talking about, because you're the boss, you're now the chairman of the board, the hospital facility board. So we're talking about possibly unifying and merging and joining so we can take advantage of, economies of scale with our procurement. And you mentioned the CFO. Are those your ideas that you're telling me that the board is going to have those discussions? We accept your statement of eliminating the district boards, and I do have that bill to eliminate those. But give me some more specifics on your plans for being able to operate more efficiently. You spoke about the billing system, the IT system, etc. Give us some more details.
Thank you very much, Senator Fonseca, Jerry Smith. So you just heard discussions from CEO Commissiong about the unified IT system. That is a great example of an initiative of pushing the two entities together. If you go back to dialogue that occurred 6 or 9 months ago, we were speaking about paying millions of dollars to buy two separate IT systems. The board has squashed that idea and pushed the two entities to unify their goal, and their professionals came back with a great solution where there's a online version of this system. So that's an example of where the emphasis is, the work gets done. So that is one area, but truly, the short answer to you is I am unable at this point to give you the exact roadmap because I don't want to just helter-skelter just say and make promises that I really can't keep. The goal and the idea of the entity is this is the direction we're going, but we want to be responsible in the implementation of it. So the areas that can be done quick, easy, and without a lot of friction, we will do those first. Where logistically it makes sense to do that, we will go ahead and do that. And the areas that will take a little bit more work, we will take the time, we would use the expertise that we have in front of us. There's some ARPA funding being used through OMB for EY. That entity has already started the work and looking at the organizations, looking at our organizational chart. One quick example is in the credentialing of our physicians. Currently, it's two totally different processes that happen. They mirror each other, but they're two totally different processes. So if a physician wants to be credentialed to work at SRMC, they have to start the entire process over to be credentialed to work at JFL. Makes no sense. If you go at the airport or the seaport in the mornings, you see the amount of physicians for their private offices that run back and forth to provide services. Why can't that be the same way with the hospital? So we could benefit the patients in the territory. So it's things like that that's really, really easy. If we could mirror the systems, make them identical, because by the regulators, we still have to have two processes for the hospitals themselves, for their individual CMS certifications. But we could make them identical and run them parallel. That way, the physicians are credentialed in both facilities at the same time, and we can make it more efficient and have more access to care. That's an example of things that we can do really easy right away. Another example of things that can be done is potentially earmarking the line item in the budgets for equipment, supplies, and then creating a central procurement entity that then takes the line items from both facilities, merge them into one larger sum of money, create one central large warehousing, and then purchasing in large bulk orders to save money, warehousing in the territory, and then distributing more efficiently than having to ship from Florida or where have you when you need something quickly. So it's just things like that really could benefit the operations of the facility, not just pricing, but also time that we need to be looking at very closely to see how we could really impact the system.
Thank you, Dr. Jerry Smith. Vice Chair Fredericks, you're recognized for your point of information. And then we'll go to Senator Francis.
Dr. Smith, thank you again for your time, for your testimony. I'm a fan of yours already because you're speaking the language I understand when it comes to efficiency. I don't know why it's been bifurcated the way it is. No one has been able to articulate it as well as you have so far, other than it's always been like that. That's not good business sense. That's not good economic sense. We need economies of scale savings. You're on the right track. Of course, how soon you implement it could save these hospitals. The longer you take as a board to make a firm decision, the pain will continue. The payables are going to be stretched. So this is something that you need to do quickly as an organization. And if it takes legislation to assist the process to mandate it, so be it. But we cannot continue like this anymore. The red ink that I see with these hospitals, half of it is self-imposed, poor structuring. So I'm looking for your leadership and the board members to start looking at these things seriously. I need the two CEOs to work collaboratively together as much as you can to bring resources together so that it doesn't cost us as a territory more money. The physician that one hospital have and expertise should be shared. It's coming out of one central government. Why do we act so separate? No, I believe in equity and parity now. I'm going to be looking to make sure St. Croix is being treated fairly. So just keep that in mind too, right? So, can I have your commitment real quick? Can I have your commitment that you'll do whatever it takes and call us? We'll be happy to help to push this process through.
Yes, sir, you have my commitment.
Thank you. No further questions, sir.
Yes, thank you, Senator Herbert Fredericks. Senator Novell E. Francis Jr., you're recognized for your point of information.
Thank you very much, Mr. Chair. I've been around here long enough to know that haste make waste. I'm not going to sign on to any haste. I think that there needs to be a well thought out plan, and there needs to be a feasibility study and determination to ensure how we move forward. I'm very open-minded to this merger, consolidation, if you want to call it that. I totally agree that when you look at economy of scale, we have to look at that, how we begin to do things differently. Equity, parity, and priority is critical and important for me. A lot of times when we move, and the reason why it's been that way for some time now is because we have unique situation at both hospitals. Each of them strictly have unique situation. Hence, that's the way I've worked for quite some time. Chairman come and go, CEO come and go. We see how many we have had here in the St. Croix district for quite some time. So we have to ensure that there's documentation language to protect these institutions as we move forward. So yes, I believe that there needs to be discussion. It was ripe for discussion as we in this crisis mode right now. But haste make waste, and I'm not going to sign anything just to rush. I believe that there is opportunities for us to sit at the table and make sure that we're ensuring that the priorities that need to be taken, and certainly the equity and parity exists as we move forward. Thank you very much.
Thank you. Senator Alma Francis Heiliger, you're recognized for your point of information.
Thank you so much. Quickly, because I know the doctor has to head out, Dr. Smith, I do support everything that you have shared here today. I support the fact that we do need to have the discussion of merging. And I think whether it's from an economic standpoint or for the benefit for the health of the people of this territory, I support it. I'm willing to have the conversation. But the question I want to speak to you about specifically in regards to dealing with the board, specifically with the Schneider Hospital, where do you see that there could be potential improvements as it relates to offering more services to the people of this territory? Because we hear a lot about people leaving the territory because we don't have services. Do you see room for growth for the hospital, potentially other specialized services? Specifically whether it's long-term, that maybe if we ultimately do merge, the services could be shared between the islands. Could you expound on that a little bit? Thank you.
Yes, good afternoon, Senator Jerry Smith. So the short answer is yes. There's lots of room for expansion. There are some challenges that exist that we need to cautiously approach. One of the things you heard lots of talk earlier today about the Medicaid state plan. One of the caveats of the Medicaid state plan is that a fully insured physician within the hospital is unable to bill for the professional fees of the fully insured physician. So we have such a large percentage of our case mix being Medicaid. We have to be very, very careful as we add services, because we could really be adding services where we would invite a large salary for a provider that we can't compensate for, because a large percentage of that mix we won't be able to collect from. So we need to look at the state plan so we can make adjustments there, and we can have full compensation just as if that provider was in their private office. So with that being said, it's a matter of looking at the various service lines to see where the benefits really are, trying to avoid lost leaders as much as possible, where services are lacking, using I referenced it in my testimony, the needs assessment done by the Department of Health to look where the gaps are in services in the territory. That's a good source of data. Also looking just in the community, what services are available and where those gaps are. Potentially getting information from the government health insurance board, if we can get them to share data, which is not always so easy, on the types of services that Cigna is now paying for people to go off island to do, and using that as almost as a cheat sheet for what things to expand into. Those are the areas that we want to look at first, because we don't want to. Yes, we want to improve services, we want to offer more services, but at this point, we can't just offer services for offering them sake. We have to offer things also that generate revenue, so that we can balance against the things that don't generate revenue, so we can grow evenly and we can sustain ourselves. So those things aren't to be haphazardly approached. We have to be very cautious as we go forward and make good, wise business and healthcare decisions as we go forward.
Thank you.
Excellent. Thank you so much for that response, and thank you for the time, Mr. Chair.
Thank you, Senator Alma Francis Heiliger. We have to go to a break, but we're going to recognize Senator
One quick one
Kurt
for
A. Vele
the doctor
for
before he
point of
leaves.
information, and then we'll...
One quick one.
Senator Vele, you're recognized for your point of information.
Thank you so much, Mr. Chair. I listened to the comments, and I got so much different areas I want to comment on that I don't know where to start. But 9 out of 10 mergers in the Virgin Islands, St. Croix received the short end of the stick. It's just a reality. Let's go all the way back historically. 9 out of 10 mergers, anything that becomes territorial, St. Croix received the short end of the stick. We have two systems that are struggling. None really doing good. I want to take these two struggling systems and make one big struggling system, assuming the debt from both entities, and we haven't fixed any yet. So we haven't fixed billing here, we haven't fixed procurement, we haven't fixed anything, but now we want to go towards a more central model. I'm open to discussion. However, it got to be well planned out, extremely well planned out. Because Wang Louis, 7 CEOs in the last 10 years. They got to be planned out. Says how was a different vision. And what we need right now is just some continuity and somebody that's going to be given the opportunity to run the ship and run the ship right. And not somebody that is going to be terminated because of political reasons. Can't happen. I hear you spoke about the credentialing. What really stopped the board from credentialing doctors now for both hospitals? That's a policy. What stopped the board from doing that? And why the board can't develop a policy that once a doctor is credentialed, they credential for both hospitals? What stops the board from doing that? What stops the board from coming up with one consistent policy for both healthcare systems? I don't know that anything that stops it. Secondly, we're having the conversation about, or thirdly, about merger. But we're not having a conversation about composition of the board to make sure that we have subject area experts on the board in every single area and not political appointees that are just going to do the bidding of somebody. If we are going to have a merger, we got to discuss the composition of the board. And the board must become apolitical and have the qualifications to sit on the board. And not somebody that just believes that they got named to the board and I have all the answers. So we got to be careful as we proceed on. Because this could quickly blow up in our face, very, very quickly. So proceed with caution. Thank you, Mr. Chair.
Yes, Honorable Senator Kenneth L. Gittins, you're recognized for your point of information.
Thank you so much, Mr. Chair. Just to add to the conversation before the good doctor leaves, on a positive note, I want to take this opportunity to publicly commend and congratulate him. And I believe he just attained another degree on top of his doctorate degree regarding healthcare management and administration. And I just wanted to publicly commend him because this surely shows us his commitment and his passion to our healthcare system. And as a young person, I want to also, encourage others on boards and that serves on boards and commission to take this same passion and further their education to make sure that the entity in which they serve, that they will do it to the best of their ability. So again, congratulations to you, Dr. Jerry Smith. You could tell us exactly what degree and exactly what it is. I think it's in healthcare management though, and administration.
Yes, sir. Jerry Smith once again. So yes, I just completed, after being in healthcare for the last 20 years and managing my business and being involved on the board, I just wanted to make sure that there wasn't any blind spots. So I decided to undergo a formal program, and I just completed literally a week ago a master's degree in healthcare administration to make sure that I had the requisite knowledge to back up what we're doing. So thank you.
Congrats. I still do my little investigation, so I found it. Thank you.
Thank you, Senator Gittins. And actually, Madam Clerk will reset the clock. And, I'm sorry, yes. Senator Maurice James, you're recognized for your point of information.
Smith had to leave, so I didn't want him to leave without my saying congratulations to you too. I am a firm believer that local needs are met best at the local level. So I'm going to be one of those that will need convincing that a merger would in fact benefit both, well, not both, the three islands, really. Because in the short time that I have been a senator, I have seen such a distinct difference between the islands. And so I really will need convincing. I understand that some components, like the financial and the technology, can perhaps be addressed together, but I'm not sure about other components. So you'll have to convince me, Dr. Smith. Thank you.
Thank you, Senator Maurice James. The Committee on Health, and you would be excused and you'll be permitted to catch your flight. Hopefully you catch it. The Committee on Health, Hospitals, Human Services is in recess for 2 minutes. The Committee on Health, Hospitals, and Human Services is back on the record. Okay, so we've been receiving some testimony from various officials in the hospitals, from Tina Commissiong, the CEO for the Roy Lester Schneider Hospital, and also Darlene Carty-Baptiste, the CEO from the Juan Louis Hospital. We had present with us Dr. Jerry Smith. He just had to leave to catch a flight. He is the new chair of the Hospital Facilities Board, and we also have several other members of their staff here today. So before we went to break, we were about to recognize Senator Kenneth Gittins for his 6 minutes. Senator Gittins, you may proceed.
Thank you. Good afternoon to all. Thank you for the testimony today. Let me go back a bit and start first. I'll start from the bottom of my notes up. Based on what I asked the CEO of the St. Thomas Hospital earlier regarding borders. How many borders do you have on St. Croix at GFL?
Good afternoon, Darlene Baptiste, CEO, Juan F. Louis Hospital. Senator, we currently have 9 borders as of today.
Are they of senior age? Are they seniors?
Senator, I would like to, all except one. For further questions, I'd like to defer to our Chief Nursing Officer for greater detail.
All except one. No, it's okay. Are any of these borders undocumented?
Yes, Senator, there is one undocumented border in St. Croix.
Okay, so St. Thomas has 3, you have 1. All right, we'll talk off the record with that. Now, what would you say are your top 3 revenue generating areas of the hospital? Juan Louis first and then RLSH.
Our top 3 generating will probably be ICU, one second, and our diagnostic services for imaging.
And one more?
Perioperative services.
Okay, RLSH?
Yes, thank you for the question, Senator Gittins. Our outpatient surgeries, our GI procedures through our gastroenterology program. And we have a lot of opportunities to do more revenue generating activity through lab and radiology with a little bit of investment and some additional personnel there. I think it's really an area we can expand.
Thank you. So between both of your responses, I hit the nail on 2. Because based on what I had, I would say that your operating room would have probably been your first one. And then I was also looking at possibly your emergency room, which none of you stated, and then radiology. But so knowing this, have all the clinical services at JFL, have all the clinical services been transferred out of the old building into JFL North?
No, Senator, not all services.
So services like what have remained over, have not been transferred?
I'd like to call our CNO for response.
Good afternoon, Chief Nursing Officer Doris Plaskett. The remaining services that are still operating out of JFM Main includes the pharmacy. We have mammography, some outpatient laboratory services. Those are the major services that are still operating out of JFL Maine.
Do you have a IV compounding room?
That is under the pharmacy department, and they're still operating out of JFL Maine.
So, and what's the condition of that?
I will have to defer that question to Mr. Smalls.
All right. Mr. Smalls is on St. Thomas. Can you recognize his mic, please? Thank you.
Good afternoon. Good afternoon, Senator. The outpatient radiology services, we just finished the scope of work. We obtained the permits, and we're getting ready to issue a solicitation for the services of a contractor to facilitate moving the outpatient radiology services out of JFL up to VICC.
So how soon would you say?
I would say that the advertisement should hit the streets within the next 30 days or less.
All right, thank you. And both CEOs, do you have an outpatient clinic, or is there a fast track in place at the emergency room?
In a Commissiong for Schneider Regional, we have at our emergency department, we're looking to expand the number of bays there to handle more fast track patients. We have some outpatient clinic services.
One second. Just yes or no. Do we have fast track at the ER?
Yes.
All right, and we're capturing revenues in this area as well?
Yes.
Okay, St. Croix?
Yes, based on staffing schedules, and no, we're not maximizing our revenue opportunities.
So based on staffing schedules, so you'll say that it's closed most of the time?
Again, it's driven by our locum coverage, so I can give you an estimation based on our projections for the month of March and volume.
We'll need to, we'll zero in on that off the record. Have there been a lot of, and this is for both CEOs as well, have there been a lot of cancellations for surgeries? And remember that I had surgery at the top of my listing for revenue generating areas. How are we doing on cancellations? On surgeries?
Specifically for the Governor Juan F, we have noted a number of cancellations due to staffing with our surgical techs. I alluded to that a little bit in my testimony, specifically to our allied health negotiation. And then the other piece is supplies.
Staffing and supplies. St. Thomas?
At Schneider Regional, we really try hard. We have minimal cancellations. We try to keep our ORs going. Sometimes we're not able to open as many rooms as we'd like because we're dependent on anesthesiology staffing. But no, we don't tend to cancel many outpatient cases.
What would be your reasons for cancellations?
Sometimes it may be an environment of care issue. Our most recent cancellation was due to an AC failure within the OR. Took a little time to take that unit offline, repair it, and get it back running for elective surgeries. And that's due to with no money for capital replacement.
Thank you. Now, I'm one of the senators that have his boots on the ground, and I am just hopeful that we're not canceling a $20,000 procedure because we don't have a $12 box of gloves to be able to carry out a surgical procedure. I note that staffing is one and supplies is one. Supplies should not be an issue, and I'm hearing from within that there have been cancellations for minor things of supplies. The doctors have even had to leave the hospital to go to the respective offices to just pick up boxes of this and boxes of that. So I'm asking that we pay attention to this and not be canceling out on a $20,000 procedure just because we lack a $12 box of gloves. And I'll conclude by asking the director here on St. Thomas, Mr. Smalls, do we have design contracts in place for all three hospital sites?
Yes, Senator.
And what's the status and the amount of each of those designs?
When you say status, you're referring to the dollar value?
Yeah, the dollar value or they're completed?
No, I don't have the dollar value before me. However, I could get that information. The design for the Governor Juan F. Louis Hospital is completed. The designs for the Myra Keating Smith as well as the Royal Schneider Hospital are not completed. We're only in the what we call the programmatic stages right now.
So through the chair, can you provide that information to us at a later date?
Yes, Senator.
Just giving us an update on all 3 or 4 sites.
Fair enough, Senator.
Thank you. Thank you, Mr. Chair.
Thank you, Senator Gittins. Real quickly, and I'm going to need an update, CEO Tina Commissiong, on the status of the morgue in St. John and also the lab in the Roy Lester Snyder Hospital. Is the lab functioning and is the morgue open?
The morgue on St. Thomas, good day, Tina Commissiong, Schneider Regional. The morgue on St. Thomas.
St. John, morgue St. John.
The morgue cooler on St. John is not functional. Bodies are being transported to Schneider Regional's morgue or to Justice's morgue, which is also on St. Thomas. The lab is open and functional. It's been consistently open for inpatient care. There were blips due to staffing where we weren't able to do all of the outpatient services that we'd like to do through lab. We're working to stabilize that staffing and stabilize the outpatient offerings from our laboratory.
Okay, thank you. Senator Novell Francis, you're recognized for your 6 months.
Thank you very much, Mr. Chair. I'll just jump right into it because I have a bunch of questions. In regards to allotments, have you received all of your allotments thus far? Wang Louis?
Darlene Baptiste, CEO, Juan F. Louis. Yes, to date, we have received our allotments.
What is your, what about vendors payment? What is your delta or the owed amount for vendors payment?
Our accounts payable stand at $19.9 million.
19.9. And that is of when? These are some, I guess, aged.
Yes, they're aged, going back to 2010.
And Snyder Hospital, your allotments, have you received all of your due allotments to date?
We've received our allotments through February, Senator.
Okay. And what is your delta in terms of vendors payment?
Our accounts payable is at $38 million. That includes government liabilities, supply vendors, staffing vendors, and some insurance refunds.
Okay. Good, thank you. And now that I have you, CEO Commissiong, I know that you were very explicit about your uncompensated care and what is the impact that is that having on your system there. Can you tell me what is the accuracy of you spoke about $44 million of uncompensated care. How are you calculating that?
Yes, Senator, that comes directly from the cost report. It's a measure of the bad debt and the charity care that we give. And it would say that neither hospital is doing good, but I think, we exist in a very difficult environment. We have a population that's uninsured, underinsured. We're getting paid insufficiently for the uncompensated care. We're being underpaid for the Medicare and Medicaid. So sometimes you don't have it to pay all the suppliers you need to pay. You don't have it to catch up on AP. You certainly don't have it to invest in the new tools that you need, like a new EMR that helps you bill and collect better. So picking up for the team a little bit, we're doing a lot to make miracles happen despite the underfunding. When you're not getting what you need to cover the day-to-day activities, you don't have it to put back into the facility and invest in your mechanical systems. You're not getting a separate line item for capital. You're not getting a separate line item for that kind of IT investment. So then you're vulnerable to things like the IT attack and the downtime and those things that happen.
Understood. So tell me, let's use a quick scenario. In terms of a gunshot victim that comes into the emergency room that's underinsured or uninsured, how then do you assess the costs associated with that? Are you eligible for presumptive eligibility for the first 30 days, or there's total uncompensated care throughout that time? Or tell me about what happened to a gunshot individuals that have no insurance.
Sure, and I think that's a great example, Senator. So a gunshot victim that comes in with no insurance may use several units of blood, certainly OR time, the physician time, the nursing time, the medication. Sometimes they need to be airlifted off island. And where we can get presumptive eligibility, we do try to register persons for that. There are some people that live within our community that we have to treat and take care of that are not eligible for presumptive eligibility. And so then we are burdened with that total cost of care. How we come up with the level of uncompensated care is directly off the charges associated with delivering that care. It's not an inflated number. It is really what it costs to take care of those patients.
Okay. Also, can you tell me, are you still having issues with certified coders? Do you have sufficient certified coders at this time?
We do have some certified coders on site. We need some additional coding support.
How
Again,
many,
this is another.
how many do you have in the St. Thomas district? How many do you have?
If you had a more robust system, folks could remote in and do it, you know, from that are experts in it from anywhere.
How many
But
certified coders do you have, CEO?
we have about 5 coders working right now. We have 2 that are more skilled in doing the more complex coding, the inpatient work, the surgical procedures, et cetera. And we have a few other coders that help us with more of the routine bread and butter outpatient ER encounters and can code those basic things.
Thank you. Ms. Baptiste, CEO Baptiste, how many certified coders do you have on St. Croix?
So we only have 1 on the island of St. Croix.
1. What are you doing to improve that number?
As part of our strategy in reference to our collections, we're doing the re-op and the productivity and evaluation of all our team within the business office services. So our performance review, again, initiates next week.
Now, talking about revenues coming in,
1 minute.
obviously we have where the CKCI will be opening in St. Thomas District in short order. What are we doing about the cardiac center here in St. Croix?
Specifically to the cardiac center, we're looking at re-upping some of our services. We have received grant funding for some initial equipment. So we are looking at that as one of our line items to re-up for operations.
And how soon? Any plans in terms of a timeline in which you intend to get the cardiac center up and running?
No specific timeline at this moment. Right now, I'm in day 15, so I'm spending the sponge period of this first phase of 30 days, just looking at a review, and then we could actually look at service line specific information and reference to those low-hanging fruits for our revenue-generated areas. Again, the major focus, along with the performance review, is our financial position and strengthening that.
Okay. Quickly, my time is about to call. I just want to say for the record that in fact we believe and we'll be having discussion as a committee and as a body in regards to the EMR. We believe that should, we should try or endeavor best to fund that. So we're working on that. We also have discussed the issue of borders and the costs associated with borders on the hospital. We believe that should be borne by the government of the Virgin Islands. And not carried by you, so we're looking and see exactly what that accurate count is so that we could be able to address that. I want to say in conclusion, as the chair of the Budget Appropriations and Finance Committee, that is difficult when you ask about an additional $14 million for each of the hospitals. It's going to be very difficult for us to come because there's crisis all over this government. Waste management, tax refund, public safety, retroactive pays. There's a lot of crisis there, and we endeavor to at least meet halfway. But it's very, very important that you're able to again address your billing issues as well as bill additional revenues. Thank you very much for the time, Mr. Chair.
Thank you, Senator Francis. Real quickly, for Darrell Smalls, a question with the cardiac center over here on St. Croix. In the Wang Louis demo and redevelopment that's going out to bid, is the cardiac center included in that, or is that going to be in another phase? Yeah, can you give me an update on that?
Yes, good afternoon, Senator. Great question. The Virgin Islands Cardiac Center, unfortunately, was not impacted by the hurricanes and as such did not receive any FEMA funding. However, understanding the need for cardiac care on the island of St. Croix, we have incorporated into the design the ability to perform certain procedures within the newly constructed hospital. Should there be funds remaining, because it's going to be connected to the new facility, we would try to expend some funds to do some necessary upgrades or any opportunities based on available funding.
Okay, so my question is, so as far as the cardiac center being functional, do those equipment, those scanners and stuff that we toured, are they functional or are they not? What's the plan to have a functioning cardiac center on St. Croix?
Well, I believe through the chair, through the CEO and the team of JFL, they alluded to the fact that they've applied for some grant funding to acquire replacement equipment. Some assessments have been performed on the existing equipment, and it's deemed that those pieces of equipment need to be upgraded and or replaced in their entirety.
So it's a possibility, CEO Darlene Carty-Baptiste, that all the equipment in the cardiac center needs to be replaced? That's what I'm hearing?
No, Senator Darlene Baptiste, CEO Juan Louis, that's not our position at this time. We're just looking at the current equipment, what's coming in through the grant, and also in my testimony, I did allude to the allied health professionals and looking sure that we have the skill sets in reference to be functional, our technologists, technicians, echocardiogram technicians. So that's also all part of that particular plan.
Okay, so then some of the equipment has to be replaced, but we don't know if all needs to be replaced. That's what you're telling me?
Correct, sir.
Okay, thanks. Senator Nova Francis, you're recognized for your point of information.
Just real quickly, what's your highest census for the year so far in St. Croix and St. Thomas?
For St. Croix, I'll like to call a CNO, sir.
CNO, Doris Plaskett, our full capacity for inpatient is 52 beds. We have run as high as about 48, 50 patients.
48, 50 so far for this year, and that's inclusive of the borders, of course.
Yes, that is inclusive of the borders, yes.
Okay. And St. Thomas, your census so far the highest for the year?
Yes, Senator Tina Commissiong for Schneider Regional. We've had in excess of 85 patients at any given time, plus that does not include the ER count for the day or any of the outpatient work for the day. So we have been running a pretty full house a lot of the year.
Good. Thank you. Thank you, Mr. Chair. Thanks.
Thank you, Senator Francis. Senator Maurice C. James, you're recognized for your 6 minutes. Well, Sapo, for 6 months.
I think we needed a little levity at this point anyway, so thank you, Mr. Chair. I definitely needed it because I was sitting here just sad, really, about the state of affairs in the Virgin Islands. I do want to start, though, by congratulating the new CEO, Carty-Baptiste, and wishing you the best. But I want to go to Mr. Finch because this border situation, I was sitting here thinking that, and looking at your testimony and about the aging population, and I do want to share a personal story with you. My husband's grandmother, she passed away in 2014, 10 years ago. And she was collecting $603 a month Social Security and $60 in her pension from Woolworths. Most of you who remember Woolworths, that was her pension. And she, at 93, she fell. And so she went into the hospital and they released her, but to his care. So she only had one child. I'd predeceased her, my husband's mother. And my husband and his brother actually hired two ladies, 4 hours each per day, to take care of their grandmother. And, you know, lucky for my husband, he was married to me in the sense that I was working. You know what I'm saying? But if he had a spouse who was not working, because almost his entire income went to taking care of his grandmother during the year. I think they took care of her for a year. So I started to think on the island of St. Croix, what's the average income? I was wondering if you had even gone into that, the average income of persons who are 65 and older, because I'm concerned about the future of the Virgin Islands as we age, and we're all aging, and whether or not who's going to be able to afford this long-term care that you're talking about if we don't have family members like my husband and his brother who decided to spend their money taking care of their grandmother. Not too many people step up and do that. And not too many people have the income. So did you look at the income of our seniors in this community, the average income?
Senator, not directly. However, through my private business, I was involved in doing tenant assessments for a number of the public housing communities on St. Croix that were looking to be rebuilt, Wim Gardens, Red Brick, Walter I.M. Hodge, and others. And I don't have that right at the top of my head, but we looked at the income of everyone living in those communities, and it was extraordinarily low.
Yeah. I was looking at the U.S. income, and the average income was for individuals was $29,000 in the United States of America. So I can only imagine in the Virgin Islands. And the largest part of a person's income is really their Social Security. And right now we know nationally we're all a little anxious, I guess, about what's happening. And I'm going to go from that to say Lutheran Social Services is one of the most wonderful organizations on the island. But I'm a little concerned now, how is the national agenda going to affect the federal funding of organizations like yours, Lutheran Social? Well, I say yours, but you know why I said that, right?
Right.
What's going to happen? Or has anything happened yet?
I believe that they had at least some short-term stoppage of early Head Start funds when, that a few weeks ago was going on. Nobody really knows. All of the Lutheran systems, and this is probably true for every one of the church social service systems, but the National Evangelical Lutheran Church of America has been doing a tremendous amount of writing because there's huge concern about exactly this. The LSS system is one of the largest social service systems in the United States, bar none, and particularly in long-term care.
1 minute.
And I bring that to our attention because I was very I like the fact that the Commissioner of Human Services was very real in saying that when we lose federal funds, we, the Virgin Islands, we do not have the capacity, the financial capacity to take care of ourselves, and we need to admit that. But then we look at nonprofits, and nonprofits also will be affected by whatever the agenda is. So we have to begin to really concern ourselves and plan and be wise and smart with respect to how we're going to handle all these things. And the borders alone, if you take that one issue, it is, to me, clear that there are not too many people who are the children, maybe, of the borders or spouses, I don't know, who have the income to do what my husband and his brother did.
Right.
And we have to be real about that. My time is called. Thank you. Sure, I'd like to hear your response.
So one of the points I wanted to make in my testimony, and it does feel, I mean, almost ridiculous to talk about it, particularly right now. But most of the long-term care in the States is paid for by the Medicaid system. And we've talked about getting our facilities CMS certified, et cetera, which it has to be done before you can put any Medicaid dollars into them. Mm-hmm. However, we have that cap, which none of the states do. And so I was trying to make the point that if we're spending up to our cap, or close to up to our cap, on acute care, healthcare services, then we have no room. And even if we create a number of Medicaid certified, home-based, institutional-based, both systems, it won't behoove us anything because we won't have any additional Medicaid dollars. So the cap needs to be raised, although it looks like this is not quite the atmosphere that's going to happen. But we can hope.
We can hope, and I guess we can lobby and we can hope, right? Thank you, Mr. Finch, and yes, thank you. Thank you, Mr. Chair.
Thank you, Senator. Senator Maurice C. James. Next, the chair will recognize Mr. President, Senator Milton Potter. You're recognized for your 6 minutes.
Thank you very much, Mr. Chair. Good afternoon, colleagues, especially good afternoon to the testifiers who are here today. I want to just start by definitely echoing my congratulations to CEO Darlene Baptiste. Thank you for agreeing to serve as the CEO for the Wang Louis Hospital. Welcome aboard. But my first question is to you, CEO Baptiste. You mentioned that JFL has hired 22 full-time nurses, registered nurses, and currently you don't have any travel nurses. And I just want to congratulate the JFL team for that. And can you elaborate on how you plan to sustain this staffing model on a long-term basis?
Darlene Baptiste, CEO. Thank you so much, Senator, for that question. And I'd like to defer to our Chief Nursing Officer to give you details about our recruitment and retention activities.
Okay.
Good afternoon, Doris Plaskett, Chief Nursing Officer. As provided in the testimony that was effective through the collaborative relationship with the University of the Virgin Islands. How we plan to retain these nurses, first, is investing in the mentorship, the training and the orientation, supporting them transitioning from a novice, inexperienced nurse to a well-trained nurse that can work in many different specialty areas. I think nursing is a special calling, and so a lot of our nurses are very dedicated and invested, especially in serving in their own community. And so one of the key factors in retention, and I think we have addressed one of it, and that is the compensation, but it's not always about money. When I speak with the nursing staff, they'll tell you it's not all about money. It's about wanting to do the best care possible. And so some of the other retention factors I think we discussed today, one, supplies, equipment, and just having the right tool to be able to provide good care, good quality care based on the training that they received.
Excellent. What's the current nurse to patient ratio? And how does that compare with like the national best practice models?
So that's a very loaded question because we staff based on the level of acuity. So all patients' need, as far as the resources, varies. You could have a trauma gunshot wound and they need 2 nurses and a provider and other allied health support. So that is the reason you'll see in hospitals, they cohort different patient population to separate based on the level of acuity and the needs, the patient age, so we don't commingle the very young with other population, especially from a safety, security, infection control standpoint. And so I could go on and on. So the staffing models that we use are based on national standards, best practice that are based on patient acuity and the resource needs.
Okay, how many vacancies, how many nursing vacancies do we have as far as RN nursing vacancies?
We currently have 28 nurses vacancies, And the way we are able to manage with that number of vacancies really correlates to our census. So we're not at the same census every day. The challenge comes when our census peak. We have a lot of individuals waiting to be seen in the ED, and how we compensate is unfortunately right now through overtime.
Gotcha.
Yes, and all hands on deck. It's being told, yes. All meaning that, you know, if you're in an administrative position, then you put your scrubs on and you assist.
All hands on deck. Understood. I respect that. The Emergency Department Involvement Team, and you said that it was reestablished in May 2024 to enhance patient throughput. What measurable improvements have been seen since the reinstatement of that program? And what's patient
1 minute.
throughput?
So there are national standards that we monitor from a quality performance improvement standpoint. Throughput is from the time someone arrived to when they are triaged by a nurse, from the time they're triaged by a nurse to when they are seen by a provider, to when they are either they find a disposition, either they're admitted to an inpatient bed or they're discharged from the emergency room. So there are different best practice and standard threshold, and we use what our statistics to compare to the national levels.
Okay, thank you for that. Ms. Commissiong, CEO Commissiong, I wanted to ask you about FEMA. While FEMA has obligated funds for a new hospital construction, and maybe Mr. Smalls may be able to weigh in on this. You stated that these funds cannot be used for maintaining the existing facilities, so we understand that. What interim solutions do you propose to ensure that the current infrastructure remains operational until the new state-of-the-art facilities, hospital facilities, are completed?
Thank you, Senator Potter. Yes, as you mentioned, we got large awards for the rebuilding of the facilities, but nothing really for this interim maintenance that needs to occur while they're being built. We submitted a capital list that totals $9.7 million of specific line-by-line items that we would want to purchase. We scale that to say if it can all be provided in 1 year, this is what we would buy in year 1, this is what we would buy in year 2. It includes a number of items for the management of the facilities and the environment of care, and it includes a number of items that are pieces of medical equipment. We need investment for that, sir.
Thank you for that. Mr. Chair, if I may just ask one final question, I believe my time may have been gone. I wanted to ask you, both CEOs, what specific policy changes or budget reallocations do you believe the Senate should prioritize to improve your facilities' financial health and service delivery?
Sure, I'm happy to start. Tina Commissiong. I think really we need some immediate debt relief. We need some help with paying some of our AP vendors, especially the local vendors, staffing vendors, supply vendors. We need a lump sum allotment to deal with some AP. We need some forgiveness of the government debt that we have, the government AP. We need investment in digital transformation so that we can start to help ourselves do better with billing and collecting. And we need some investment in facilities maintenance and capital equipment.
Darlene.
Thank you.
Darlene Baptiste, CEO, Juan F. Hospital. Really great question. First of all, for us as a debt relief, our APs, the electronic health record, which Senator Francis alluded to, is being worked on, and the fact of addressing our accounts payable specifically for our locums, especially those who provide services that we have not been able to compensate them for, to entice them to come on and join the team, medical staff team.
Thank you very much for your responses. Thank you very much, Mr. Chair. absolutely health is wealth. That's the real wealth, not silver and gold. So I think that we have a responsibility as elected leaders to do our very best to provide the most optimal health care that we can afford. I mean, it is our responsibility to do so. Thank you very much.
Thank you so kindly, Mr. President. CEO Carty-Baptiste, I wanted to follow up on that statement with the locums, because in your testimony on page, it's line 62, page, I can't say, but line 62, you said outstanding balance to the locums of 827,097. And for the listening audience, the locum is contract physicians, contract medical services, et cetera, et cetera. So you have a balance of 827,097, and so to date you've expended 527.26. So how much does a locum physician cost you on average per year? And also I want to know what's the average salary of an emergency room physician. So average salary of an emergency room physician and how much the locums cost you per year.
Darlene Baptiste, CEO, Juan F. Louis. Our physicians' locum coverage is based on specialties. So depending on the specialty services, the cost differs, which we could provide for you. And of course, that's included of the, not inclusive of the ancillary or the wraparound for housing, transportation.
Emergency room physician.
And the emergency room salary, again, Senator, to keep me very honest, I would like to defer to our HR in reference to the salary compensation for our emergency room doctors.
Ms. Kanagata?
Sorry, good afternoon, Kanagata, JFL. Our emergency room physician, it's based on a range, like I said, with the specialty, the years of experience, et cetera, et cetera. So what I could do, I could give you a compilation with a list with all the different specialties and what their salaries are and the ranges are. That'll be more, I'll give you a more definitive look at that.
Okay, how about the locums? Do you have an exact number what the locums?
No,
you don't?
I don't handle
the
locums.
Well, yes. Okay. Can you send that to the committee? Yes.
Yeah, I will get it from the CMO's office.
Okay. And CEO Tina Commissiong, do you have that information? The average salary for emergency room locum and a salary for emergency room physician, and do you have outstanding AP for locums?
Yes, we have outstanding AP for locum, Senator. We have all the emergency room doctors are part of a union, so they have a salary scale. And we do utilize some locums on direct contracting for the emergency department. Right now, we have a rotation of 2 providers, and we can send you the details of those contract amounts.
Okay, so just to be clear, we're requesting the breakdown of the average salary for the emergency locum physicians, and also we need to know the outstanding balance. Well, we already have that for Wang Louis, but for Roy Schneider, the outstanding balance for the locums, and then also the average salary for emergency room physician. So those 3 things: average salary for the locum emergency room, average salary for emergency room physician, and outstanding balance for the locums. Okay? Yes. Point of information, Senator Herbert Frederick.
Good afternoon again. This is for both CEOs of the hospital. Can you guys send us your legal liability, anticipated legal liability for this fiscal year, so we could know, if you have an idea what it might potentially be, what it was based on prior years, so we could know what to expect?
Yes, we can provide that through the chair.
Thank you.
Thank you, Senator Fredericks. Next, we'll go to Senator Kurt Vele. Senator Vele, you're recognized for your 6 minutes.
Thank you, Mr. Chair. I sat as the chair of the Health, Hospital, and Human Services Committee back in 2015, 2016. And 10 years later, and really not much has changed. Matter of fact, 10 years later, it's worse than it was 10 years ago. So I'm listening to all the testimony, and I'm just here trying to figure out What is the path moving forward, and how are we going to be able to stabilize healthcare in the Virgin Islands? Healthcare dictates everything. Economic development. It leads to a decline in our population when you can't get adequate healthcare. It literally dictates everything. And a lot of individuals are not comfortable with the quality of healthcare that we're receiving in the Virgin Islands. So I think that is my big issue, quality of healthcare. I'm hearing everything, more just do this, do that, and I think what quality of healthcare, being able to generate sufficient funds so that we can improve the system moving forward, and making sure that we have key individuals in positions that understand the role of their position and are going to make those under them do what they're supposed to do, including middle management. Because a lot of times there's just a culture of, it's not my responsibility, and not realizing that they're affecting healthcare in the Virgin Islands. So everyone in healthcare need to change their mindset and really be serious about making sure that the Virgin Islands, on a regular basis, is able to provide quality healthcare. The discussion about the locum no costs about 300,000 plus for the emergency room. So we just need to put a figure on it. I'm afraid to put a figure on it. It's an emergency room doctor. They specialize. They deserve that type of money. Just say the figure is 300,000 plus. Now, we passed a bill before that allowed you to hire specialists, hematologists, etc., outside of the union. And the bill also said that the hospital would be responsible for the billing because you're paying them what they're worth. So the hospital could bill for those services. Are you aware of that?
Darlene Baptiste, CEO, Juan F. Yes, that information was shared with me with our legal counsel. Okay. So that's why we're going through the review of all the agreements.
Now, we spoke about the locums, and locums sometimes come for a month, they sometimes come for 2 months, correct? Are we capturing the costs in the ER for the services provided by those locums? If they come for 60 days, do we have a system in place that clearly outlines that every single patient that they saw, they have generated a chart and we're able to bill for the patient?
Specifically for Juan F. Louis, we're actually going through that report as we speak with all our locums to ensure
let me ask you, CFO. She getting the money and everything else. Are they billing? Can we?
It's currently not up to date. That's why
it's currently not being.
Rosalie Javois. It's currently not up to date. That's why the C.
No, okay, that's the question. Yeah. And let me, Ms. Commissiong, all the locums, when they leave, when the contract expire, are you able to capture every billable expense for services that they provided in the ER?
Senator, every billable expense, no, we should be capturing more, but we do require them to complete their documentation before they leave. We try to tie that to them getting their check for payment for services. We can't pay them if we're not billing for the care that they provide. So we've tried to really tighten that up and have them complete their open records before they leave Ireland. Of course, there are a couple that we miss here and there. And because
we shouldn't, thank you, because I can't really have long answers. We shouldn't miss none.
But you're going to miss it right now because they're writing on paper, Senator. When we have the better system that you go into the room with your phone, it records the conversation. It automatically documents everything that's done. It suggests the coding that should be dropped. It drops it onto a bill and you walk out the room. You've captured a lot more of what happens with the patient. Right now, you're depending on the doc to go in the room, do it, come out, remember what they did, mark it down on a piece of paper, then the unit secretary enter that into the system, maybe catching everything, maybe not catching everything. Do they do every single patient before they leave? No. We have opportunities.
And I hear all of that, but that's not really the concern of the legislature. No. You need to come up with a mechanism to make sure that happens. That's not our concern that you're saying, oh, they have to do that. Do your OmniCells work? You have OmniCells over there?
OmniCells work.
Is that capturing costs?
It is. That's a great use of technology.
Excuse me 1 second. CEO Tina, I'm being told you're talking a little too fast. If you could slow down with the translation. Yes, thank you.
We could reach to the point of any system. You have to have buy-in from the staff to utilize the system. Because we have had OmniCell and all different type of stuff, and individuals don't use it. They refuse to utilize it for what they're supposed to. And that's why I continue to speak about the culture of the hospital. Money isn't going to save the hospital, or a change of practices is what's going to change the hospital. We could build a whole new shiny building, and if we go in that building with these same practices, nothing is going to improve. We cannot continue to sit here and hear excuses when this body have to bail out money on a regular basis to the hospital as to why you can't capture 100% of the charges. Whether or not you have to hire scribes for the ER, individuals that's going to follow the doctor around and capture everything, but we got to capture it. I'm sure a scribe of students who are majoring in biology, et cetera, following somebody around, it will pay for itself. The cost of hiring those individuals will pay for itself. But there's always an excuse. I've heard it for 10 years as to why we can't function, why people can work remotely,
Senator,
why
for
we're
10
not
years,
doing what we're supposed to do. If we spend, and we're going to try our best, not now, Ms. Commissiong, you're going to have your chance. We're going to try our best to make sure that we could provide the hospitals with that system. That's $10 million. So when the money is spent, we don't want to hear an excuse 2 years from now that this wasn't working, or like the system, the waxilla units come online, they break down 1 month after, buy VI come online, the component to print checks ain't working. We want Meditech got issues, this ain't come online. We want to make sure when we spend these monies that that contract is going to be so tight and so closely monitored and executed that when they're complete, everything is working online and everybody understands their responsibility that they must utilize the system. That's what we really need to move towards. Now, and one of my last questions, you said you owe GRS, and it's brought to my attention that you owe employee contribution also?
We have withholdings for employee and employer contributions that are owed. We have reserves for employee contributions.
Okay, so that's, hold on. Well, what's the cost, the total cost?
The bulk of the money that we owe to GRS, almost $8 million, is on the employer side. There is 2 months, maybe 2.5 months of employee withholdings that need to be remitted. But the vast majority is the employer portion.
We need to deal with the employee contribution right now. You can't take money out of an employee check and it's not going towards the contribution. And this body bailed out both hospitals a couple years ago, maybe 5 years ago, in terms of the outstanding employer contribution. We paid all. And by God, 4 or 5 years after, we back up to $6 million. We paid all, every single employer contribution for Wang Louis and Schneider. When I was the chair and my colleagues were there, we paid it. And 5 years after, we back to step one. Vendor payment, how much? 19? 19 to Wang Louis, 39, 38. Unheard of. How are we cutting costs? How are we restructuring? How large is our leadership team? What's the budget for leadership? Millions? What are we cutting? What departments are actually a duplication of a next and could cut back? You know, all of that we got to do, you got to reach, we have 500 plus employees for 50 beds. Correct?
Yes, sir. We have 555 employees.
And how much employees on St. Thomas, Ms. CEO Commissiong?
About the same, and we've been averaging about 80 plus, 85 plus patients in-house.
Okay, so 500 and change for 50-something bed and 80 beds. We got to revisit the model. Look at the comparable hospital in the mainland and check and see how much employees they have. We have so much levels of leadership. Quality nurses that are just in, 1 million of them in leadership position. It just can't work. I don't have no bunch of questions. I got questions, but it don't make no sense asking them. I just want a change. And I'm literally just tired and I'm sad to be here. Because we're driving people away from this island by the lack of health care facing the people of the Virgin Islands. Thank you so much, Mr. Chair.
Thank you, Senator Vele. Senator Alma Francis Heiliger, you're recognized for your 6 minutes.
Good day to my colleagues. Good day to the people of the territory, to the testifiers, to the staff. I first wanted to hone in a little bit on the initial testimony from Miss Commissiong. You spoke a little bit in your testimony about cyber attacks. what exactly happened around that? Because I know that is very sensitive when it's dealing with people's data, et cetera. What exactly happened around that? How long did it take you guys to recover from that? And what type of effort is being made or has been made? I heard from a previous testimony, they're talking about the IT working together a little bit closely. How are you guys dealing with that, or how did you handle it?
Yeah, so thank you, Senator Heiliger, for the question. We were affected by 2 cyber attacks within calendar year 24. It was due to vulnerabilities within the system. Since then, when we had the attack, we worked very closely with the federal authorities and the local authorities to report the attack. Essentially, the bad actors were in our system, locked us out of our system. We had to rebuild things from scratch and strengthen the system. And we've since done that, and we're back to functioning, doing data, and charting within our electronic record system.
And you think you have a much more sound system? And were they able, after they locked you guys out, were they also able to get information, or it was just a direct lockout with whatever viruses or whatever they put on the system?
We just saw that we were directly locked out. We don't have any evidence of information being removed from the system.
Okay. Well, I hope that whatever you guys have now is a much greater improvement, because protecting people's health information is very critical. I wanted to ask a little bit more about, between the 2 hospitals, dealing with these vendor payments and how much they're owed. When I was in St. Croix last month, I did have, or it might have been earlier this month, I did have a conversation in regards to the $19 million that's owed. And I also heard through testimony, it's about $38 million here in the District of St. Thomas, St. John. Between the 2 CEOs, how are you guys thinking that, first of all, how did we get to this level? And what do you think we need to do, whether it's as a government or whether as a whole, how the hospital function? Because we heard the conversation earlier about potentially merging, and one of the aspects would be cost savings. How do you think, even if we don't go with the whole merger, let's say I'm not discussing that, what are your thoughts about the hospitals functioning together for purchasing purposes? Is that something y'all could see that we could do to help cut costs, even if we want to discuss the merger at a larger scale, and continue that discussion? What are your thoughts on purchasing collectively?
Sure. So I'm happy to start. Tina Commissiong from Schneider Regional. We have opportunities to work together. I had a very good relationship working with Doug Cook and Ms. Hazel Philbert when she was in the role, and I look forward to continuing that with Ms. Baptiste. We do have opportunities to buy things together and approach some procurements together and try to get some economies of scale. We already benefit from economies of scale right now at Schneider Regional because we participate in a GPO with 50 other hospitals. So we're already getting some advantages of purchasing at scale, and that has not come forward in the discussion so far today. But could we buy things with JFL? So we need a new CBC machine. Let's buy the same machine so that when we need reagents or somebody's out, we can share with each other. You bring a tech in to service the machine, they can come and service both, go island to island and do both and then leave. There are opportunities for us to work together some more in aligning our purchasing. And I think we talk about the AP and why are we at where we're at with the AP, and we talk about we're back at square one, and because we haven't addressed the root of the problem, which is we're not funding the hospitals for the uncompensated care that's delivered. So every day, very talented people are making difficult decisions about who to pay and who not to pay to keep clinical care going. And that's why we're back at square one. We don't want to be back at square one. We talk about the number of staff we have. We have that number of staff, but we're talking about adding scribes. We don't need to add scribes. That's adding to that number. You say, well, why does a stateside hospital have less staff? We're talking about adding scribes? No, you add the technology that you need that help you function better today. You need to do the digital transformation that needs to happen to function better. Then you get lean, right? So we've done a lot to get lean, especially at the executive level, but we haven't fixed the root of the problem.
Okay, thank you for your response. Carty-Baptiste?
1 minute.
Yes, specifically for Wang Louis, the sentiments are shared. Shared. The cost of care has not kept up with the uncompensated care. We too are part of the GPO for Premier under Baptiste. So it comes back to us looking at our hardwiring our systems and processes, specifically on our financial pieces. And in my testimony, I did outline some tangible steps that we have to take as an organization to be better stewards of the funding that we received.
Well, what I will say is that as a representative of the people, I'll give you an example. I had one constituent contact me from St. Croix sharing that they had some issues where their family member was in the hospital and they couldn't even get water. They had to leave the hospital to go get water for them to drink. I had a constituent here in the District of St. Thomas, St. John that spoke about their relative in the hospital, and they had to leave the hospital and go to the across, I think, the Kmart to buy diapers for their adult family member. So when you're hearing these type of things from the residents and they're scratching their heads, and then we have you guys here, and then we're hearing these astronomical numbers. But understand me, I fully understand what you're saying about the uncompensated care. But what do you do in regards to dealing with priority? Because seeing that you have these large numbers that have to be paid off, how do you deal with priority and trying to keep up with what you need to give the best care that you can within the confines of the funding that you do have available?
Darlene Baptiste, CEO, Juan Louis. For us, we meet at 8:30 every morning for our e-huddles and actually go through some of those critical areas to see where preemptively deal with what's needed from the night before and what's needed for the day. Each one of the department heads and the executive are on that, and we report out what's the priorities. It's literally drinking water from a fire hose every day. We're to that position right now. And of course, the steps that are needed are drastic, but we're making, for one, we were making those efforts right now. So we really prioritize based on what's the census in the house, driven by addressing to show that we have safety and quality services.
Okay.
And this is I'm from Schneider. Very similar process. We have a daily safety huddle every morning. We hear about the real pressing needs from our department heads. They also, by every Wednesday, send us a list of their most pressing vendors for things that they need to keep services going. We meet every Friday to talk about the vendor priority list and figure out who's going to get paid and what we need to fund. And it's a balance of needing to take care of the current priorities as well as needing to make good on our agreements with vendors to pay down what we owe them from an AP standpoint. And some of them have gotten to the point where they want prepays. They want to be assured that you're going to be paid on the balance in order to keep providing supplies and services. So it really is a lot of juggling, and the whole team is leaning in on it. And it's a day-to-day figuring out those priorities to try to make it for people.
Well, I want to thank you guys for being direct with me, because I'm an individual knows that we can't resolve things if we don't know what the issues are. So if we know these are the things that we have to do as a government, I do agree that we have to focus on figuring out a little bit more with the uncompensated care, as well as making sure that we do have that happy balance of providing the best quality service to our constituents. I think I heard time, and I don't want to drag this out. So thank you, Mr. Chair, for the time.
Thank you, Senator Alma Francis Heiliger, for those good questions. So, colleagues, as we conclude today's proceeding, I'd like to extend sincere gratitude to all.
Point of information, Mr.
Oh, yes. Yeah, go ahead. Proceed, Senator Lewis.
You know you're going to conclude, but I'd also like to ask Ms. Commissiong real quick. Earlier in her testimony, page 4, she talked about our insurance and having a conversation with the group health board. No, I was going to ask her if she started to have a conversation yet with the group health board and so forth to see what kind of benefits or arrangements could be made so, you know, the hospital could be more beneficial from the return from the insurance.
Yes, Senator Lewis, thanks for the question. I have been very engaged with the Group Health Insurance Board. I attend their monthly meetings. I have lobbied for some of the changes. I have the support of some of the trustees in pushing for that change and working with the insurers on our behalf. We have also done direct outreach to United Healthcare as well as to Cigna to try to sit with them and renegotiate those plans. And so those conversations have started, and we look forward to your support and advocacy as a body to help to make those changes happen.
And real quick, as it pertains to the borders, do you think about, have you ever thought about maybe, I wouldn't say create a whole wing, but some additional rooms on the other side? I don't know what impediments I may have or drain I might put on the hospital, but there was ever a thought or anything?
Yes, Senator Lewis, great question. So we actually have done that. We've created a non-acute care unit, which we use one wing of medical for the acute medical patients, and we use the other wing for the non-acute border patients. We are looking to see what designations and how we can get reimbursement for some of the care we're giving there. Can we get certified as a skilled nursing facility for those beds? Can we do swing beds? How do we get ourselves to fit in one of those designations where we can try to hopefully get some level of reimbursement for the care that we're giving to those patients, since there's not been good movement on getting them out of our facility.
Thank you very much for your responses. Thank you, Mr. Chairman. And everybody have a great evening.
Yes, thank you, Senator Lewis. Senator Maurice James, point of information, you're recognized.
Thank you, Mr. Chair. Actually, I just wanted to express my condolences to Mr. Edgar Baker Phillips on the loss of his sister, and let him know that we heard him. Thank you.
Thank you, Senator James. Senator Novell Francis, you're recognized for your point of information.
Thank you very much, Mr. Chair. Madam CEO, Commissiong, do you have a quote or an invoice for the EMR system that you could forward to the chair for circulation? I'd like to try to get it as soon as possible.
Yes, sir. I'd be happy to submit that to you. We have been investigating. We currently both use Meditech, so we have good information around moving to the Meditech Mass version, which is the higher version of Expanse that's in the cloud. We also are looking at 2 alternative systems. We'll be happy to provide that information to you through the chair.
Thank you very much. Thank you, Mr. Chair.
Thank you, Senator Francis. Senator Lorenzo Frederick, you're recognized for your point of information.
Thank you very much, Mr. Chair. This is for Mr. Darrell Smalls, Director Smalls. Real quick, is there a contingency plan in place given the current federal environment for possibly defunding some of the funds that we have already awarded to us for the Juan F. Louis Hospital? What do we do if we get the worst news? Is there a plan in place for that?
Great question, Senator. I believe last week the Director Williams of the ODR was here testifying. We're all hopeful that would not occur. Do we have a backup plan? I would say we don't. It would be a tremendous hit and loss to our healthcare system. So I would just say we gotta hope and pray that our funds that have been obligated to date remain untouched.
Okay, the reason I'm asking is the current modular unit is seeing its useful life expired, and so we don't have a backup. We can't use the existing building, and so something else has to give in case something happens. We just can't be exposed like that.
I concur, Senator, and I will speak on behalf, or I would say assist both CEOs in their concerns that they raise. Following a disaster, FEMA provides you funding for a temporary facility. We have temporary facilities on all 3 islands. That was a one-time shot in the arm. It is up to us as a government to be able to maintain those facilities until the new facilities come online. So I share the concerns by each of the CEOs as a former facility person myself. Ongoing maintenance is essential. For the interim facility on the JFL North. Yes, it is approaching its life expectancy. However, with continued ongoing maintenance that needs additional funding, we could try to prolong the usefulness of that facility.
Thank you very much.
Thank you, Senator Frederick. So, colleagues, we've heard today several issues, staffing shortages, emergency room wait times issues, critical healthcare services. We've got an update on our medical facilities, including the Herbert Grigg Nursing Home, the Queen Louise Home, and both hospitals. And we need to continue our oversight on this important healthcare and hospital crisis. In my personal opinion, I think that we are in a hospital state of emergency. I look forward to continued collaboration and progress on these issues. However, we've also learned that some of these same issues were addressed 10 years ago, and we're right back where we were. So I'd like to say thank you to everyone. As we conclude today's proceedings, I'd like to extend my sincere gratitude to all of my colleagues, the testifiers, the legislature, central staff, and my staff for the hard work and dedication to putting this meeting together. I'll allow at this time a 30-second closing for the testifiers, and we'll start with CEO Tina Commissiong, and then we'll go to the St. Thomas staff of Darrell Smalls, and then Mr. Phillips, and then we'll come to St. Thomas and we'll go to Darlene Carty, and to my left to Chris Finch. Yes,
Thank you, Senator Baker. In closing, I just say, Schneider Regional, we got a great hospital, we got a well thought out strategic plan, and we got a bright future with the right. We have a great team of excellent providers. We have high quality scores, and we're fully accredited. But we operate in a difficult environment, and even though some things were addressed years ago, we haven't made the structural changes that need to happen, and we haven't invested at the level we need to cover the care that's being provided. We have insufficient primary care in our environment. That means people are coming to the hospital sicker. We have an older population, and we have an insufficient number of, placement beds for them, nursing home beds, which has led to the border situation. 75% of the people that we treat are Medicare, Medicaid, self-pay, no pay. And so it's very difficult to operate in that environment. That's why we have only a couple of days cash on hand. We need to really fix the problem. We say we've addressed certain things years ago, but if you're not covering the uncompensated care, you're not giving anything for capital investment, you're not doing anything to maintain the buildings, it's going to be this constantly, and it's going to keep coming back up. So we have to figure some of these things out at a structural level. I definitely appreciate the conversation today, the opportunity to testify. We are committed at Schneider Regional to doing our part in improving our financial position and expanding our service lines. I can tell you if we make that investment in the EMR, we will make that adoption happen. Our providers will use it, just like they're using the OmniCells now. We're going to work to help ourselves, being aggressive in billing and collections. And we're just looking for that appropriate financial support from the government. Thank you for the opportunity to present. I want to thank the Honorable Governor Bryan and his administration, to include OMB and the Director of OMB, the Commissioner of Finance, as well as our territorial governing board and district boards for their support over the years for the healthcare system, and the leadership and staff of Schneider Regional, who really give of themselves every day to take care of our community. We thank you very much for all that you do for each of us. And like I say, any of us could need our hospital any day. You never know when you're going to have a heart attack, or your parent has a heart attack, your child has a trauma, gets in a car accident. It could happen to any of us at any time. It behooves all of us to continue to invest in our hospitals, support our hospitals. Everyone needs a healthy community, needs a healthy healthcare system. And so we look forward to being part of that and working with all of you. Thanks for the opportunity to discuss some of our issues today.
Thank you, CEO Tina Commissiong. Darrell Smalls.
Yes, good afternoon, Senator. I just want to say thank you for this opportunity to present to the public the hard work that the THRT has been doing on behalf of our territorial hospital facilities, and we look forward to continuing doing what we do best, and that is preparing for new state-of-the-art facility, maximizing the funding that's available, again, working with the board, working with the hospital leadership, working with our architects and engineers who are designing our facilities, working with the with ODR. At the end of the day, It's one territory, and we want to make sure that we complete these tasks with the available funding on time and on budget. Thank you.
Thank you, CEO Smalls. Mr. Edgar Phillips.
Thank you, Senator, for giving me the opportunity to come and share my story here with you today and the body. I'd like to also thank Senator Jim and Blyden for offering up their condolences to me and the family. But I was very surprised that much more of the senators didn't even ask me any question relative to the situation that I presented here today. I think the situation that I presented not only affects me, it affects so many of our residents here in the territory, and I believe that this situation needs to be addressed. Again, thank you so much for giving me the opportunity to come here and share our concerns with your body. Thank you.
Through the chair, Senator Fonseca, may I also offer our condolences on behalf of Schneider? And I wanted to give a little feedback because I didn't get to touch it in any of the line of questioning, that we have made changes responsive to this situation. We have now put in a policy where we would notify if we tried to reach the next of kin, which we did in this situation and were unsuccessful. We would also try to through Human Services and through VIPD. And so we have made some changes, and we're very sorry for what happened, and we extend our condolences for the loss of your sister. So I just wanted to add that. I'm sorry we didn't get to touch on it during the discussion.
Thank you.
Thank you so much for your concern.
Yes, thank you, Mr. Ed Phillips. Next, we'll go to Christopher Finch.
Thank you. It was good to have this conversation today, and a lot of information came out. So I won't recap any of that, but I just want to mention that at times, at odd times, it could be the middle of the night, very early in the morning, a holiday, a storm threatening. It just occurs to me that both our hospitals are staffed with people who are there in case we need them, and I just want to thank them.
Thank you, Mr. Finch. CEO Darlene Carty-Baptiste.
Yes, thank you so much to all the senators for this opportunity to lay the roadmap that we have trying to establish at JFL. We made the commitment to have a positive impact and proven that we can be the beacon of the island of St. Croix, and working in partnerships with our sister hospital to handle the overwhelming tasks that is before us. We don't take this opportunity lightly. I'd like to thank the executive staff and the supporting administrative staff, the board, for the confidence that they put in us. We can be result-driven, not just hoping, but proven that we can do better in the island of St. Croix. And just thank you. Thank you to the listening public as well.
Thank you, CEO Darlene Carty-Baptiste. And our next committee hearing is scheduled for March 25th. And we would like to ask for the blessings of our most holy Father, Pope Francis. And may God bless all of you, and may God bless the Virgin Islands. The Committee on Health, Hospitals, and Human Services is now adjourned.
It's night already.